Section 27 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For further information or to volunteer, please visit librivox.org. Anatomy of the Human Body, Part 1, by Henry Gray. The Lacrimal Bone, Os Lacrimale. The lacrimal bone, the smallest and most fragile bone of the face, is situated at the front part of the medial wall of the orbit. It has two surfaces and four borders. Surfaces. The lateral or orbital surface is divided by a vertical ridge, the posterior lacrimal crest, into two parts. In front of this crest is a longitudinal groove, the lacrimal sulcus, sulcus lacrimalis, the inner margin of which unites with the frontal process of the maxilla, and the lacrimal fossa is thus completed. The upper part of this fossa lodges the lacrimal sac, the lower part the naso-lacrimal duct. The portion behind the crest is smooth, and forms part of the medial wall of the orbit. The crest, with a part of the orbital surface immediately behind it, gives origin to the lacrimal part of the orbicularis oculi, and ends below in a small hook-like projection, the lacrimal hamulus, which articulates with the lacrimal tubercle of the maxilla, and completes the upper orifice of the lacrimal canal. It sometimes exists as a separate piece, and is then called the lesser lacrimal bone. The medial or nasal surface presents a longitudinal furrow corresponding to the crest on the lateral surface. The area in front of this furrow forms part of the middle meatus of the nose; that behind it articulates with the ethmoid, and completes some of the anterior ethmoidal cells. Borders. Of the four borders, the anterior articulates with the frontal process of the maxilla, the posterior with the lamina papyracea of the ethmoid, the superior with the frontal bone. The inferior is divided by the lower edge of the posterior lacrimal crest into two parts. The posterior part articulates with the orbital plate of the maxilla. The anterior is prolonged downwards as the descending process, which articulates with the lacrimal process of the inferior nasal concha, and assists in forming the canal for the naso-lacrimal duct. Ossification. The lacrimal is ossified from a single centre, which appears about the 12th week in the membrane covering the cartilaginous nasal capsule. Articulations. The lacrimal articulates with four bones, two of the cranium, the frontal and ethmoid, and two of the face, the maxilla and the inferior nasal concha. The zygomatic bone, os zygomaticum, malar bone. The zygomatic bone is small and quadrangular, and is situated at the upper and lateral part of the face. It forms the prominence of the cheek, part of the lateral wall and floor of the orbit, and parts of the temporal and infratemporal fossae. It presents a malar and a temporal surface. Four processes, the frontosphenoidal, orbital, maxillary, and temporal, and four borders. Surfaces. The malar surface is convex and perforated near its centre by a small aperture, the zygomaticofacial foramen, for the passage of the zygomaticofacial nerve and vessels. Below this foramen is a slight elevation, which gives origin to the zygomaticus. The temporal surface, directed backward and medialward, is concave, presenting medially a rough triangular area for articulation with the maxilla, and laterally a smooth concave surface, the upper part of which forms the anterior boundary of the temporal fossa, the lower a part of the infratemporal fossa. Near the centre of this surface is the zygomaticotemporal foramen, for the transmission of the zygomaticotemporal nerve. Processes. The frontosphenoidal process is thick and serrated, and articulates with the zygomatic process of the frontal bone. On its orbital surface, just within the orbital margin and about 11 mm below the zygomatico-frontal suture, is a tubercle of varying size and form, but present in 95% of skulls. The orbital process is a thick, strong plate, projecting backward and medialward from the orbital margin. Its anteromedial surface forms, by its junction with the orbital surface of the maxilla and with the great wing of the sphenoid, part of the floor and lateral wall of the orbit. On it are seen the orifices of two canals, the zygomatico-orbital foramina. One of these canals opens into the temporal fossa, the other on the malar surface of the bone. The former transmits the zygomatico-temporal, the latter the zygomatico-facial nerve. Its posterolateral surface, smooth and convex, forms part of the temporal and infratemporal fossae. Its anterior margin, smooth and rounded, is part of the circumference of the orbit. Its superior margin, rough and directed horizontally, articulates with the frontal bone behind the zygomatic process. Its posterior margin is serrated for articulation with the great wing of the sphenoid and the orbital surface of the maxilla. At the angle of junction of the sphenoidal and maxillary portions, a short, concave, non-articular part is generally seen. This forms the anterior boundary of the inferior orbital fissure. Occasionally this non-articular part is absent, the fissure then being completed by the junction of the maxilla and sphenoid, or by the interposition of a small sutural bone in the angular interval between them. The maxillary process presents a rough triangular surface which articulates with the maxilla. The temporal process, long, narrow, and serrated, articulates with the zygomatic process of the temporal. Borders. The antero-superior or orbital border is smooth, concave, and forms a considerable part of the circumference of the orbit. The antero-inferior or maxillary border is rough, and bevelled at the expense of its inner table, to articulate with the maxilla. Near the orbital margin it gives origin to the quadratus labii superioris. The postero-superior or temporal border, curved like an italic letter F, is continuous above with the commencement of the temporal line, and below with the upper border of the zygomatic arch. The temporal fascia is attached to it. The postero-inferior or zygomatic border affords attachment by its rough edge to the masseter. Ossification. The zygomatic bone is generally described as ossifying from three centres, one for the malar and two for the orbital portion. These appear about the 8th week, and fuse about the 5th month of foetal life. Mal describes it as being ossified from one centre which appears just beneath and to the lateral side of the orbit. After birth the bone is sometimes divided by a horizontal suture into an upper larger and a lower smaller division. In some quadrumana the zygomatic bone consists of two parts, an orbital and a malar. Articulations. The zygomatic articulates with four bones, the frontal, sphenoidal, temporal, and maxilla. End of section 27. Section 28 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For further information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 1, by Henry Gray. The palatine bone. Os palatinum. Palate bone. The palatine bone is situated at the back part of the nasal cavity between the maxilla and the pterygoid process of the sphenoid. it contributes to the walls of three cavities, the floor and lateral wall of the nasal cavity, the roof of the mouth, and the floor of the orbit. It enters into the formation of two fossae, the pterygopalatine and the pterygoid fossae, and one fissure, the inferior orbital fissure. The palatine bone somewhat resembles the letter L, and consists of a horizontal and a vertical part, and three outstanding processes, viz. the pyramidal process, which is directed backward and lateralward from the junction of the two parts, and the orbital and sphenoidal processes, which surmount the vertical part, and are separated by a deep notch, the sphenopalatine notch. The horizontal part, pars horizontalis, horizontal plate. The horizontal part is quadrilateral, and has two surfaces and four borders. Surfaces. The superior surface, concave from side to side, forms the back part of the floor of the nasal cavity. The inferior surface, slightly concave and rough, forms, with the corresponding surface of the opposite bone, the posterior fourth of the hard palate. Near its posterior margin may be seen a more or less marked transverse ridge for the attachment of part of the aponeurosis of the tensor veli palatini. Borders. The anterior border is serrated and articulates with the palatine process of the maxilla. The posterior border is concave, free, and serves for the attachment of the soft palate. Its medial end is sharp and pointed, and when united with that of the opposite bone forms a projecting process, the posterior nasal spine, for the attachment of the musculus uvulae. The lateral border is united with the lower margin of the perpendicular part, and is grooved by the lower end of the pterygopalatine canal. The medial border, the thickest, is serrated for articulation with its fellow of the opposite side. Its superior edge is raised into a ridge, which, united with the ridge of the opposite bone, forms the nasal crest for articulation with the posterior part of the lower edge of the voma. The vertical part, pars perpendicularis, perpendicular plate. The vertical part is thin, of an oblong form, and presents two surfaces and four borders. Surfaces. The nasal surface exhibits at its lower part a broad, shallow depression, which forms part of the inferior meatus of the nose. Immediately above this is a well marked horizontal ridge, the conchal crest, for articulation with the inferior nasal concha. Still higher is a second broad shallow depression, which forms part of the middle meatus, and is limited above by a horizontal crest less prominent than the inferior, the ethmoidal crest, for articulation with the middle nasal concha. Above the ethmoidal crest is a narrow horizontal groove, which forms part of the superior meatus. The maxillary surface is rough and irregular throughout the greater part of its extent, for articulation with the nasal surface of the maxilla. Its upper and back part is smooth where it enters into the formation of the pterygopalatine fossa. It is also smooth in front, where it forms the posterior part of the medial wall of the maxillary sinus. On the posterior part of this surface is a deep vertical groove, converted into the pterygopalatine canal by articulation with the maxilla. This canal transmits the descending palatine vessels and the anterior palatine nerve. Borders. The anterior border is thin and irregular. Opposite the conchal crest is a pointed projecting lamina, the maxillary process, which is directed forward and closes in the lower and back part of the opening of the maxillary sinus. The posterior border presents a deep groove, the edges of which are serrated for articulation with the medial pterygoid plate of the sphenoid. This border is continuous above with the sphenoidal process. Below it expands into the pyramidal process. The superior border supports the orbital process in front and the sphenoidal process behind. These processes are separated by the sphenopalatine notch, which is converted into the sphenopalatine foramen by the under surface of the body of the sphenoid. In the articulated skull this foramen leads from the pterygopalatine fossa into the posterior part of the superior meatus of the nose, and transmits the sphenopalatine vessels and the superior nasal and nasopalatine nerves. The inferior border is fused with the lateral edge of the horizontal part, and immediately in front of the pyramidal process is grooved by the lower end of the pterygopalatine canal. The pyramidal process or tuberosity. Processus pyramidalis. The pyramidal process projects backward and lateralward from the junction of the horizontal and vertical parts, and is received into the angular interval between the lower extremities of the pterygoid plates. On its posterior surface is a smooth grooved triangular area, limited on either side by a rough articular furrow. The furrows articulate with the pterygoid plates, while the grooved intermediate area completes the lower part of the pterygoid fossa, and gives origin to a few fibres of the pterygoideus internus. The anterior part of the lateral surface is rough for articulation with the tuberosity of the maxilla. Its posterior part consists of a smooth triangular area, which appears in the articulated skull between the tuberosity of the maxilla and the lower part of the lateral pterygoid plate, and completes the lower part of the infratemporal fossa. On the base of the pyramidal process, close to its union with the horizontal part, are the lesser palatine foramina, for the transmission of the posterior and middle palatine nerves. The orbital process. Processus orbitalis. The orbital process is placed on a higher level than the sphenoidal, and is directed upward and lateralward from the front of the vertical part, to which it is connected by a constricted neck. It presents 5 surfaces, which enclose an air cell. Of these surfaces 3 are articular and 2 non-articular. The articular surfaces are 1. The anterior or maxillary, directed forward, lateralward, and downward, of an oblong form, and rough for articulation with the maxilla. 2. The posterior or sphenoidal, directed backward, upward, and medialward. It presents the opening of the air cell, which usually communicates with the sphenoidal sinus. The margins of the opening are serrated for articulation with the sphenoidal concha. 3. The medial or ethmoidal, directed forward, articulates with the labyrinth of the ethmoid. In some cases the air cell opens on this surface of the bone, and then communicates with the posterior ethmoidal cells. More rarely it opens on both surfaces, and then communicates with the posterior ethmoidal cells and the sphenoidal sinus. The non-articular surfaces are 1. The superior or orbital, directed upward and lateralward. It is triangular in shape, and forms the back part of the floor of the orbit, and 2. The lateral, of an oblong form, directed toward the pterygopalatine fossa. It is separated from the orbital surface by a rounded border, which enters into the formation of the inferior orbital fissure. The sphenoidal process. Processus sphenoidalis. The sphenoidal process is a thin compressed plate, much smaller than the orbital, and directed upward and medialward. It presents 3 surfaces and 2 borders. The superior surface articulates with the root of the pterygoid process and the under surface of the sphenoidal concha, its medial border reaching as far as the ala of the voma. it presents a groove which contributes to the formation of the pharyngeal canal. The medial surface is concave and forms part of the lateral wall of the nasal cavity. The lateral surface is divided into an articular and a non-articular portion. The former is rough, for articulation with the medial pterygoid plate; the latter is smooth, and forms part of the pterygopalatine fossa. The anterior border forms the posterior boundary of the sphenopalatine notch. The posterior border, serrated at the expense of the outer table, articulates with the medial pterygoid plate. The orbital and sphenoidal processes are separated from one another by the sphenopalatine notch. Sometimes the two processes are united above and form between them a complete foramen, or the notch may be crossed by one or more spicules of bone, giving rise to two or more foramina. Ossification. The palatine bone is ossified in membrane from a single centre, which makes its appearance about the 6th or 8th week of foetal life at the angle of junction of the two parts of the bone. From this point ossification spreads medialward to the horizontal part, downward into the pyramidal process, and upward into the vertical part. Some authorities describe the bone as ossifying from 4 centres, one for the pyramidal process and portion of the vertical part behind the pterygopalatine groove, a second for the rest of the vertical and the horizontal parts, a third for the orbital, and a fourth for the sphenoidal process. At the time of birth the height of the vertical part is about equal to the transverse width of the horizontal part, whereas in the adult the former measures about twice as much as the latter. Articulations. The palatine articulates with 6 bones: the sphenoid, ethmoid, maxilla, inferior nasal concha, voma, and opposite palatine. End of section 28.
Section 29 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Anatomy of the Human Body, Part 1, by Henry Gray. Section 29. The inferior nasal concha, the voma. Concha nasalis inferior, inferior turbinated bone. The inferior nasal concha extends horizontally along the lateral wall of the nasal cavity and consists of a lamina of spongy bone curled upon itself like a scroll. It has 2 surfaces, 2 borders, and 2 extremities. The medial surface is convex, perforated by numerous apertures and traversed by longitudinal grooves for the lodgment of vessels. The lateral surface is concave and forms part of the inferior meatus. Its upper border is thin, irregular, and connected to various bones along the lateral wall of the nasal cavity. It may be divided into 3 portions. Of these, the anterior articulates with the conchal crest of the maxilla, the posterior with the conchal crest of the palatine. The middle portion represents 3 well-marked processes, which vary much in their size and form. Of these, the anterior or lacrimal process is small and pointed, and is situated at the junction of the anterior fourth with the posterior 3/4 of the bone. It articulates by its apex with the descending process of the lacrimal bone, and by its margins with the groove on the back of the frontal processes of the maxilla, and thus assists in forming the canal for the nasolacrimal duct. Behind this process a broad, thin plate, the ethmoidal process, ascends to join the uncinate process of the ethmoid. From its lower border a thin lamina, the maxillary process, curves downward and lateralward. It articulates with the maxilla and forms a part of the medial wall of the maxillary sinus. The inferior border is free, thick, and cellular in structure, more especially in the middle of the bone. Both extremities are more or less pointed, the posterior being the more tapering. Ossification. The inferior nasal concha is ossified from a single centre, which appears about in the 5th month of fetal life in the lateral wall of the cartilaginous nasal capsule. Articulations. The inferior nasal concha articulates with 4 bones, the ethmoid, maxillar, lacrimal, and palatine. 5b7. The voma. The voma is situated in the median plane, but its anterior portion is frequently bent to one or other side. It is thin, somewhat quadrilateral in shape, and forms the hinder and lower parts of the nasal septum. It has 2 surfaces and 4 borders. The surfaces are marked by small furrows for blood vessels, and on each is the nasopalatine groove, which runs obliquely downward and forward, and lodges the nasopalatine nerve and vessels. The superior border, the thickest, presents a deep furrow, bounded on either side by a horizontal projecting ala of bone. The furrow receives the rostrum of the sphenoid, while the margins of the alae articulate with the vaginal process of the medial pterygoid plates of the sphenoid behind, and with the sphenoidal process of the palatine bones in front. The inferior border articulates with the crest formed by the maxilla and palatine bones. The anterior border is the longest and slopes downward and forward. Its upper half is fused with the perpendicular plate of the ethmoid. Its lower half is grooved for the inferior margin of the septal cartilage of the nose. The posterior border is free, concave, and separates the choani. It is thick and bifid above, thin below. Ossification. At an early period, the septum of the nose consists of a plate of cartilage, the ethmovomerian cartilage. The postero-superior part of this cartilage is ossified to form the perpendicular plate of the ethmoid. Its antero-inferior portion persists as the septal cartilage, while the voma is ossified in the membrane covering its postero-inferior part. 2 ossific centres, one on either side of the middle line, appear about the 8th week of fetal life in this part of the membrane, and hence the voma consists primarily of 2 lamellae. About the 3rd month these unite below, and thus a deep groove is formed in which the cartilage is lodged. As growth proceeds, the union of the lamellae extend upward and forward, and at the same time the intervening plate of cartilage undergoes absorption. By the age of puberty, the lamellae are almost completely united to form a median plate, but evidence of the bilaminar origin of the bone is seen in the inverted alae of its upper border and the groove on its anterior margin. Articulations. The voma articulates with 6 bones, 2 of the cranium, the sphenoid and ethmoid, and 4 of the face, the 2 maxillae and 2 palatine bones. It also articulates with the septal cartilage of the nose. End of section 29.
Section 30 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information, or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 1, by Henry Gray. The Mandible. 5b, Part 8. The Mandible, Lower Jaw. Inferior maxillary bone. The mandible, the largest and strongest bone of the face, serves for the reception of the lower teeth. It consists of a curved horizontal portion, the body, and 2 perpendicular portions, the rami, which unite with the ends of the body nearly at right angles. The body, Corpus mandibuli. The body is curved somewhat like a horseshoe and has two surfaces and two borders. Surfaces. The external surface is marked in the median line by a faint ridge indicating the symphysis or line of junction of the two pieces of which the bone is composed at an early period of life. This ridge divides below and encloses a triangular eminence, the mental protuberance, the base of which is depressed in the center but raised on either side to form the mental tubercle. On either side of the symphysis, just below the incisor teeth, is a depression, the incisive fossa, which gives origin to the mentalis and a small portion of the orbicularis oris. Below the second premolar tooth on either side, midway between the upper and lower borders of the body, is the mental foramen, for the passage of the mental vessels and nerve. Running backward and upward from each mental tubercle is a faint ridge, the oblique line, which is continuous with the anterior border of the ramus. It affords attachment to the quadratus labii inferioris and triangularis. The platysma is attached below it. The internal surface is concave from side to side. Near the lower part of the symphysis is a pair of laterally placed spines, termed the mental spines, which give origin to the genioglossae. Immediately below these is a second pair of spines, or more frequently a median ridge or impression, for the origin of the geniohyoidea. In some cases the mental spines are fused to form a single eminence, in others they are absent and their position is indicated merely by an irregularity of the surface. Above the mental spines a median foramen and furrow are sometimes seen. They mark the line of union of the halves of the bone. Below the mental spines, on either side of the middle line, is an oval depression for the attachment of the anterior belly of the digastricus. Extending upward and backward on either side from the lower part of the symphysis is the myeloid line, which gives origin to the mylohyoideus. The posterior part of this line, near the alveolar margin, gives attachment to a small part of the constrictor pharyngis superior, and to the pterygomandibular raphe. Above the anterior part of this line is a smooth triangular area against which the sublingual gland rests, and below the hinder part an oval fossa for the submaxillary gland. Borders. The superior or alveolar border, wider behind than in front, is hollowed into cavities for the reception of the teeth. These cavities are 16 in number and vary in depth and size according to the teeth which they contain. To the outer lip of the superior border on either side, the buccinator is attached as far forward as the first molar tooth. The inferior border is rounded, longer than the superior, and thicker in front than behind. At the point where it joins the lower border of the ramus a shallow groove, for the external maxillary artery, may be present. The ramus. Ramus mandibuli, perpendicular portion. The ramus is quadrilateral in shape and has two surfaces, four borders, and two processes. Surfaces. The lateral surface is flat and marked by oblique ridges at its lower part. It gives attachment throughout nearly the whole of its extent to the masseter. The medial surface presents about its center the oblique mandibular foramen, for the entrance of the inferior alveolar vessels and nerve. The margin of this opening is irregular. It presents in front a prominent ridge, surmounted by a sharp spine, the lingula mandibuli, which gives attachment to the sphenomandibular ligament. At its lower and back part is a notch from which the myloioid groove runs obliquely downward and forward and lodges the myloioid vessels and nerve. Behind this groove is a rough surface for the insertion of the pterygoideus internus. The mandibular canal runs obliquely downward and forward in the ramus, and then horizontally forward in the body, where it is placed under the alveoli and communicates with them by small openings. On arriving at the incisor teeth, it turns back to communicate with the mental foramen, giving off two small canals which run to the cavities containing the incisor teeth. In the posterior 2/3 of the bone the canal is situated nearer the internal surface of the mandible, and in the anterior third nearer its external surface. It contains the inferior alveolar vessels and nerve, from which branches are distributed to the teeth. The lower border of the ramus is thick, straight, and continuous with the inferior border of the body of the bone. At its junction with the posterior border is the angle of the mandible, which may be either inverted or everted, and is marked by rough, oblique ridges on each side for the attachment of the masseter laterally and the pterygoideus internus medially. The stylomandibular ligament is attached to the angle between these muscles. The anterior border is thin above, thicker below, and continuous with the oblique line. The posterior border is thick, smooth, rounded, and covered by the parotid gland. The upper border is thin and is surmounted by two processes, the coronoid in front and the condyloid behind, separated by a deep concavity, the mandibular notch. The coronoid process, processus coronoideus, is a thin, triangular eminence which is flattened from side to side and varies in shape and size. Its anterior border is convex and is continuous below with the anterior border of the ramus. Its posterior border is concave and forms the anterior boundary of the mandibular notch. Its lateral surface is smooth and affords insertion to the temporalis and masseter. Its medial surface gives insertion to the temporalis and presents a ridge which begins near the apex of the process and runs downward and forward to the inner side of the last molar tooth. Between this ridge and the anterior border is a grooved triangular area, the upper part of which gives attachment to the temporalis, the lower part to some fibers of the buccinator. The condyloid process, processus condyloideus, is thicker than the coronoid and consists of two portions, the condyle and the constricted portion which supports it, the neck. The condyle presents an articular surface for articulation with the articular disc of the temporomandibular joint. It is convex from before backward and from side to side, and extends farther on the posterior than on the anterior surface. Its long axis is directed medialward and slightly backward, and if prolonged to the middle line will meet that of the opposite condyle near the anterior margin of the foramen magnum. At the lateral extremity of the condyle is a small tubercle for the attachment of the temporomandibular ligament. The neck is flattened from before backward and strengthened by ridges which descend from the forepart and sides of the condyle. Its posterior surface is convex, its anterior presents a depression for the attachment of the pterygoideus externus. The mandibular notch, separating the two processes, is a deep semilunar depression and is crossed by the mesenteric vessels and nerve. Ossification. The mandible is ossified in the fibrous membrane covering the outer surfaces of Meckel's cartilages. These cartilages form the cartilaginous bar of the mandibular arch, and are two in number, a right and a left. Their proximal or cranial ends are connected with the ear capsules, and their distal extremities are joined to one another at the symphysis by mesodermal tissue. They run forward immediately below the condyles and then, bending downward, lie in a groove near the lower border of the bone. In front of the canine tooth they incline upward to the symphysis. From the proximal end of each cartilage, the malleus and incus, two of the bones of the middle ear, are developed. The next succeeding portion, as far as the lingula, is replaced by fibrous tissue, which persists to form the sphenomandibular ligament. Between the lingula and the canine tooth the cartilage disappears, while the portion of it below and behind the incisor teeth becomes ossified and incorporated with this part of the mandible. Ossification takes place in the membrane covering the outer surface of the ventral end of Meckel's cartilage, and each half of the bone is formed from a single centre which appears, near the mental foramen, about the 6th week of fetal life. By the 10th week the portion of Meckel's cartilage which lies below and behind the incisor teeth is surrounded and invaded by the membrane bone. Somewhat later, accessory nuclei of cartilage make their appearance, viz., a wedge-shaped nucleus in the condyloid process, and extending downward through the ramus, a small strip along the anterior border of the coronoid process, and smaller nuclei in the front part of both alveolar walls and along the front of the lower border of the bone. These accessory nuclei possess no separate ossific centers, but are invaded by the surrounding membrane bone and undergo absorption. The inner alveolar border, usually described as arising from a separate ossific center, splenial center, is formed in the human mandible by an ingrowth from the main mass of the bone. At birth the bone consists of two parts, united by a fibrous symphysis in which ossification takes place during the first year. The foregoing description of the ossification of the mandible is based on the researches of Lowe and Fawcett, and differs somewhat from that usually given. Articulations. The mandible articulates with the two temporal bones. Changes produced in the mandible by age. At birth the body of the bone is a mere shell, containing the sockets of the two incisor, the canine, and the two deciduous molar teeth, imperfectly partitioned off from one another. The mandibular canal is of large size, and runs near the lower border of the bone. The mental foramen opens beneath the socket of the first deciduous molar tooth. The angle is obtuse, 175 degrees, and the condyloid portion is nearly in line with the body. The coronoid process is of comparatively large size, and projects above the level of the condyle. After birth, the two segments of the bone become joined at the symphysis, from below upward, in the first year, but a trace of separation may be visible in the beginning of the second year, near the alveolar margin. The body becomes elongated in its whole length, but more especially behind the mental foramen, to provide space for the three additional teeth developed in this part. The depth of the body increases owing to increased growth of the alveolar part, to afford room for the roots of the teeth, and by thickening of the subdental portion which enables the jaw to withstand the powerful action of the masticatory muscles. But the alveolar portion is the deeper of the two, and consequently the chief part of the body lies above the oblique line. The mandibular canal, after the second dentition, is situated just above the level of the myloioid line, and the mental foramen occupies the position usual to it in the adult. The angle becomes less obtuse, owing to the separation of the jaws by the teeth. About the fourth year it is 140 degrees. In the adult, the alveolar and subdental portions of the body are usually of equal depth. The mental foramen opens midway between the upper and lower borders of the bone, and the mandibular canal runs nearly parallel with the myloioid line. The ramus is almost vertical in direction, the angle measuring from 110 to 120 degrees. In old age the bone becomes greatly reduced in size, for with the loss of the teeth the alveolar process is absorbed, and consequently the chief part of the bone is below the oblique line. The mandibular canal, with the mental foramen opening from it, is close to the alveolar border. The ramus is oblique in direction, the angle measures about 140 degrees, and the neck of the condyle is more or less bent backward. 5b, Section 9, the hyoid bone. Os hyoideum, lingual bone. The hyoid bone is shaped like a horseshoe, and is suspended from the tips of the styloid processes of the temporal bones by the styloid ligaments. It consists of 5 segments, viz., a body, 2 greater cornua, and 2 lesser cornua. The body, or basiheel, corpus os hyoidei. The body or central part is of a quadrilateral form. Its anterior surface is convex and directed forward and upward. It is crossed in its upper half by a well-marked transverse ridge with a slight downward convexity, and in many cases a vertical median ridge divides it into 2 lateral halves. The portion of the vertical ridge above the transverse line is present in a majority of specimens, but the lower portion is evident only in rare cases. The anterior surface gives insertion to the geniohyoideus in the greater part of its extent both above and below the transverse ridge. A portion of the origin of the hyoglossus notches the lateral margin of the geniohyoideus attachment. Below the transverse ridge the mylohyoideus, sternohyoideus, and omohyoideus are inserted. The posterior surface is smooth, concave, directed backward and downward, and separated from the epiglottis by the hyothyroid membrane and a quantity of loose areolar tissue. A bursa intervenes between it and the hyothyroid membrane. The superior border is rounded and gives attachment to the hyothyroid membrane and some aponeurotic fibers of the genioglossus. The inferior border affords insertion medially to the sternohyoideus and laterally to the omohyoideus, and occasionally a portion of the thyrohyoideus. It also gives attachment to the levator glandulae thyroidei, when this muscle is present. In early life the lateral borders are connected to the greater cornua by synchondroses, after middle life usually by bony union. The greater cornua, or thyrohyals, cornua majora. The greater cornua project backward from the lateral borders of the body. They are flattened from above downward and diminish in size from before backward. Each ends in a tubercle to which is fixed the lateral hyothyroid ligament. The upper surface is rough close to its lateral border, for muscular attachments. The largest of these are the origins of the hyoglossus and constrictor pharyngeus medius, which extend along the whole length of the cornu. The digastricus and stylohyoideus have small insertions in front of these near the junction of the body with the cornu. To the medial border the hyothyroid membrane is attached, while the anterior half of the lateral border gives insertion to the thyrohyoideus. The lesser cornua, or ceratohyals, cornua minora. The lesser cornu are two small conical eminences attached by their bases to the angles of junction between the body and greater cornua. They are connected to the body of the bone by fibrous tissue, and occasionally to the greater cornua by distinct diarthrodial joints, which usually persist throughout life, but occasionally become ankylosed. The lesser cornua are situated in the line of the transverse ridge on the body, and appear to be morphological continuations of it. The apex of each cornu gives attachment to the stylohyoid ligament. Footnote: These ligaments in many animals are distinct bones, and in man may undergo partial ossification. End footnote. The chondroglossus rises from the medial side of the base. Ossification. The hyoid is ossified from 6 centers, 2 for the body and 1 for each cornu. Ossification commences in the greater cornua toward the end of fetal life, in the body shortly afterward, and in the lesser cornua during the first or second year after birth. End of section 30. Recording by Leanne Howlett.
Section 31 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 1, by Henry Gray. The exterior of the skull, Part 1. The skull as a whole may be viewed from different points, and the views so obtained are termed the normae of the skull. Thus, it may be examined from above, norma verticalis, from below, norma basalis, from the side, norma lateralis, from behind, norma occipitalis, or from the front, norma frontalis. Norma verticalis. When viewed from above, the outline presented varies greatly in different skulls. In some it is more or less oval, in others more nearly circular. The surface is traversed by 3 sutures, viz. 1. The coronal sutures, nearly transverse in direction, between the frontal and parietals. 2. The sagittal sutures, medially placed, between the parietal bones, and deeply serrated in its anterior 2/3. And 3. The upper part of the lambdoidal suture, between the parietals and the occipital. The point of junction of the sagittal and coronal suture is named the bregma, that of the sagittal and lambdoid sutures the lambda. They indicate respectively the positions of the anterior and posterior fontanelles in the fetal skull. On either side of the sagittal suture are the parietal eminence and parietal foramen. The latter, however, is frequently absent on one or both sides. The skull is often somewhat flattened in the neighbourhood of the parietal foramina, and the term obelian is applied to that point of the sagittal suture which is on a level with the foramina. In front is the glabella, and on its lateral aspects are the superciliary arches, and above these the frontal eminences. Immediately above the glabella may be seen the remains of the frontal suture. In a small percentage of skulls this suture persists and extends along the middle line to the bregma. Passing backward and upward from the zygomatic processes of the frontal bone are the temporal lines, which mark the upper limits of the temporal fossae. The zygomatic arches may or may not be seen projecting beyond the anterior portion of these lines. Norma bassalis. The inferior surface of the base of the skull, exclusive of the mandible, is bounded in front by the incisor teeth in the maxillae, behind by the superior nuchal lines of the occipital, and laterally by the alveolar arch, the lower border of the zygomatic bone, the zygomatic arch, and an imaginary line extending from it to the mastoid process and extremity of the superior nuchal line of the occipital. It is formed by the palatine processes of the maxillae and palatine bones, the vomer, the pterygoid processes, the under surfaces of the great wings, spinous processes, and part of the body of the sphenoid, the under surfaces of the squamae and mastoid and petrous portions of the temporals, and the under surface of the occipital bone. The anterior part or hard palate projects below the level of the rest of the surface, and is bounded in front and laterally by the alveolar arch containing the 16 teeth of the maxillae. Immediately behind the incisor teeth is the incisive foramen. In this foramen are two lateral apertures, the openings of the incisive canals, foramina of Stenson, which transmit the anterior branches of the descending palatine vessels and the nasopalatine nerves. Occasionally, two additional canals are present in the incisive foramen. They are termed the foramina of Scarpa and are situated in the middle line. When present, they transmit the nasopalatine nerves. The vault of the hard palate is concave, uneven, perforated by numerous foramina, marked by depressions for the palatine glands, and traversed by a crucial suture formed by the junction of the four bones of which it is composed. In the young skull a suture may be seen extending on either side from the incisive foramen to the interval between the lateral incisor and canine teeth, and marking off the os incisivum or premaxillary bone. At either posterior angle of the hard palate is the greater palatine foramen, for the transmission of the descending palatine vessels and anterior palatine nerve, and running forward and medialward from it is a groove, for the same vessels and nerve. Behind the posterior palatine foramen is the pyramidal process of the palatine bone, perforated by one or more lesser palatine foramina, and marked by the commencement of a transverse ridge, for the attachment of the tendinous expansion of the tensor veli palatini. Projecting backward from the centre of the posterior border of the hard palate is the posterior nasal spine, for the attachment of the musculus uvulae. Behind and above the hard palate are the conae, measuring about 2.5 cm in their vertical and 1.25 cm in their transverse diameters. They are separated from one another by the vomer, and each is bounded above by the body of the sphenoid, below by the horizontal part of the palatine bone, and laterally by the medial pterygoid plate of the sphenoid. At the superior border of the vomer may be seen the expanded alae of this bone, receiving between them the rostrum of the sphenoid. Near the lateral margins of the alae of the vomer, at the roots of the pterygoid processes, are the pharyngeal canals. The pterygoid process presents near its base the pterygoid canal, for the transmission of a nerve and artery. The medial pterygoid plate is long and narrow. On the lateral side of its base is the scaphoid fossa, for the origin of the tensor veli palatini, and at its lower extremity the hamulus, around which the tendon of this muscle turns. The lateral pterygoid plate is broad, its lateral surface forms the medial boundary of the infratemporal fossa, and affords attachment of the pterygoideus externus. Behind the nasal cavities is the basilar portion of the occipital bone, presenting near its centre the pharyngeal tubercle for the attachment of the fibrous raphe of the pharynx, with depressions on either side for the insertions of the rectus capitis anterior and longus capitis. At the base of the lateral pterygoid plate is the foramen ovale, for the transmission of the mandibular nerve, the accessory meningeal artery, and sometimes the lesser superficial petrosal nerve. Behind this are the foramen spinosum, which transmits the middle meningeal vessels, and the prominent spina angularis sphenoidal spine, which gives attachment to the sphenomandibular ligament and the tensor veli palatini. Lateral to the spina angularis is the mandibular fossa, divided into two parts by the petrotympanic fissure, the anterior portion, concave, smooth, bounded in front by the articular tubercle, serves for the articulation of the condyle of the mandible. The posterior portion, rough and bounded behind by the tympanic part of the temporal, is sometimes occupied by a part of the parotid gland. Emerging from between the laminae of the vaginal process of the tympanic part is the styloid process, and at the base of this process is the stylomastoid foramen for the exit of the facial nerve and entrance of the stylomastoid artery. Lateral to the stylomastoid foramen, between the tympanic part and the mastoid process, is the tympanomastoid fissure, for the auricular branch of the vagus. Upon the medial side of the mastoid process is the mastoid notch, for the posterior belly of the digastricus, and medial to the notch, the occipital groove for the occipital artery. At the base of the medial pterygoid plate is a large and somewhat triangular aperture, the foramen lacerum, bounded in front by the great wing of the sphenoid, behind by the apex of the petrous portion of the temporal bone, and medially by the body of the sphenoid and basilar portion of the occipital bone. It presents in front the posterior orifice of the pterygoid canal, behind the aperture of the carotid canal. The lower part of this opening is filled up in the fresh state by a fibrocartilaginous plate, across the upper or cerebral surface of which the internal carotid artery passes. Lateral to this aperture is a groove, the sulcus tubi auditivi, between the petrous part of the temporal and the great wing of the sphenoid. This sulcus is directed lateralward and backward from the root of the medial pterygoid plate and lodges the cartilaginous part of the auditory tube. It is continuous behind with the canal in the temporal bone which forms the bony part of the same tube. At the bottom of this sulcus is a narrow cleft, the petrosphenoidal fissure, which is occupied, in the fresh condition, by a plate of cartilage. Behind this fissure is the undersurface of the petrous portion of the temporal bone, presenting, near its apex, the quadrilateral rough surface, part of which affords attachment to the levator veli palatini. Lateral to this surface is the orifice of the carotid canal, and medial to it the depression leading to the aqueductus cochleae, the former transmitting the internal carotid artery and the carotid plexus of the sympathetic, the latter serving for the passage of a vein from the cochlea. Behind the carotid canal is the jugular foramen, a large aperture, formed in front by the petrous portion of the temporal and behind by the occipital. It is generally larger on the right than on the left side, and may be subdivided into three compartments. The anterior compartment transmits the inferior petrosal sinus, the intermediate, the glossopharyngeal, vagus, and accessory nerves, the posterior, the transverse sinus, and some meningeal branches from the occipital and ascending pharyngeal arteries. On the ridge of bone dividing the carotid canal from the jugular foramen is the inferior tympanic canaliculus for the transmission of the tympanic branch of the glossopharyngeal nerve, and on the wall of the jugular foramen, near the root of the styloid process, is the mastoid canaliculus for the passage of the auricular branch of the vagus nerve. Extending forward from the jugular foramen to the foramen lacerum is the petrooccipital fissure, occupied, in the fresh state, by a plate of cartilage. Behind the basilar portion of the occipital bone is the foramen magnum, bounded laterally by the occipital condyles, the medial sides of which are rough for the attachment of the alar ligaments. Lateral to each condyle is the jugular process which gives attachment to the rectus capitis lateralis muscle and the lateral atlanto-occipital ligament. The foramen magnum transmits the medulla oblongata and its membranes, the accessory nerves, the vertebral arteries, the anterior and posterior spinal arteries, and the ligaments connecting the occipital bone with the axis. The midpoints on the anterior and posterior margins of the foramen magnum are respectively termed the basion and the opistheon. In front of each condyle is the canal for the passage of the hypoglossal nerve and a meningeal artery. Behind each condyle is the condyloid fossa, perforated on one or both sides by the condyloid canal for the transmission of a vein from the transverse sinus. Behind the foramen magnum is the medium nuchal line, extending above at the external occipital protuberance, while on either side are the superior and inferior nuchal lines. These, as well as the surfaces of the bone between them, are rough for the attachment of the muscles which are enumerated on pages 129 and 130. Norma lateralis. When viewed from the side, the skull is seen to consist of the cranium above and behind, and of the face below and in front. The cranium is somewhat ovoid in shape, but its contour varies in different cases and depends largely on the length and height of the skull and on the degree of prominence of the superciliary arches and frontal eminences. Entering into its formation are the frontal, the parietal, the occipital, the temporal, and the great wing of the sphenoid. These bones are joined to one another and to the zygomatic by the following sutures: the zygomatico-temporal between the zygomatic process of the temporal and the temporal process of the zygomatic, the zygomatico-frontal uniting the zygomatic bone with the zygomatic process of the frontal, the sutures surrounding the great wing of the sphenoid, viz., the sphenozygomatic in front, the sphenofrontal and sphenoparietal above, and the sphenosquamosal behind. The sphenoparietal suture varies in length in different skulls, and is absent in those cases where the frontal articulates with the temporal squama. The point corresponding with the posterior end of the sphenoparietal suture is named the pterion. It is situated about 3 cm behind and a little above the level of the zygomatic process of the frontal bone. The squamosal suture arches backward from the pterion and connects the temporal squama with the lower border of the parietal. This suture is continuous behind with the short, nearly horizontal parieto-mastoid suture, which unites the mastoid process of the temporal with the region of the mastoid angle of the parietal. Extending from above downward and forward across the cranium are the coronal and lambdoidal sutures. The former connects the parietals with the frontal, the latter the parietals with the occipital. The lambdoidal suture is continuous below with the occipito-mastoid suture between the occipital and mastoid portion of the temporal. In or near the last suture is the mastoid foramen, for the transmission of an emissary vein. The point of meeting of the parieto-mastoid, occipito-mastoid, and lambdoidal sutures is known as the asterion. Immediately above the orbital margin is the superciliary arch, and at a higher level the frontal eminence. Near the centre of the parietal bone is the parietal eminence. Posteriorly is the external occipital protuberance, from which the superior nuchal line may be followed forward to the mastoid process. Arching across the side of the cranium are the temporal lines, which mark the upper limit of the temporal fossa. The temporal fossa, fossa temporalis. The temporal fossa is bounded above and behind by the temporal lines, which extend from the zygomatic process of the frontal bone upward and backward across the frontal and parietal bones, and then curve downward and forward to become continuous with the supramastoid crest and the posterior root of the zygomatic arch. The point where the upper temporal line cuts the coronal suture is named the stephanion. The temporal fossa is bounded in front by the frontal and zygomatic bones, and opening on the back of the latter is the zygomatico-temporal foramen. Laterally the fossa is limited by the zygomatic arch, formed by the zygomatic and temporal bones. Below it is separated from the infratemporal fossa by the infratemporal crest on the great wing of the sphenoid, and by a ridge, continuous with this crest, which is carried backward across the temporal squama to the anterior root of the zygomatic process. In front and below, the fossa communicates with the orbital cavity through the inferior orbital or sphenomaxillary fissure. The floor of the fossa is deeply concave in front and convex behind, and is formed by the zygomatic, frontal, parietal, sphenoid, and temporal bones. It is traversed by vascular furrows. One, usually well marked, runs upwards above and in front of the external acoustic meatus, and lodges the middle temporal artery. Two others, frequently indistinct, may be observed on the anterior part of the floor, and are for the anterior and posterior deep temporal arteries. The temporal fossa contains the temporalis muscle and its vessels and nerves, together with the zygomatico-temporal nerve. The zygomatic arch is formed by the zygomatic process of the temporal and the temporal process of the zygomatic, the two being united by an oblique suture. The tendon of the temporalis passes medial to the arch to gain insertion into the coronoid process of the mandible. The zygomatic process of the temporal arises by two routes, an anterior, directed inward in front of the mandibular fossa, where it expands to form the articular tubercle, and a posterior, which runs backwards above the external acoustic meatus and is continuous with the supramastoid crest. The upper border of the arch gives attachment to the temporal fascia. The lower border and medial surface give origin to the masseter. Below the posterior root of the zygomatic arch is the elliptical orifice of the external acoustic meatus, bounded in front, below, and behind by the tympanic part of the temporal bone. To its outer margin the cartilaginous segment of the external acoustic meatus is attached. The small triangular area between the posterior root of the zygomatic arch and the posterous superior part of the orifice is termed the suprameatal triangle, on the anterior border of which a small spinous process, the suprameatal spine, is sometimes seen. Between the tympanic part and the articular tubercle is the mandibular fossa, divided into two parts by the petrotympanic fissure. The anterior and larger part of the fossa articulates with the condyle of the mandible and is limited behind by the external acoustic meatus. The posterior part sometimes lodges a portion of the parotid gland. The styloid process extends downward and forward for a variable distance from the lower part of the tympanic part, and gives attachment to the styloglossus, stylohyoideus, and stylopharyngeus, and to the stylohyoid and stylomandibular ligaments. Projecting downward behind the external acoustic meatus is the mastoid process, to the outer surface of which the sternocleidomastoideus, splenius capitis, and longissimus capitis are attached. End of section number 31. Section 32 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 1 by Henry Gray. The Exterior of the Skull, Part 2. The infratemporal fossa, fossa infratemporalis, zygomatic fossa. The infratemporal fossa is an irregularly shaped cavity, situated below and medial to the zygomatic arch. It is bounded, in front, by the infratemporal surface of the maxilla and the ridge which descends from its zygomatic process; behind, by the articular tubercle of the temporal and the spinal angularis of the sphenoid; above, by the great wing of the sphenoid below the infratemporal crest, and by the under surface of the temporal squama; below, by the alveolar border of the maxilla; medially, by the lateral pterygoid plate. It contains the lower part of the temporalis, the pterygoideae internus and externus, the internal maxillary vessels, and the mandibular and maxillary nerves. The foramen ovale and foramen spinosum open on its roof, and the alveolar canals on its anterior wall. At its upper and medial part are two fissures, which together form a T-shaped fissure, the horizontal limb being named the inferior orbital, and the vertical one the pterygomaxillary. The inferior orbital fissure, fissura orbitalis inferior, sphenomaxillary fissure, horizontal in direction, opens into the lateral and back part of the orbit. It is bounded above by the lower border of the orbital surface of the great wing of the sphenoid, below by the lateral border of the orbital surface of the maxilla and the orbital process of the palatine bone, laterally by a small part of the zygomatic bone. Note 48. Occasionally the maxilla and the sphenoid articulate with each other at the interior extremity of this fissure. The zygomatic is then excluded from it. Medially it joins at right angles with the pterygomaxillary fissure. Through the inferior orbital fissure the orbit communicates with the temporal, infratemporal, and pterygopalatine fossae. The fissure transmits the maxillary nerve and its zygomatic branch, the infraorbital vessels, the ascending branches from the sphenopalatine ganglion, and a vein which connects the inferior ophthalmic vein with the pterygoid venous plexus. The pterygomaxillary fissure is vertical and descends at right angles from the medial end of the preceding. It is a triangular interval, formed by the divergence of the maxilla from the pterygoid process of the sphenoid. It connects the infratemporal with the pterygopalatine fossa and transmits the terminal part of the internal maxillary artery. The pterygopalatine fossa, fossa pterygopalatina, sphenomaxillary fossa. The pterygopalatine fossa is a small triangular space at the angle of junction of the inferior orbital and pterygomaxillary fissures, and placed beneath the apex of the orbit. It is bounded above by the undersurface of the body of the sphenoid and by the orbital process of the palatine bone, in front by the infratemporal surface of the maxilla, behind by the base of the pterygoid process and lower part of the anterior surface of the great wing of the sphenoid, medially by the vertical part of the palatine bone with its orbital and sphenoidal processes. This fossa communicates with the orbit by the inferior orbital fissure, with the nasal cavity by the sphenopalatine foramen, and with the infratemporal fossa by the pterygomaxillary fissure. 5 foramina open into it. Of these, 3 are on the posterior wall, viz., the foramen rotundum, the pterygoid canal, and the pharyngeal canal, in this order downward and medialward. On the medial wall is the sphenopalatine foramen, and below is the superior orifice of the pterygopalatine canal. The fossa contains the maxillary nerve, the sphenopalatine ganglion, and the terminal part of the internal maxillary artery. Norma occipitalis. When viewed from behind, the cranium presents a more or less circular outline. In the middle line is the posterior part of the sagittal suture connecting the parietal bones. Extending downward and lateralward from the hinder end of the sagittal suture is the deeply serrated lambdoidal suture, joining the parietals to the occipital, and continuous below with the parietomastoid and occipitomastoid sutures. It frequently contains one or more sutural bones. Near the middle of the occipital squama is the external occipital protuberance, or inion, and extending lateralward from it on either side is the superior nuchal line, and above this the faintly marked highest nuchal line. The part of the squama above the inion and highest lines is named the planum occipitali, and is covered by the occipitalis muscle. The part below is termed the planum nuchale, and is divided by the median nuchal line which runs downward and forward from the inion to the foramen magnum. This ridge gives attachment to the ligamentum nuchae. The muscles attached to the planum nuchale are enumerated on page 130. Below and in front are the mastoid processes, convex laterally and grooved medially by the mastoid notches. In or near the occipitomastoid suture is the mastoid foramen for the passage of the mastoid emissary vein. Norma frontalis. When viewed from the front, the skull exhibits a somewhat oval outline, limited above by the frontal bone, below by the body of the mandible, and laterally by the zygomatic bones and the mandibular rami. The upper part, formed by the frontal squama, is smooth and convex. The lower part, made up of the bones of the face, is irregular. It is excavated laterally by the orbital cavities, and presents in the middle line the anterior nasal aperture leading to the nasal cavities, and below this the transverse slit between the upper and lower dental arcades. Above, the frontal eminences stand out more or less prominently, and beneath these are the superciliary arches, joined to one another in the middle by the glabella. On and above the glabella a trace of the frontal suture sometimes persists. Beneath is the frontonasal suture, the midpoint of which is termed the nasion. Behind and below the frontonasal suture the frontal articulates with the frontal process of the maxilla and with the lachrymal. Arching transversely below the superciliary arches is the upper part of the margin of the orbit, thin and prominent in its lateral 2/3, rounded in its medial third, and presenting at the junction of these two portions the supraorbital notch or foramen for the supraorbital nerve and vessels. The supraorbital margin ends laterally in the zygomatic process which articulates with the zygomatic bone, and from it the temporal line extends upward and backward. Below the frontonasal suture is the bridge of the nose, convex from side to side, concavo-convex from above downward, and formed by the two nasal bones supported in the middle line by the perpendicular plate of the ethmoid, and laterally by the frontal processes of the maxillae which are prolonged upward between the nasal and lachrymal bones and form the lower and medial part of the circumference of each orbit. Below the nasal bones and between the maxillae is the anterior aperture of the nose, piriform in shape, with the narrow end directed upward. Laterally this opening is bounded by sharp margins, to which the lateral and alar cartilages of the nose are attached. Below, the margins are thicker and curve medialward and forward to end in the anterior nasal spine. On looking into the nasal cavity, The bony septum which separates the nasal cavities presents, in front, a large triangular deficiency. This, in the fresh state, is filled up by the cartilage of the nasal septum. On the lateral wall of each nasal cavity the anterior part of the inferior nasal concha is visible. Below and lateral to the anterior nasal aperture are the anterior surfaces of the maxillae, each perforated, near the lower margin of the orbit, by the infraorbital foramen for the passage of the infraorbital nerve and vessels. Below and medial to this foramen is the canine eminence separating the incisive from the canine fossa. Beneath these fossae are the alveolar processes of the maxillae containing the upper teeth, which overlap the teeth of the mandible in front. The zygomatic bone on either side forms the prominence of the cheek, the lower and lateral portion of the orbital cavity, and the anterior part of the zygomatic arch. It articulates medially with the maxilla, behind with the zygomatic process of the temporal, and above with the great wing of the sphenoid and the zygomatic process of the frontal. It is perforated by the zygomaticofacial foramen for the passage of the zygomaticofacial nerve. On the body of the mandible is a median ridge, indicating the position of the symphysis. This ridge divides below to enclose the mental protuberance, the lateral angles of which constitute the mental tubercles. Below the incisor teeth is the incisive fossa, and beneath the second premolar tooth the mental foramen which transmits the mental nerve and vessels. The oblique line runs upward from the mental tubercle and is continuous behind with the anterior border of the ramus. The posterior border of the ramus runs downward and forward from the condyle to the angle, which is frequently more or less everted. The orbits. The orbits are two quadrilateral pyramidal cavities, situated at the upper and anterior part of the face, their bases being directed forward and lateralward, and their apices backward and medialward, so that their long axes, if continued backward, would meet over the body of the sphenoid. Each presents for examination a roof, a floor, a medial and a lateral wall, a base, and an apex. The roof is concave, directed downward and slightly forward, and formed in front by the orbital plate of the frontal, behind by the small wing of the sphenoid. It presents medially the trochlea fovea for the attachment of the cartilaginous pulley of the obliquus oculi superior, laterally the lacrimal fossa for the lacrimal gland, and posteriorly the suture between the frontal bone and the small wing of the sphenoid. The floor is directed upward and lateralward, and is of less extent than the roof. It is formed chiefly by the orbital surface of the maxilla, in front and laterally by the orbital process of the zygomatic bone, and behind and medially, to a small extent, by the orbital process of the palatine. At its medial angle is the upper opening of the nasolacrimal canal, immediately to the lateral side of which is a depression for the origin of the obliquus oculi inferior. On its lateral part is the suture between the maxilla and zygomatic bone, and at its posterior part that between the maxilla and the orbital process of the palatine. Running forward near the middle of the floor is the infraorbital groove, ending in front in the infraorbital canal and transmitting the infraorbital nerve and vessels. The medial wall is nearly vertical, and is formed from before backward by the frontal process of the maxilla, the lacrimal, the lamina papyrachia of the ethmoid, and a small part of the body of the sphenoid in front of the optic foramen. Sometimes the sphenoidal concha forms a small part of this wall. It exhibits three vertical sutures, viz. The lacromaxillary, lacrimoethmoidal, and sphenoethmoidal. In front is seen the lacrimal groove, which lodges the lacrimal sac, and behind the groove is the posterior lacrimal crest, from which the lacrimal part of the orbicularis oculi arises. At the junction of the medial wall and the roof are the frontomaxillary, frontolacrimal, frontoethmoidal, and sphenofrontal sutures. The point of junction of the anterior border of the lacrimal with the frontal is named the dacrion. In the frontoethmoidal suture are the anterior and posterior ethmoidal foramina, the former transmitting the nasociliary nerve and anterior ethmoidal vessels, the latter the posterior ethmoidal nerve and vessels. The lateral wall, directed medialward and forward, is formed by the orbital process of the zygomatic and the orbital surface of the great wing of the sphenoid. These are united by the sphenozygomatic suture which terminates below at the front end of the inferior orbital fissure. On the orbital process of the zygomatic bone are the orbital tubercle, Whitnell, and the orifices of one or two canals which transmit the branches of the zygomatic nerve. Between the roof and the lateral wall, near the apex of the orbit, is the superior orbital fissure. Through this fissure the oculomotor, the trochlea, the ophthalmic division of the trigeminal, and the adjacent nerves enter the orbital cavity. Also some filaments from the cavernous plexus of the sympathetic and the orbital branches of the middle meningeal artery. Passing backward through the fissure are the ophthalmic vein and the recurrent branch from the lacrimal artery to the dura mater. The lateral wall and floor are separated posteriorly by the inferior orbital fissure, which transmits the maxillary nerve and its zygomatic branch, the infraorbital vessels, and the ascending branches from the sphenopalatine ganglion. The base of the orbit, quadrilateral in shape, is formed above by the supraorbital arch of the frontal bone, in which is supraorbital notch or foramen for the passage of the supraorbital vessels and nerve. Below by the zygomatic bone and maxilla, united by the zygomatico-maxillary suture, laterally by the zygomatic bone and the zygomatic process of the frontal joined by the zygomatico-frontal suture, medially by the frontal bone and the frontal process of the maxilla, united by the frontomaxillary suture. The apex, situated at the back of the orbit, corresponds to the optic foramen, a short cylindrical canal which transmits the optic nerve and ophthalmic artery. Some anatomists describe the apex of the orbit as corresponding with the medial end of the superior orbital fissure. It seems better, however, to adopt the statement in the text, since the ocular muscles take origin around the optic foramen and diverge from it to the bulb of the eye. It will thus be seen that there are 9 openings communicating with each orbit, viz. the optic foramen, superior and inferior orbital fissures, supraorbital foramen, infraorbital canal, anterior and posterior ethmoidal foramina, zygomatic foramen, and the canal for the nasolacrimal duct. End of section 32. Section 33 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 1 by Henry Gray. The Interior of the Skull, Part 1. Inner surface of the skull cap. The inner surface of the skull cap is concave and presents depressions for the convolutions of the cerebrum, together with numerous furrows for the lodgment of branches of the middle meningeal vessels. Along the middle line is a longitudinal groove, narrow in front, where it commences at the frontal crest, but broader behind. It lodges the superior sagittal sinus, and its margins afford attachment to the falx cerebri. On either side of it are several depressions for the arachnoid granulations, and, at its back part, the openings of the parietal foramina when these are present. It is crossed in front by the coronal suture, and behind by the lambdoidal, while the sagittal lies in the medial plane between the parietal bones. Upper surface of the base of the skull. The upper surface of the base of the skull or floor of the cranial cavity presents 3 fossae, called the anterior, middle, and posterior cranial fossae. Anterior fossa, fossa cranii anterior. The floor of the anterior fossa is formed by the orbital plates of the frontal, the cribriform plate of the ethmoid, and the small wings and front part of the body of the sphenoid. It is limited behind by the posterior borders of the small wings of the sphenoid and by the anterior margin of the chiasmatic groove. It is transversed by the frontoethmoidal, sphenoethmoidal, and sphenofrontal sutures. Its lateral portions roof in the orbital cavities and support the frontal lobes of the cerebrum. They are convex and marked by depressions for the brain convolutions, and grooves for the branches of the meningeal vessels. The central portion corresponds with the roof of the nasal cavity, and is markedly depressed on either side of the crista galli. It presents, in and near the median line, from before backward, the commencement of the frontal crest for the attachment of the falx cerebri, the foramen caecum, between the frontal bone and the crista galli of the ethmoid, which usually transmits a small vein from the nasal cavity to the superior sagittal sinus. Behind the foramen caecum, the crista galli, the free margin of which affords attachment to the falx cerebri on either side of the crista galli. The olfactory groove, formed by the cribriform plate, which supports the olfactory bulb and presents foramina for the transmission of the olfactory nerves, and in front a slit-like opening for the nasociliary nerve. Lateral to either olfactory groove are the internal openings of the anterior and posterior ethmoidal foramina. The anterior, situated about the middle of the lateral margin of the olfactory groove, transmits the anterior ethmoidal vessels and the nasociliary nerve. The nerve runs in a groove along the lateral edge of the cribriform plate to the slit-like opening above mentioned. The posterior ethmoidal foramen opens at the back part of this margin under cover of the projecting lamina of the sphenoid and transmits the posterior ethmoidal vessels and nerve. Farther back in the middle line is the ethmoidal spine, bounded behind by a slight elevation separating two shallow longitudinal grooves which support the olfactory lobes. Behind this is the anterior margin of the chiasmatic groove, running lateralward on either side to the upper margin of the optic foramen. The middle fossa, fossa cranii media. The middle fossa, deeper than the preceding, is narrow in the middle and wide at the sides of the skull. It is bounded in front by the posterior margins of the small wings of the sphenoid, the anterior clinoid processes, and the ridge forming the anterior margin of the chiasmatic groove. Behind, by the superior angles of the petrous portions of the temporals and the dorsum sellae. Laterally by the temporal squamae. Sphenoidal angles of the parietals, and great wings of the sphenoid. It is traversed by the squamosal, sphenoparietal, sphenosquamosal, and sphenopetrosal sutures. The middle part of the fossa presents, in front, the chiasmatic groove and tuberculum sellae. The chiasmatic groove ends on either side at the optic foramen, which transmits the optic nerve and ophthalmic artery to the orbital cavity. Behind the optic foramen the anterior clinoid process is directed backward and medialward and gives attachment to the tentorium cerebelli. Behind the tuberculum sellae is a deep depression, the sella turcica, containing the fossa hypophyseos, which lodges the hypophysis, and presents on its anterior wall the middle clinoid processes. The sella turcica is bounded posteriorly by a quadrilateral plate of bone, the dorsum sellae, the upper angles of which are surmounted by the posterior clinoid processes. These afford attachment to the tentorium cerebelli, and below each is a notch for the abducent nerve. On either side of the sella turcica is the carotid groove, which is broad, shallow, and curved, somewhat like the italic letter F. It begins behind at the foramen lacerum and ends on the medial side of the anterior clinoid process, where it is sometimes converted into a foramen, caroticoclinoid, by the union of the anterior with the middle clinoid process. Posteriorly it is bound laterally by the lingula. The groove lodges the cavernous sinus and the internal carotid artery, the latter being surrounded by a plexus of sympathetic nerves. The lateral parts of the middle fossa are of considerable depth and support the temporal lobes of the brain. They are marked by depressions for the brain convolutions and traversed by furrows for the anterior and posterior branches of the middle meningeal vessels. These furrows begin near the foramen spinosum, and the anterior runs forward and upward to the sphenoidal angle of the parietal, where it is sometimes converted into a bony canal. The posterior runs lateralward and backward across the temporal squama and passes on to the parietal near the middle of its lower border. The following apertures are also to be seen. In front is the superior orbital fissure, bounded above by the small wing, below by the great wing, and medially by the body of the sphenoid. It is usually completed laterally by the orbital plate of the frontal bone. It transmits to the orbital cavity the oculomotor, the trochlea, the ophthalmic division of the trigeminal, and the abducent nerves. Some filaments from the cavernous plexus of the sympathetic, and the orbital branch of the middle meningeal artery, and from the orbital cavity a recurrent branch from the lacrimal artery to the dura mater, and the ophthalmic veins. Behind the middle end of the superior orbital fissure is the foramen rotundum for the passage of the maxillary nerve. Behind and lateral to the foramen rotundum is the foramen ovale, which transmits the mandibular nerve, the accessory meningeal artery, and the lesser superficial petrosal nerve. Medial to the foramen ovale is the foramen versalii, which varies in size in different individuals, and is often absent. When present it opens below at the lateral side of the scaphoid fossa and transmits a small vein. Lateral to the foramen ovale is the foramen spinosum, for the passage of the middle meningeal vessels and a recurrent branch from the mandibular nerve. Medial to the foramen ovale is the foramen lacerum. In the fresh state the lower part of this aperture is filled up by a layer of fibrocartilage, while its upper and inner parts transmit the internal carotid artery surrounded by a plexus of sympathetic nerves. The nerve of the pterygoid canal and a meningeal branch from the ascending pharyngeal artery pierce the layer of fibrocartilage. On the anterior surface of the petrous portion of the temporal bone are seen the eminence caused by the projection of the superior semicircular canal. In front of and a little lateral to this depression corresponding to the roof of the tympanic cavity, the groove leading to the hiatus of the facial canal, for the transmission of the greater superficial petrosal nerve and the petrosal branch of the middle meningeal artery. Beneath it, the smaller groove, for the passage of the lesser superficial petrosal nerve, and, near the apex of the bone, the depression for the semilunar ganglion and the orifice of the carotid canal. The posterior fossa, fossa cranii posterior. The posterior fossa is the largest and deepest of the three. It is formed by the dorsum sellae and clivus of the sphenoid, the occipital, the petrous and mastoid portions of the temporals, and the mastoid angles of the parietal bones. It is crossed by the occipito-mastoid and parieto-mastoid sutures, and lodges the cerebellum, pons, and medulla oblongata. It is separated from the middle fossa in and near the median line by the dorsum sellae of the sphenoid and on either side by the superior angle of the petrous portion of the temporal bone. This angle gives attachment to the tentorum cerebelli, is grooved for the superior petrosal sinus, and presents at its medial end a notch upon which the trigeminal nerve rests. The fossa is limited behind by the grooves for the transverse sinuses. In its centre is the foramen magnum, on either side of which is a rough tubercle for the attachment of the alar ligaments. A little above this tubercle is the canal, which transmits the hypoglossal nerve and a meningeal branch from the ascending pharyngeal artery. In front of the foramen magnum, the basilar portion of the occipital and the posterior part of the body of the sphenoid form a grooved surface which supports the medulla oblongata and pons. In the young skull these bones are joined by a synchondrosis. This grooved surface is separated on either side from the petrous portion of the temporal by the petro-occipital fissure, which is occupied in the fresh state by a plate of cartilage. The fissure is continuous behind with the jugular foramen, and its margins are grooved for the inferior petrosal sinus. The jugular foramen is situated between the lateral part of the occipital and the petrous portion of the temporal. The anterior portion of this foramen transmits the inferior petrosal sinus, the posterior portion, the transverse sinus and some meningeal branches from the occipital and ascending pharyngeal arteries, and the intermediate portion, the glossopharyngeal, vagus, and accessory nerves. Above the jugular foramen is the internal acoustic meatus, for the facial and acoustic nerves and internal auditory artery. Behind and lateral to this is the slit-like opening leading into the aqueductus vestibuli, which lodges the ductus endolymphaticus, while between these and near the superior angle of the petrous portion is a small triangular depression, the remains of the fossa subarcuata, which lodges a process of the dura mater and occasionally transmits a small vein. Behind the foramen magnum are the inferior occipital fossae, which support the hemispheres of the cerebellum, separated from one another by the internal occipital crest, which serves for the attachment of the falx cerebelli and lodges the occipital sinus. The posterior fossae are surmounted by the deep grooves for the transverse sinuses. Each of these channels, in its passage to the jugular foramen, grooves the occipital, the mastoid angle of the parietal, the mastoid portion of the temporal, and the jugular process of the occipital, and ends at the back part of the jugular foramen. Where this sinus grooves the mastoid portion of the temporal, the orifice of the mastoid foramen may be seen, and, just previous to its termination, the condyloid canal opens into it. Neither opening is constant. The nasal cavity, cavum nasi, nasal fossa. The nasal cavities are two irregular spaces, situated one on either side of the middle line of the face, extending from the base of the cranium to the roof of the mouth, and separated from each other by a thin vertical septum. They open on the face through the pear-shaped anterior nasal aperture, and their posterior openings or coni communicate, in the fresh state, with the nasal part of the pharynx. They are much narrower above than below, and in the middle than at the anterior or posterior openings. Their depth, which is considerable, is greatest in the middle. They communicate with the frontal, ethmoidal, sphenoidal, and maxillary sinuses. Each cavity is bounded by a roof, a floor, a medial and a lateral wall. The roof is horizontal in its central part, but slopes downward in front and behind. It is formed in front by the nasal bone and the spine of the frontal, in the middle by the cribriform plate of the ethmoid, and behind by the body of the sphenoid, the sphenoidal concha, the ali of the vomer, and the sphenoidal process of the palatine bone. In the cribriform plate of the ethmoid are the foramina for the olfactory nerves, and on the posterior part of the roof is the opening into the sphenoidal sinus. The floor is flattened from before backward and concave from side to side. It is formed by the palatine process of the maxilla and the horizontal part of the palatine bone. Near its anterior end is the opening of the incisive canal. The medial wall, septum nasi, is frequently deflected to one or other side, more often to the left than to the right. It is formed in front by the crest of the nasal bones and frontal spine, in the middle by the perpendicular plate of the ethmoid, behind by the vomer and the rostrum of the sphenoid, below by the crest of the maxillae and palatine bones. It presents in front a large triangular notch, which receives the cartilage of the septum, and behind the free edge of the vomer. Its surface is marked by numerous furrows for vessels and nerves and by the grooves for the nasopalatine nerve, and is traversed by sutures connecting the bones of which it is formed. The lateral wall is formed in front by the frontal process of the maxilla and by the lacrimal bone, in the middle by the ethmoid, maxilla, and inferior nasal concha, behind by the vertical plate of the palatine bone and the medial pterygoid plate of the sphenoid. On this wall are three irregular antero-posterior passages, termed the superior, middle, and inferior meatuses of the nose. The superior meatus, the smallest of the three, occupies the middle third of the lateral wall. It lies between the superior and middle nasal conchae, the sphenopalatine foramen opens into it behind, and the posterior ethmoidal cells in front. The sphenoidal sinus opens into a recess, the sphenoethmoidal recess, which is placed above and behind the superior concha. The middle meatus is situated between the middle and inferior conchae, and extends from the anterior to the posterior end of the latter. The lateral wall of this meatus can be satisfactorily studied only after the removal of the middle concha. On it is a curved fissure, the hiatus semilunaris, limited below by the edge of the uncinate process of the ethmoid and above by an elevation named the bulla ethmoidalis. The middle ethmoidal cells are contained within this bulla and open on or near it. Throughout the hiatus semilunaris the meatus communicates with a curved passage termed the infundibulum, which communicates in front with the anterior ethmoidal cells, and in rather more than 50% of skulls is continued upward as the frontonasal duct into the frontal air sinus. When this continuity fails, the frontonasal duct opens directly into the anterior part of the meatus. Below the bulla ethmoidalis, and hidden by the uncinate process of the ethmoid, is the opening of the maxillary sinus, ostium maxillare. An accessory opening is frequently present above the posterior part of the inferior nasal concha. The inferior meatus, the largest of the three, is the space between the inferior concha and the floor of the nasal cavity. It extends almost the entire length of the lateral wall of the nose, is broader in front than behind, and presents anteriorly the lower orifice of the nasolacrimal canal. The anterior nasal aperture is a heart-shaped or piriform opening, whose long axis is vertical, and narrow end upward. In the recent state it is much contracted by the lateral and alar cartilages of the nose. It is bounded above by the inferior borders of the nasal bones, laterally by the thin sharp margins which separate the anterior from the nasal surfaces of the maxillae, and below by the same borders, where they curve medialward to join each other at the anterior nasal spine. The coni are each bounded above by the under surface of the body of the sphenoid and alar of the vomer, below by the posterior border of the horizontal part of the palatine bone, laterally by the medial pterygoid plate. They are separated from each other by the posterior border of the vomer. End of section 33. Section 34 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 1 by Henry Gray. The Interior of the Skull, Part 2. Differences in the skull due to age. At birth. The skull is large in proportion to the other parts of the skeleton, but its facial portion is small, and equals only about 1/8 of the bulk of the cranium as compared with 1/2 in the adult. The frontal and parietal eminences are prominent, and the greatest width of the skull is at the level of the latter. On the other hand, the glabella, superciliary arches, and mastoid processes are not developed. Ossification of the skull bones is not completed, and many of them, e.g. the occipital, temporals, sphenoid, frontal, and mandible, consist of more than one piece. Unossified membranous intervals, termed fontanelles, are seen at the angles of the parietal bones. These fontanelles are 6 in number. 2, an anterior and a posterior, are situated in the middle line, and 2, an anterolateral and a posterolateral, on either side. The anterior or bregmatic fontanelle is the largest, and is placed at the junction of the sagittal, coronal, and frontal sutures. It is lozenge-shaped, and measures about 4 cm in its anteroposterior and 2.5 cm in its transverse diameter. The posterior fontanelle is triangular in form and is situated at the junction of the sagittal and lambdoidal sutures. The lateral fontanelles are small, irregular in shape, and correspond respectively with the sphenoidal and mastoidal angles of the parietal bones. An additional fontanelle is sometimes seen in the sagittal suture at the region of the obelion. The fontanelles are usually closed by the growth and extension of the bones which surround them, but sometimes they are the sites of separate ossific centres which develop into sutural bones. The posterior and lateral fontanelles are obliterated within a month or 2 after birth, but the anterior is not completely closed until about the middle of the 2nd year. The smallness of the face at birth is mainly accounted for by the rudimentary condition of the maxillae and mandible, the non-eruption of the teeth, and the small size of the maxillary, air sinuses, and nasal cavities. At birth the nasal cavities lie almost entirely between the orbits, and the lower border of the anterior nasal aperture is only a little below the level of the orbital floor. With the eruption of the deciduous teeth there is an enlargement of the face and jaws, and these changes are still more marked after the 2nd dentition. The skull grows rapidly from birth to the 7th year, by which time the foramen magnum and petrous parts of the temporals have reached their full size, and the orbital cavities are only a little smaller than those of the adult. Growth is slow from the 7th year until the approach of puberty, when a second period of activity occurs. This results in an increase in all directions, but it is especially marked in the frontal and facial regions, where it is associated with the development of the air sinuses. Obliteration of the sutures of the vault of the skull takes place as age advances. This process may commence between the ages of 30 and 40, and is first seen on the inner surface, and some 10 years later on the outer surface of the skull. The dates given are, however, only approximate, as it is impossible to state with anything like accuracy the time at which the sutures are closed. Obliteration usually occurs first in the posterior part of the sagittal suture, next in the coronal, and then in the lambdoidal. In old age the skull generally becomes thinner and lighter, but in a small proportion of cases it increases in thickness and weight, owing to an hypertrophy of the inner table. The most striking feature of the old skull is the diminution in the size of the maxillae and mandible consequent on the loss of the teeth and the absorption of the alveolar processes. This is associated with a marked reduction in the vertical measurement of the face and with an alteration in the angles of the mandible. Sexual differences in the skull. Until the age of puberty there is little difference between the skull of the female and that of the male. The skull of an adult female is, as a rule, lighter and smaller, and its cranial capacity about 10% less than that of the male. Its walls are thinner and its muscular ridges less strongly marked. The glabella, superciliary arches, and mastoid processes are less prominent, and the corresponding air sinuses are small or rudimentary. The upper margin of the orbit is sharp, the forehead vertical, the frontal and parietal eminences prominent, and the vault somewhat flattened. The contour of the face is more rounded, the facial bones are smoother, and the maxillae and mandible and their contained teeth smaller. From what has been said it will be seen that more of the infantile characteristics are retained in the skull of the adult female than in that of the adult male. A well-marked male or female skull can easily be recognized as such, but in some cases the respective characteristics are so indistinct that the determination of the sex may be difficult or impossible. Craniology. Skulls vary in size and shape, and the term craniology is applied to the study of these variations. The capacity of the cranial cavity constitutes a good index of the size of the brain which it contained, and is most conveniently arrived at by filling the cavity with shot and measuring the contents in a graduated vessel. Skulls may be classified according to their capacities as follows. 1. Microcephalic, with a capacity of less than 1,350 cubic centimetres, e.g. those of native Australians and Andaman Islanders. 2. Mesocephalic, with a capacity of from 1,350 cubic centimetres to 1,450 cubic centimetres, e.g. those of African Negroes and Chinese. 3. Megacephalic, with a capacity of over 1,450 cubic centimetres, e.g. those of Europeans, Japanese, and Eskimos. In comparing the shape of one skull with that of another it is necessary to adopt some definite position in which the skulls should be placed during the process of examination. They should be so placed that a line carried through the lower margin of the orbit and upper margin of the external acoustic meatus is in the horizontal plane. The normi of one skull can then be compared with those of another, and the differences in contour and surface form noted. Further, it is necessary that the various linear measurements used to determine the shape of the skull should be made between definite and easily localized points on its surface. The principal points may be divided into two groups: 1. Those in the median plane, and 2. Those on either side of it. The points in the median plane are the mental point, the most prominent point of the chin; alveolar point or prostheon, the central point of the anterior margin of the upper alveolar arch; subnasal point, the middle of the lower border of the anterior nasal aperture, at the base of the anterior nasal spine; nasion, the central point of the frontonasal suture; glabella, the point in the middle line at the level of the superciliary arches; ophryon, the point in the middle line of the forehead at the level where the temporal lines most nearly approach each other; bregma, the meeting point of the coronal and sagittal sutures; orbelion, a point in the sagittal suture on a level with the parietal foramina; lambda, the point of junction of the sagittal and lambdoidal sutures; occipital point, the point in the middle line of the occipital bone farthest from the glabella; inion, the external occipital protuberance; opistheon, the midpoint of the posterior margin of the foramen magnum; bassion, the midpoint of the anterior margin of the foramen magnum. The points on either side of the median plane are the gonion, the outer margin of the angle of the mandible; dacrion, the point of union of the antero-superior angle of the lacrimal with the frontal bone and the frontal process of the maxilla; stephanion, the point where the temporal line intersects the coronal suture; pterion, the point where the great wing of the sphenoid joins the sphenoidal angle of the parietal; auricular point, the centre of the orifice of the external acoustic meatus; asterion, the point of meeting of the lambdoidal, masto-occipital, and masto-parietal sutures. The horizontal circumference of the cranium is measured in a plane passing through the glabella, terna, or the ophryon, flower, in front, and the occipital point behind. It averages about 50 cm in the female and 52.5 cm in the male. The occipitofrontal or longitudinal arc is measured from the nasion over the middle line of the vertex to the opistheon, while the basinasal length is the distance between the bastion and the nasion. These two measurements, plus the antero-posterior diameter of the foramen magnum, represent the vertical circumference of the cranium. The length is measured from the glabella to the occipital point, while the breadth or greatest transverse diameter is usually found near the external acoustic meatus. The proportion of breadth to length, breadth times 100 divided by length, is termed the cephalic index, or index of breadth. The height is usually measured from the bastion to the bregma, and the proportion of height to length, height times 100 divided by length, constitutes the vertical or height index. In studying the face, the principal points to be noted are the proportion of its length and breadth, the shape of the orbits and of the anterior nasal aperture, and the degree of projection of the jaws. The length of the face may be measured from the ophryon or nasion to the chin, or, if the mandible be wanting, to the alveolar point, while its width is represented by the distance between the zygomatic arches. By comparing the length with the width of the face, skulls may be divided into two groups: dolichofacial or leptoprosope, long-faced, and brachyfacial or chemoprosope, short-faced. The orbital index signifies the proportion which the orbital height bears to the orbital width, thus: orbital height times 100 divided by orbital width. The nasal index expresses the proportion which the width of the anterior nasal aperture bears to the height of the nose, the latter being measured from the nasion to the lower margin of the nasal aperture, thus: nasal width times 100 divided by nasal height. The degree of projection of the jaws is determined by the gnathic or alveolar index, which represents the proportion between the basialveolar and basinasal lengths, thus: basialveolar length times 100 divided by basinasal length. The following table, modified from that given by Duckworth, illustrates how these different indices may be utilized in the classification of skulls. Index 1. Cephalic, classification, below 75, nomenclature, dolichocephalic, examples, Kaffirs and native Australians. Index 1. Cephalic, classification, between 75 and 80, nomenclature, mesatecephalic, examples, Europeans and Chinese. Index 1. Cephalic, classification, above 80, nomenclature, brachycephalic, examples, Mongolians and Andamans. Index 2. Orbital, classification, below 84, nomenclature, microceme, examples, Tasmanians and native Australians. Index 2. Orbital, classification, between 84 and 89, nomenclature, mesoceme, examples, Europeans. Index 2. Orbital, classification, above 89, nomenclature, megaceme, examples, Chinese and Polynesians. Index 3. Nasal, classification, below 48, nomenclature, leptorhine, examples, Europeans. Index 3. Nasal, classification, between 48 and 53, nomenclature, mesorhine, examples, Japanese and Chinese. Index 3. Nasal, classification, above 53, nomenclature, platyrhine, examples, Negroes and native Australians. Index 4. Gnathic, classification, below 98, nomenclature, orthognathus, examples, Europeans. Index 4. Gnathic, classification, between 98 and 103, nomenclature, mesognathus, examples, Chinese and Japanese. Index 4. Gnathic, classification, above 103, nomenclature, prognathus, examples, native Australians. The chief function of the skull is to protect the brain, and therefore those portions of the skull which are most exposed to external violence are thicker than those which are shielded from injury by overlying muscles. Thus the skull cap is thick and dense, whereas the temporal squamae, being protected by the temporalis muscles and the inferior occipital fossae being shielded by the muscles at the back of the neck, are thin and fragile. Fracture of the skull is further prevented by its elasticity, its rounded shape, and its construction of a number of secondary elastic arches, each made up of a single bone. The manner in which vibrations are transmitted through the bones of the skull is also of importance as regards its protective mechanism, at all events as far as the base is concerned. In the vault, the bones being of a fairly equal thickness and density, vibrations are transmitted in a uniform manner in all directions. But in the base, owing to the varying thickness and density of the bones, this is not so, and therefore in this situation there are special buttresses which serve to carry the vibrations in certain definite directions. At the front of the skull, on either side, is the ridge which separates the anterior from the middle fossa of the base, and behind the ridge or buttress which separates the middle from the posterior fossa, and if any violence is applied to the vault, the vibrations would be carried along these buttresses to the sella turcica, where they meet. This part has been termed the centre of resistance, and here there is a special protective mechanism to guard the brain. The subarachnoid cavity at the base of the brain is dilated, and the cerebrospinal fluid which fills it acts as a water cushion to shield the brain from injury. In like manner, when violence is applied to the base of the skull, as in falls upon the feet, the vibrations are carried backwards through the occipital crest and forward through the basilar part of the occipital and body of the sphenoid to the vault of the skull. In connection with the bones of the face, a common malfunction is cleft palate. The cleft usually starts posteriorly, and its most elementary form is a bifid uvula, or the cleft may extend through the soft palate, or the posterior part of the whole of the hard palate may be involved, the cleft extending as far forward as the incisive foramen. In the severest form, the cleft extends through the alveolus and passes between the incisive or premaxillary bone and the rest of the maxilla, that is to say, between the lateral incisor and canine teeth. In some instances, the cleft runs between the central and lateral incisor teeth, and this has induced some anatomists to believe the premaxillary bone is developed from two centres and not from one, as was stated on page 163. The medial segment, bearing a central incisor, is called an endognathion. The lateral segment, bearing the lateral incisor, is called a mesognathion. The cleft may affect one or both sides. If the latter, the central part is frequently displaced forward and remains united to the septum of the nose, the deficiency in the alveolus being complicated with the cleft in the lip, hare lip. On examining a cleft palate in which the alveolus is not implicated, the cleft will generally appear to be in the median line, but occasionally is unilateral and in some cases bilateral. To understand this, it must be borne in mind that three processes are concerned in the formation of the palate: the palatine processes of the two maxillae, which grow in horizontally and unite in the middle line, and the ethmovomerine process, which grows downward from the base of the skull and frontonasal process to unite with the palatine processes in the middle line. In those cases where the palatine processes fail to unite with each other and with the medial process, the cleft of the palate is median. Where one palatine process unites with the medial septum, the other failing to do so, the cleft in the palate is unilateral. In some cases where the palatine processes fail to meet in the middle, the ethmovomerine process grows downward between them and thus produces a bilateral cleft. Occasionally there may be a hole in the middle line of the hard palate, the anterior part of the hard and soft palate being perfect. This is rare, because as a rule the union of the various processes progresses from before backward, and therefore the posterior part of the palate is more frequently defective than the anterior. End of section 34.
Section 35 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Steve Foreman. Anatomy of the Human Body, Part 1, by Henry Gray. The extremities. The bones by which the upper and lower limbs are attached to the trunk constitute respectively the shoulder and pelvic girdles. The shoulder girdle, or girdle of the superior extremity, is formed by the scapula and clavicles, and is imperfect in front and behind. In front, however, it is completed by the upper end of the sternum, with which the medial ends of the clavicle articulate. Behind, it is widely imperfect, the scapula being connected to the trunk by muscles only. The pelvic girdle, or girdle of the inferior extremity, is formed by the hip bones, which articulate with each other in front at the symphysis pubis. It is imperfect behind, but the gap is filled in by the upper part of the sacrum. The pelvic girdle with the sacrum is a complete ring, massive and comparatively rigid, in marked contrast to the lightness and mobility of the shoulder girdle. The clavicle. The clavicle forms the anterior portion of the shoulder girdle. It is a long bone, curved somewhat like the italic letter F, and placed nearly horizontally at the upper and anterior part of the thorax, immediately above the first rib. It articulates medially with the manubrium sterni, and laterally with the acromion of the scapula. Footnote: the clavicle acts especially as a fulcrum to enable the muscles to give lateral motion to the arm. It is accordingly absent in those animals whose forelimbs are used only for progression, but is present for the most part in animals whose anterior extremities are clawed and used for prehension, though in some of them, as, for instance, in a large number of carnivora, it is merely a rudimentary bone suspended among the muscles, and not articulating with either the scapula or sternum. End of footnote. It presents a double curvature, the convexity being directed toward the sternal end, and the concavity at the scapular end. Its lateral third is flattened from above downward, while its medial 2/3 is of a rounded or prismatic form. Lateral third. The lateral third has two surfaces, an upper and a lower, and two borders, an anterior and a posterior. Surface. The upper surface is flat, rough, and marked by impressions for the attachments of the deltoideus in front and the trapezius behind. Between these impressions, a small portion of the bone is subcutaneous. The undersurface is flat. At its posterior border, near the point where the prismatic joins with the flattened portion, is a rough eminence, the coracoid tuberosity. This, in the natural position of the bone, surmounts the coracoid process of the scapula, and gives attachment to the conoid ligament. From this tuberosity an oblique ridge, the oblique or trapezoid ridge, runs forward and lateralward, and afford attachment to the trapezoid ligament. Borders. The anterior border is concave, thin, and rough, and gives attachments to the deltoideus. The posterior border is convex, rough, thicker than the anterior, and gives attachment to the trapezius. Medial 2/3. The medial 2/3 constitute the prismatic portion of the bone, which is curved so as to be convex in front, concave behind, and is marked by three borders separating three surfaces. Borders. The anterior border is contiguous with the anterior margin of the flat portion. Its lateral part is smooth, and corresponds to the interval between the attachments of the pectoralis major and deltoideus. Its medial part forms the lower boundary of an elliptical surface for the attachment of the clavicular portion of the pectoralis major, and approaches the posterior border of the bone. The superior border is continuous with the posterior margin of the flat portion, and separates the anterior from the posterior surface. Smooth and rounded laterally, it becomes rough towards the medial third for the attachment of the sternocleidomastoideus, and ends at the upper angle of the sternal extremity. The posterior or subclavian border separates the posterior from the inferior surface, and extends from the coracoid tuberosity to the costal tuberosity. It forms the posterior boundary of the groove for the subclavius, and gives attachment to the layer of cervical fascia which envelops the omohyoideus. Surfaces. The anterior surface is included between the superior and anterior borders. Its lateral part looks upward, and is continuous with the superior surface of the flattened portion. It is smooth, convex, and nearly subcutaneous, being covered only by the platysma. Medially it is divided by a narrow subcutaneous area into two parts, a lower elliptical in form, and directed forward for the attachment of the pectoralis major, and an upper for the attachment of the sternocleidomastoideus. The posterior or cervical surface is smooth and looks backward toward the root of the neck. It is limited above by the superior border, below by the subclavian border, medially by the margin of the sternal extremity, and laterally by the coracoid tuberosity. It is concave mediolaterally and is in relation, by its lower part, with the transverse scapular vessels. This surface, at the junction of the curves of the bone, is also in relation to the brachial plexus of nerves and the subclavian vessels. It gives attachment near the sternal extremity to part of the sternohyoideus and presents, near the middle, an oblique foramen directed lateralward, which transmits the chief nutrient artery of the bone. Sometimes there are two foramini on the posterior surface, or one on the posterior and another on the inferior surface. The inferior or subclavian surface is bounded in front by the anterior border, behind by the subclavian border. It is narrowed medially, but gradually increases in width laterally, and is continuous with the upper surface of the flat portion. On its medial part is a broad, rough surface, the costal tuberosity, rather more than 2 centimeters in length, for the attachment of the costoclavicular ligament. The rest of this surface is occupied by a groove, which gives attachment to the subclavius. The coracoclavicular fascia, which splits to enclose the muscle, is attached to the margins of the groove. Not infrequently this groove is subdivided longitudinally by a line which gives attachment to the intramuscular septum of the subclavius. The sternal extremity, extremitas sternalis, internal extremity. The sternal extremity of the clavicle is triangular in form, directed medialward and a little downward and forward. It presents an articular facet, concave from before backward, convex from above downward, and articulates with the manubrium sterni through the intervention of an articular disc. The lower part of the facet is continued on to the inferior surface of the bone as a small semi-oval area for articulation with the cartilage of the first rib. The circumference of the articular surface is rough, for the attachment of numerous ligaments. The upper angle gives attachment to the articular disc. The acromial extremity, extremitas acromialis, outer extremity. The acromial extremity presents a small, flattened, oval surface directed obliquely downward for articulation with the acromion of the scapula. The circumference of the articular facet is rough, especially above, for the attachment of the acromioclavicular ligaments. In the female, the clavicle is generally shorter, thinner, less curved, and smoother than in the male. In those persons who perform considerable manual labor, it becomes thicker and more curved, and its ridges for muscular attachment are prominently marked. Structure. The clavicle consists of cancellous tissue, enveloped by a compact layer, which is much thicker in the intermediate part than at the extremities of the bone. Ossification. The clavicle begins to ossify before any other bone in the body. It is ossified from 3 centers. 2 primary centers, a medial and lateral, for the body, which appears during the 5th or 6th week of fetal life, and a secondary center for the sternal end, which appears about the 18th or 20th year, and unites with the rest of the bone about the 25th year. End of section 35. Section 36 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. recording by Steve Foreman. Anatomy of the Human Body, Part 1, by Henry Gray. The Scapula. The scapula forms the posterior part of the shoulder girdle. It is a flat, triangular bone with 2 surfaces, 3 borders, and 3 angles. Surfaces. The costal or ventral surface presents a broad concavity, the suprascapular fossa. The medial 2/3 of the fossa are marked by several oblique ridges, which run lateralward and upward. The ridges give attachment to the tendinous insertions, and the surfaces between them to the fleshy fibers of the subscapularis. The lateral third of the fossa is smooth and covered by the fibers of this muscle. The fossa is separated from the vertebral border by smooth triangular areas at the medial and inferior angles, and in the interval between these by a narrow ridge which is often deficient. These triangular areas and the intervening ridge afford attachment to the serratus anterior. At the upper part of the fossa is a transverse depression, where the bone appears to be bent on itself along a line at right angles to and passing through the center of the glenoid cavity, forming the considerable angle called the subscapular angle. This gives greater strength to the body of the bone by its arched form, while the summit of the arch serves to support the spine and acromion. The dorsal surface is arched from above downward, and is subdivided into 2 unequal parts by the spine. The portion above the spine is called the supraspinatus fossa, and that below it is the infraspinatus fossa. The supraspinatus fossa, the smaller of the 2, is concave, smooth, and broader at its vertebral than at its humeral end. Its medial 2/3 is origin to the supraspinatus. The infraspinatus fossa is much larger than the preceding. Toward its vertebral margin, a shallow concavity is seen at its upper part. Its center presents a prominent convexity, while near the axillary border is a deep groove which runs from the upper towards the lower part. The medial 2/3 of the fossa give origin to the infraspinatus. The lateral third is covered by this muscle. The dorsal surface is marked near the axillary border by an elevated ridge, which runs from the lower part of the glenoid cavity downward and backward to the vertebral border about 2.5 centimeters above the inferior angle. The ridge serves for the attachment of a fibrous septum, which separates the infraspinatus from the teres major and teres minor. The surface between the ridge and the axillary border is narrow in the upper 2/3 of its extent, and is crossed near the center by a groove for the passage of the scapular circumflex vessels. It affords attachment to the teres minor. Its lower third presents a broader, somewhat triangular surface, which gives origin to the teres major, and over which the latissimus dorsi glides. Frequently the latter muscle takes origin by a few fibers from this part. The broad and narrow portions above alluded to are separated by an oblique line, which runs from the axillary border downward and backward to meet the elevated ridge. To it is attached a fibrous septum which separates the teres muscle from each other. The spine, spina scapulae. The spine is a prominent plate of bone which crosses obliquely the medial 4/5 of the dorsal surface of the scapula at its upper part, and separates the supra from the infraspinatus fossa. It begins at the vertical border by a smooth triangular area over which the tendon of insertion of the lower part of the trapezius glides, and, gradually becoming more elevated, ends in the acromion, which overhangs the shoulder joint. The spine is triangular and flattened from above downward, its apex being directed towards the vertebral border. It presents 2 surfaces and 3 borders. Its superior surface is concave. It assists in forming the supraspinatus fossa and gives origin to part of the supraspinatus. Its inferior surface forms part of the infraspinatus fossa, gives origin to a portion of the infraspinatus, and presents near its center the orifice of a nutrient canal. Of the three borders, the anterior is attached to the dorsal surface of the bone. The posterior, or crest of the spine, is broad and presents two lips and an intervening rough interval. The trapezius is attached to the superior lip, and a rough tubercle is generally seen on the portion of the spine which receives the tendon of the insertion of the lower part of this muscle. The deltoideus is attached to the whole length of the inferior lip. The interval between the lips is subcutaneous and partly covered by the tendinous fibers of these muscles. The lateral border, or base, the shortest of the three, is slightly concave. Its edges, thick and round, is continuous above within the under surface of the acromion, below the neck of the scapula. It forms the medial boundary of the great scapular notch, which serves to connect the supra and infraspinatus fossa. The acromion. The acromion forms the summit of the shoulder and is a large, somewhat triangular or oblong process, flattened from behind forward, projecting at first lateralward, and then curving upward and forward, so as to overhang the glenoid cavity. Its superior surface, directed upward, backward, and lateralward, is convex, rough, and gives attachment to some fibers of the deltoideus, and in the rest of its extent is subcutaneous. Its inferior surface is smooth and concave. Its lateral border is thick and irregular, and presents 3 or 4 tubercles for the tendinous origins of the deltoideus. Its medial border, shorter than the lateral, is concave, gives attachment to a portion of the trapezius, and presents about its center a small oval surface for articulation with the acromial end of the clavicle. Borders. Of the 3 borders of the scapula, the superior is the shortest and thinnest. It is concave and extends from the medial angle to the base of the coracoid process. At its lateral part is a deep semicircular notch, the scapular notch, formed partly by the base of the coracoid process. This notch is converted into a foramen by the superior transverse ligament, and serves for the passage of the suprascapular nerve. Sometimes the ligament is ossified. The adjacent part of the superior border affords attachment to the omohyoideus. The axillary border is the thickest of the 3. It begins above at the lower margin of the glenoid cavity, and inclines obliquely downward and backward to the inferior angle. Immediately below the glenoid cavity is the rough impression, the infraglenoid tuberosity, about 2.5 centimeters in length, which gives origin to the long head of the triceps brachii. In front of this is a longitudinal groove, which extends as far as the lower third of this border, and affords origin to part of the subscapularis. The inferior third is thin and sharp, and serves for the attachment of a few fibers of the teres major behind, and of the subscapularis in front. The vertebral border is the longest of the 3, and extends from the medial to the inferior angle. It is arched, intermediate in thickness, between the superior and axillary borders, and the portion of it above the spine forms an obtuse angle with the part below. This border presents an anterior and a posterior lip, and an intermediate narrow area. The anterior lip affords attachment to the serratus anterior, the posterior lip to the supraspinatus above the spine, the infraspinatus below, the area between the 2 lips to the levator scapulae above the triangular surface at the commencement of the spine, to the rhomboideus minor on the edge of that surface, and to the rhomboideus major below it. This last is attached by means of the fibrous arch, connected above to the lower part of the triangular surface at the base of the spine, and below to the lower part of the border. Angles. Of the 3 angles, the medial, formed by the junction of the superior and vertebral borders, is thin, smooth, rounded, inclined somewhat lateralward, and gives attachment to a few fibers of the levator scapulae. The inferior angle, thick and rough, is formed by the union of the vertebral and axillary borders. Its dorsal surface affords attachment to the teres major, and frequently to a few fibers of the latissimus dorsi. The lateral angle is the thickest part of the bone, and is sometimes called the head of the scapula. On it is a shallow piriform articular surface, the glenoid cavity, which is directed lateralward and forward and articulates with the head of the humerus. It is broader below than above, and its vertical diameter is the longest. The surface is covered with cartilage in a fresh state, and its margins, raised slightly, give attachment to a fibrocartilaginous structure, the glenoid labrum, which deepens the cavity. At its apex is a slight elevation, the supraglenoid tuberosity, to which the long head of the biceps brachii is attached. The neck of the scapula is the slightly constricted portion, which surrounds the head and is more distinct below and behind than above and in front. The coracoid process, processus coracoideus. The coracoid process is a thick curved process attached by a broad base to that upper part of the neck of the scapula. It runs at first upward and medialward, then, becoming smaller, it changes its direction and projects forward and lateralward. The ascending portion, flattened from before backwards, presents in front a smooth concave surface across which the suprascapularis passes. The horizontal portion is flattened from above downward. Its upper surface is convex and irregular, and gives attachment to the pectoralis minor. Under its surface is smooth. Its medial and lateral borders are rough. The former gives attachment to the pectoralis minor, and the latter to the coracochromial ligament. The apex is embraced by the conjoined tendon of origin of the coracobrachialis and the short head of the biceps brachii, and gives attachment to the coracoclavicular fascia. On the medial part of the root of the coracoid process is a rough impression for the attachment of the conoid ligament, and running from it obliquely forward and lateralward onto the upper surface of the horizontal portion is an elevated ridge for the attachment of the trapezoid ligament. Structure. The head, processes, and the thickened part of the bone contains cancellous tissue. The rest consists of a thin layer of compact tissue. The central part of the supraspinatus fossa and the upper part of the infraspinatus fossa, but especially the former, are usually so thin as to be semi-transparent. Occasionally the bone is found wanting in this situation, and the adjacent muscles are separated only by fibrous tissue. Ossification. The scapula is ossified from 7 or more centers, 1 for the body, 2 for the coracoid process, 2 for the acromion, 1 for the vertebral border, and 1 for the inferior angle. Ossification of the body begins about the 2nd month of fetal life by the formation of an irregular quadrilateral plate of bone immediately behind the glenoid cavity. This plate extends so as to form the chief part of the bone, and spine growing up from its dorsal surface about the 3rd month. At birth, a large part of the scapula is osseous, but the glenoid cavity, the coracoid process, the acromion, the vertebral border, and the inferior angle are cartilaginous. From the 15th through the 18th month after birth, ossification takes place in the middle of the coracoid process, which as a rule becomes joined with the rest of the bone about the 15th year. Between the 14th and 20th years, ossification of the remaining parts take place in quick succession, and usually in the following order. First, in the root of the coracoid process, in the form of a broad scale. Secondly, near the base of the acromion. Thirdly, in the inferior angle and contiguous part of the vertebral border. Fourthly, near the extremity of the acromion. Fifthly, in the vertebral border. The base of the acromion is formed by an extension from the spine. The two separate nuclei of the acromion unite, and then join with the extension from the spine. The upper third of the glenoid cavity is ossified from a separate center, subcoracoid, which makes its appearance between the 10th and 11th years, and joins between the 16th and the 18th. Further, an epiphyseal plate appears for the lower part of the glenoid cavity, while the tip of the coracoid process frequently presents a separate nucleus. These various epiphyses are joined to the bone by the 25th year. Failure of the bony union between the acromion and spine sometimes occurs, the junction being affected by fibrous tissue or by an imperfect articulation. In some cases of supposed fracture of the acromion with ligamentous union, it is probable that the detached segment was never united to the rest of the bone. End of section 36. Section 37 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Steve Foreman. Anatomy of the Human Body, Part 1, by Henry Gray. Section 37, the Humerus. The humerus is the longest and largest bone of the upper extremity. It is divisible into a body and two extremities. Upper extremity. The upper extremity consists of a large rounded head joined to the body by a constricted portion called the neck, and two eminences, the greater and lesser tubercles. The head, or caput humeri. The head, nearly hemispherical in form. Footnote: though the head is nearly hemispherical in form, its margins, as Humphrey has shown, is by no means a true circle. Its greatest diameter is from the top of the intertubercular groove in a direction downward, medialward, and backward. Hence it follows that the greatest elevation of the arm can be obtained by rolling the articular surface in this direction, that is to say, obliquely upward, lateralward, and forward. End of footnote. Is directed upward, medialward, and a little backward, and articulates with the glenoid cavity of the scapula. The circumference of its articular surface is slightly constricted, and is termed the anatomical neck, in contradistinction to a constriction below the tubercles called the surgical neck, which is frequently the seat of fracture. Fracture of the anatomical neck rarely occurs. The anatomical neck, or column anatomicum, is obliquely directed, forming an obtuse angle with the body. It is best marked in the lower half of its circumference. In the upper half it is represented by a narrow groove separating the head from the tubercles. It affords attachment to the articular capsule of the shoulder joint, and is perforated by numerous vascular foraminae. The greater tubercle, or tuberculum majus, or greater tuberosity. The greater tubercle is situated lateral to the head and lesser tubercle. Its upper surface is rounded and marked by three flat impressions. The highest of these gives insertion to the supraspinatus, the middle to the infraspinatus, the lowest one, and the body of the bone for about 2.5 centimeters below it, to the teres minor. The lateral surface of the greater tubercle is convex, rough, and continuous with the lateral surface of the body. The lesser tubercle, or tuberculum minus, or lesser tuberosity. The lesser tubercle, although smaller, is more prominent than the greater. It is situated in front, and is directed medialward and forward. Above and in front it presents an impression for the insertion of the tendon of the subscapularis. The tubercles are separated from each other by a deep groove, the intertubercular groove or bicipital groove, which lodges the long tendon of the biceps brachii and transmits a branch of the anterior humeral circumflex artery to the shoulder joint. it runs obliquely downward and ends near the junction of the upper with the middle third of the bone. In the fresh state, its upper part is covered with a thin layer of cartilage, lined by a prolongation of the synovial membrane of the shoulder joint. Its lower portion gives insertion to the tendon of the latissimus dorsi. It is deep and narrow above, and becomes shallow and a little broader as it descends. Its lips are called, respectively, the crest of the greater and lesser tubercles, or bicipital ridges, and forms the upper part of the anterior and medial borders of the body of the bone. The body or shaft, or corpus humeri. The body is almost cylindrical in the upper half of its extent, prismatic and flattened below, and has 3 borders and 3 surfaces. Borders. The anterior border runs from the front of the greater tubercle above to the coronoid fossa below, separating the anterior medial from the anterolateral surface. Its upper part is a prominent ridge, the crest of the greater tubercle. It serves for the insertion of the tendon of the pectoralis major. About its center, it forms the anterior boundary of the deltoid tuberosity. Below, it is smooth and rounded, affording the attachment to the brachialis. The lateral border runs from the back part of the greater tubercle to the lateral epicondyle, and separates the anterolateral from the posterior surface. Its upper half is rounded and indistinctly marked, serving for the attachment of the lower part of the insertion of the teres minor, and below this giving origin to the lateral head of the triceps brachii. Its center is traversed by a broad but shallow oblique depression, the radial sulcus or musculospiral groove. Its lower part forms a prominent, rough margin, a little curved from behind forward, the lateral supracondylar ridge, which presents an anterior lip for the origin of the brachioradialis above, the extensor carpi radialis longus below, a posterior lip for the triceps brachii, and an intermediate ridge for the attachment of the lateral intermuscular septum. The medial border extends from the lesser tubercle to the medial epicondyle. Its upper third consists of a prominent ridge, the crest of the lesser tubercle, which gives insertion to the tendon of the teres major. About its center is a slight impression for the insertion of the coracobrachialis, and just below this is the entrance of the nutrient canal, directed downward. Sometimes there is a second nutrient canal at the commencement of the radial sulcus. The inferior third of this border is raised into a slight ridge, the medial supracondylar ridge, which becomes very prominent below. It presents an anterior lip for the origins of the brachialis and pronator teres, a posterior lip for the medial head of the triceps brachii, and an intermediate ridge for the attachment of the medial intramuscular septum. Surfaces. The anterolateral surface is directed lateralward above, where it is smooth, rounded, and covered by the deltoideus; forward and lateralward below, where it is slightly concave from above downward, and gives origin to part of the brachialis. About the middle of this surface is a rough triangular elevation, the deltoid tuberosity, for the insertion of the deltoideus. Below this is the radial sulcus, directed obliquely from behind, forward, and downward, and transmitting the radial nerve and profunda artery. The anteromedial surface, less extensive than the anterolateral, is directed medialward above, forward and medialward below. Its upper part is narrow and forms the floor of the intertubercular groove, which gives insertion to the tendon of the latissimus dorsi. Its middle part is slightly rough for the attachment of some of the fibers of the tendon of insertion of the coracobrachialis. Its lower part is smooth, concave, from above downward, and gives origin to the brachialis. Footnote: a small hook-shaped process of bone, the supracondylar process, varying from 2 to 20 millimeters in length, is not infrequently found projecting from the anteromedial surface of the body of the humerus 5 centimeters above the medial epicondyle. It is curved downward and forward, and its pointed end is connected to the medial border just above the medial epicondyle by a fibrous band which gives origin to a portion of the pronator teres. Through the arch completed by this fibrous band, the median nerve and brachial artery pass, when these structures deviate from their usual course. Sometimes the nerve alone is transmitted through it, or the nerve may be accompanied by the ulnar artery, in cases of high division of the brachial. A well-marked groove is usually found behind the process, in which the nerve and artery are lodged. This arch is the homologue of the supracondylar foramen found in many animals, and probably serves in them to protect the nerve and artery from compression during the contraction of the muscles in this region. End of footnote. The posterior surface appears somewhat twisted, so that its upper part is directed a little medialward, its lower part backward, and a little lateralward. Nearly the whole of this surface is covered by the lateral and medial heads of the triceps brachii, the former arising above and the latter below the radial sulcus. The lower extremity. The lower extremity is flattened from before backward and curves slightly forward. It ends below in a broad articular surface which is divided into two parts by a slight ridge, projecting on either side of the lateral and medial epicondyles. The articular surface extends a little lower than the epicondyles and is curved slightly forward. Its medial extremity occupies a lower level than the lateral. The lateral portion of this surface consists of a smooth, rounded eminence named the capitellum of the humerus. It articulates with the cup-shaped depression on the head of the radius, and is limited to the front and lower part of the bone. On the medial side of this eminence is a shallow groove, in which is received the medial margin of the head of the radius. Above the part of the capitellum is a slight depression, the radial fossa, which receives the anterior border of the head of the radius when the forearm is flexed. The medial portion of the articular surface is named the trochlea, and presents a deep depression between the two well-marked borders. It is convex from before backward, concave from side to side, and occupies an anterior, lower, and posterior parts of the extremity. The lateral border separates it from the groove, which articulates with the margin of the head of the radius. The medial border is thicker, of greater length, and consequently more prominent than the lateral. The grooved portion of the articular surface fits accurately within the semilunar notch of the ulna. It is broader and deeper on the posterior than on the anterior aspect of the bone, and is inclined obliquely downward and forward towards the medial side. Above the front part of the trochlea is a small depression, the coronoid fossa, which receives the coronoid process of the ulna during flexion of the forearm. Above the back part of the trochlea is a deep triangular depression, the olecranon fossa, in which the summit of the olecranon is received in extension of the forearm. These fossa are separated from one another by a thin, transparent lamina of bone, which is sometimes perforated by the supratrochlear foramen. They are lined in the fresh state by the synovial membrane of the elbow joint, and their margins afford attachment to the anterior and posterior ligaments of this articulation. The lateral epicondyle is a small, tuberculated eminence, curved a little forward, and giving attachment to the radiocollateral ligament of the elbow joint, and to a tendon common to the origin of the supinator and some of the extensor muscles. The medial epicondyle, larger and more prominent than the lateral, is directed a little backward. It gives attachment to the ulnar collateral ligament of the elbow joint, to the pronator teres, and to a common tendon of origin of some of the flexor muscles of the forearm. The ulnar nerve runs in a groove on the back of this epicondyle. The epicondyles are continuous above with the supracondylar ridges. Structure. The extremities consist of cancellous tissue covered with a thin, compact layer. The body is composed of a cylinder of compact tissue, thicker at the center than towards the extremities, and contains a large medullary canal which extends along its whole length. Ossification. The humerus is ossified from 8 centers, one for each of the following parts: the body, the head, the greater tubercle, the lesser tubercle, the capitellum, the trochlea, and one for each epicondyle. The center for the body appears near the middle of the bone in the 8th week of fetal life, and soon extends towards the extremities. At birth, the humerus is ossified in nearly its whole length, only the extremities remaining cartilaginous. During the first year, sometimes before birth, ossification commences in the head of the bone, and during the 3rd year, the center for the greater tubercle, and during the 5th, that for the lesser tubercle, making their appearance. By the 6th year, the centers for the head and tubercles have joined, so as to form a single large epiphysis, which fuses with the body about the 20th year. The lower end of the humerus is ossified as follows. At the end of the 2nd year, ossification begins in the capitellum, and extends medialward to form the chief part of the articular end of the bone. The center for the medial part of the trochlea appears about the age of 12. Ossification begins in the medial epicondyle about the 5th year, and in the lateral about the 13th or 14th year. About the 16th or 17th year, the lateral epicondyle and both portions of the articulating surface, having already joined, unite with the body, and at the 18th year the medial epicondyle becomes joined to it. End of section 37.
Section 38 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Anne Walden. Anatomy of the Human Body, Part 1, by Henry Gray. Section 38. The Ulna, Elbow Bone. Footnote. In the anatomical position, the forearm is placed in extension and supination, with the palm looking forward and the thumb on the outer side. End footnote. The ulna is a long bone, prismatic in form, placed at the medial side of the forearm parallel with the radius. It is divisible into a body and 2 extremities. Its upper extremity, of great thickness and strength, forms a large part of the elbow joint. The bone diminishes in size from above downward, its lower extremity being very small and excluded from the wrist joint by the interposition of an articular disc. The upper extremity, proximal extremity. The upper extremity presents 2 curved processes, the olecranon and the coronoid process, and 2 concave articular cavities, the semilunar and radial notches. The olecranon, olecranon process. The olecranon is a large, thick, curved eminence situated at the upper and back part of the ulna. It is bent forward at the summit so as to present a prominent lip which is received into the olecranon fossa of the humerus in extension of the forearm. Its base is contracted where it joins the body and the narrowest part of the upper end of the ulna. Its posterior surface, directed backward, is triangular, smooth, subcutaneous, and covered by a bursa. Its superior surface is of quadrilateral form, marked behind by a rough impression for the insertion of the triceps brachii, and in front, near the margin, by a slight transverse groove for the attachment of part of the posterior ligament of the elbow joint. Its anterior surface is smooth, concave, and forms the upper part of the semilunar notch. Its borders present continuations of the groove on the margin of the superior surface. They serve for the attachment of ligaments, that is, the back part of the ulnar collateral ligament medially, and the posterior ligament laterally. From the medial border a part of the flexor carpi ulnaris arises, while to the lateral border the anconeus is attached. The coronoid process, processus coronoideus. The coronoid process is a triangular eminence projecting forward from the upper and front part of the ulna. Its base is continuous with the body of the bone and of considerable strength. Its apex is pointed, slightly curved upward, and in flexion of the forearm is received into the coronoid fossa of the humerus. Its upper surface is smooth, concave, and forms the lower part of the semilunar notch. Its antero-inferior surface is concave, and marked by a rough impression for the insertion of the brachialis. At the junction of this surface with the front of the body is a rough eminence, the tuberosity of the ulna, which gives insertion to a part of the brachialis. To the lateral border of this tuberosity the oblique cord is attached. Its lateral surface presents a narrow, oblong, articular depression, the radial notch. Its medial surface, by its prominent free margin, serves for the attachment of part of the ulnar collateral ligament. At the front part of this surface is a small rounded eminence for the origin of one head of the flexor digitorum sublimis. Behind the eminence is a depression for part of the origin of the flexor digitorum profundus. Descending from the eminence is a ridge which gives origin to one head of the pronator teres. Frequently the flexor pollicis longus arises from the lower part of the coronoid process by a rounded bundle of muscular fibers. The semilunar notch, incisura semilunaris, greater sigmoid cavity. The semilunar notch is a large depression formed by the olecranon and the coronoid process, and serving for articulation with the trochlea of the humerus. About the middle of either side of this notch is an indentation which contracts it somewhat and indicates the junction of the olecranon and the coronoid process. The notch is concave from above downward, and divided into a medial and a lateral portion by a smooth ridge running from the summit of the olecranon to the tip of the coronoid process. The medial portion is the larger, and is slightly concave transversely. The lateral is convex above, slightly concave below. The radial notch, incisura radialis, lesser sigmoid cavity. The radial notch is a narrow, oblong, articular depression on the lateral side of the coronoid process. It receives the circumferential articular surface of the head of the radius. It is concave from before backward, and its prominent extremities serve for the attachment of the annular ligament. The body or shaft, corpus ulnae. The body at its upper part is prismatic in form, and curved so as to be convex behind and lateralward. Its central part is straight, its lower part is rounded, smooth, and bent a little lateralward. It tapers gradually from above downward, and has 3 borders and 3 surfaces. Borders. The volar border, margo volaris, anterior border, begins above at the prominent medial angle of the coronoid process, and ends below in front of the styloid process. Its upper part, well defined, and its middle portion, smooth and rounded, give origin to the flexor digitorum profundus. Its lower fourth serves for the origin of the pronator quadratus. This border separates the volar from the medial surface. The dorsal border, margo dorsalis, posterior border, begins above at the apex of the triangular subcutaneous surface at the back part of the olecranon, and ends below at the back of the styloid process. It is well marked in the upper 3/4, and gives attachment to an aponeurosis which affords a common origin to the flexor carpi ulnaris, the extensor carpi ulnaris, and the flexor digitorum profundus. Its lower fourth is smooth and rounded. This border separates the medial from the dorsal surface. The interosseous crest, crista interossea, external or interosseous border, begins above by the union of 2 lines, which converge from the extremities of the radial notch, and enclose between them a triangular space for the origin of part of the supinator. It ends below at the head of the ulna. Its upper part is sharp, its lower fourth smooth and rounded. This crest gives attachment to the interosseous membrane, and separates the volar from the dorsal surface. Surfaces. The volar surface, facies volaris, anterior surface, much broader above than below, is concave in its upper 3/4, and gives origin to the flexor digitorum profundus. Its lower fourth, also concave, is covered by the pronator quadratus. The lower fourth is separated from the remaining portion by a ridge directed obliquely downward and medialward, which marks the extent of origin of the pronator quadratus. At the junction of the upper with the middle third of the bone is the nutrient canal, directed obliquely upward. The dorsal surface, facies dorsalis, posterior surface, directed backward and lateralward, is broad and concave above, convex and somewhat narrower in the middle, narrow, smooth, and rounded below. On its upper part is an oblique ridge which runs from the dorsal end of the radial notch downward to the dorsal border. The triangular surface above this ridge receives the insertion of the anconeus, while the upper part of the ridge affords attachment to the supinator. Below this the surface is subdivided by a longitudinal ridge, sometimes called the perpendicular line, into two parts. The medial part is smooth and covered by the extensor carpi ulnaris. The lateral portion, wider and rougher, gives origin from above downward to the supinator, the abductor pollicis longus, the extensor pollicis longus, and the extensor indicis proprius. The medial surface, facies medialis, internal surface, is broad and concave above, narrow and convex below. Its upper 3/4 give origin to the flexor digitorum profundus. Its lower fourth is subcutaneous. The lower extremity, distal extremity. The lower extremity of the ulna is small and presents two eminences. The lateral and larger is a rounded articular eminence, termed the head of the ulna. The medial, narrower and more projecting, is a non-articular eminence, the styloid process. The head presents an articular surface, part of which, of an oval or semilunar form, is directed downward, and articulates with the upper surface of the triangular articular disc which separates it from the wrist joint. The remaining portion, directed lateralward, is narrow, convex, and received into the ulnar notch of the radius. The styloid process projects from the medial and back part of the bone. It descends a little lower than the head, and its rounded end affords attachment to the ulnar collateral ligament of the wrist joint. The head is separated from the styloid process by a depression for the attachment of the apex of the triangular articular disc, and behind by a shallow groove for the tendon of the extensor carpi ulnaris. Structure. The long, narrow medullary cavity is enclosed in a strong wall of compact tissue, which is thickest along the interosseous border and dorsal surface. At the extremities the compact layer thins. The compact layer is continued onto the back of the olecranon as a plate of close, spongy bone with lamellae parallel. From the inner surface of this plate and the compact layer below it, trabeculi arch forward toward the olecranon and coronoid, and cross other trabeculi, passing backward over the medullary cavity from the upper part of the shaft below the coronoid. Below the coronoid process there is a small area of compact bone from which trabeculi curve upward to end obliquely to the surface of the semilunar notch, which is coated with a thin layer of compact bone. The trabeculi at the lower end have a more longitudinal direction. Ossification. The ulna is ossified from three centers, one each for the body, the inferior extremity, and the top of the olecranon. Ossification begins near the middle of the body, about the 8th week of fetal life, and soon extends through the greater part of the bone. At birth the ends are cartilaginous. About the 4th year, a center appears in the middle of the head, and soon extends into the styloid process. About the 10th year, a center appears in the olecranon near its extremity, the chief part of this process being formed by an upward extension of the body. The upper epiphysis joins the body about the 16th, the lower about the 20th year. Articulations. The ulna articulates with the humerus and radius. End of section 38. Section 39 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Recorded by Laurie Anne Walden. Anatomy of the Human Body, Part 1, by Henry Gray. The radius. The radius is situated on the lateral side of the ulna, which exceeds it in length and size. Its upper end is small and forms only a small part of the elbow joint, but its lower end is large and forms the chief part of the wrist joint. It is a long bone, prismatic in form and slightly curved longitudinally. It has a body and two extremities. The upper extremity, proximal extremity. The upper extremity presents a head, neck, and tuberosity. The head is of a cylindrical form, and on its upper surface is a shallow cup or fovea for articulation with the capitulum of the humerus. The circumference of the head is smooth. It is broad medially where it articulates with the radial notch of the ulna, narrow in the rest of its extent, which is embraced by the annular ligament. The head is supported on a round, smooth, and constricted portion called the neck, on the back of which is a slight ridge for the insertion of part of the supinator. Beneath the neck, on the medial side, is an eminence, the radial tuberosity. Its surface is divided into a posterior rough portion, for the insertion of the tendon of the biceps brachii, and an anterior smooth portion, on which a bursa is interposed between the tendon and the bone. The body or shaft, corpus radii. The body is prismoid in form, narrower above than below, and slightly curved, so as to be convex lateralward. It presents 3 borders and 3 surfaces. Borders. The volar border, margo volaris, anterior border, extends from the lower part of the tuberosity above to the anterior part of the base of the styloid process below, and separates the volar from the lateral surface. Its upper third is prominent, and from its oblique direction has received the name of the oblique line of the radius. It gives origin to the flexor digitorum sublimis and flexor pollicis longus. The surface above the line gives insertion to part of the supinator. The middle third of the volar border is indistinct and rounded. The lower fourth is prominent, and gives insertion to the pronator quadratus and attachment to the dorsal carpal ligament. It ends in a small tubercle, into which the tendon of the brachioradialis is inserted. The dorsal border, margo dorsalis, posterior border, begins above at the back of the neck, and ends below at the posterior part of the base of the styloid process. It separates the posterior from the lateral surface. It is indistinct above and below, but well marked in the middle third of the bone. The interosseous crest, crista interossea, internal or interosseous border, begins above at the back part of the tuberosity, and its upper part is rounded and indistinct. It becomes sharp and prominent as it descends, and at its lower part divides the 2 ridges which are continued to the anterior and posterior margins of the ulnar notch. To the posterior of the 2 ridges the lower part of the interosseous membrane is attached, while the triangular surface between the ridges gives insertion to part of the pronator quadratus. This crest separates the volar from the dorsal surface, and gives attachment to the interosseous membrane. Surface. The volar surface, facies volaris, anterior surface, is concave in its upper 3/4, and gives origin to the flexor pollicis longus. It is broad and flat in its lower fourth, and affords insertion to the pronator quadratus. A prominent ridge limits the insertion of the pronator quadratus below, and between this and the inferior border is a triangular rough surface for the attachment of the volar radiocarpal ligament. At the junction of the upper and middle thirds of the volar surface is the nutrient foramen, which is directed obliquely upward. The dorsal surface, facies dorsalis, posterior surface, is convex and smooth in the upper third of its extent, and covered by the supinator. Its middle third is broad, slightly concave, and gives origin to the abductor pollicis longus above, and the extensor pollicis brevis below. Its lower third is broad, convex, and covered by the tendons of the muscles which subsequently run in the grooves on the lower end of the bone. The lateral surface, facies lateralis, external surface, is convex throughout its entire extent. Its upper third gives insertion to the supinator. About its center is a rough ridge for the insertion of the pronator teres. Its lower part is narrow and covered by the tendons of the abductor pollicis longus and extensor pollicis brevis. The lower extremity. The lower extremity is large, of quadrilateral form, and provided with 2 articular surfaces, one below for the carpus, and another at the medial side for the ulna. The carpal articular surface is triangular, concave, smooth, and divided by a slight antero-posterior ridge into 2 parts. Of these, the lateral triangular articulates with the navicular bone, the medial quadrilateral with the lunate bone. The articular surface for the ulna is called the ulnar notch (sigmoid cavity) of the radius. It is narrow, concave, smooth, and articulates with the head of the ulna. These two articular surfaces are separated by a prominent ridge, to which the base of the triangular articular disc is attached. This disc separates the wrist joint from the distal radio-ulnar articulation. This end of the bone has three non-articular surfaces, volar, dorsal, and lateral. The volar surface, rough and irregular, affords attachment to the volar radiocarpal ligament. The dorsal surface is convex, affords attachment to the dorsal radiocarpal ligament, and is marked by three grooves. Enumerated from the lateral side, the first groove is broad but shallow, and subdivided into two by a slight ridge. The lateral of these two transmits the tendon of the extensor carpi radialis longus; the medial, the tendon of the extensor carpi radialis brevis. The second is deep but narrow, and bounded laterally by a sharply defined ridge. It is directed obliquely from above downward and lateralward, and transmits the tendon of the extensor pollicis longus. The third is broad for the passage of the tendons of the extensor indicis proprius and extensor digitorum communis. The lateral surface is prolonged obliquely downward into a strong conical projection, the styloid process, which gives attachment by its base to the tendon of the brachioradialis, and by its apex to the radial collateral ligament of the wrist joint. The lateral surface of this process is marked by a flat groove for the tendons of the abductor pollicis longus and extensor pollicis brevis. Structure. The long, narrow medullary cavity is enclosed in a strong wall of compact tissue which is thickest along the interosseous border, and thinnest at the extremities, except over the cup-shaped articular surface, fovea, of the head, where it is thickened. The trabeculi of the spongy tissue are somewhat arched at the upper end, and pass upward from the compact layer of the shaft to the fovea capituli. They are crossed by others parallel to the surface of the fovea. The arrangement at the lower end is somewhat similar. Ossification. The radius is ossified from three centers, one for the body and one for either extremity. That for the body makes its appearance near the center of the bone during the 8th week of fetal life. About the end of the 2nd year ossification commences in the lower end, and at the 5th year in the upper end. The upper epiphysis fuses with the body at the age of 17 or 18 years, the lower about the age of 20. An additional center sometimes found in the radial tuberosity appears about the 14th or 15th year. End of section 39.
Section 40 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 1, by Henry Gray. 6b. The Hand, Part 1, the Carpus. The skeleton of the hand is subdivided into three segments: the carpus or wrist bones, the metacarpus or bones of the palm, and the phalanges or bones of the digits. The carpus, ossa carpi. The carpal bones, 8 in number, are arranged in 2 rows. Those of the proximal row, from the radial to the ulnar side, are named the navicular, lunate, triangular, and pisiform. Those of the distal row, in the same order, are named the greater multangular, lesser multangular, capitate, and hamate. Common characteristics of the carpal bones. Each bone, excepting the pisiform, presents 6 surfaces. Of these, the volar or anterior and the dorsal or posterior surfaces are rough for ligamentous attachment, the dorsal surfaces being the broader, except in the navicular and lunate. The superior or proximal and inferior or distal surfaces are articular, the superior generally convex, the inferior concave. The medial and lateral surfaces are also articular where they are in contact with the contiguous bones, otherwise they are rough and tuberculated. The structure in all is similar, viz., cancellous tissue enclosed in a layer of compact bone. Bones of the proximal row, upper row. The navicular bone, os navicular manus, scaphoid bone. The navicular bone is the largest bone of the proximal row and has received its name from its fancied resemblance to a boat. It is situated at the radial side of the carpus, its long axis being from above downward, lateralward, and forward. The superior surface is convex, smooth, of triangular shape, and articulates with the lower end of the radius. The inferior surface, directed downward, lateralward, and backward, is also smooth, convex, and triangular, and is divided by a slight ridge into two parts, the lateral articulating with the greater multangular, the medial with the lesser multangular. On the dorsal surface is a narrow, rough groove which runs the entire length of the bone and serves for the attachment of ligaments. The volar surface is concave above and elevated at its lower and lateral part into a rounded projection, the tubercle, which is directed forward and gives attachment to the transverse carpal ligament and sometimes origin to a few fibers of the abductor pollicis brevis. The lateral surface is rough and narrow, and gives attachment to the radial collateral ligament of the wrist. The medial surface presents two articular facets. Of these, the superior or smaller is flattened of semilunar form and articulates with the lunate bone. The inferior or larger is concave, forming with the lunate a concavity for the head of the capitate bone. Articulations. The navicular articulates with 5 bones, the radius proximally, greater and lesser multangulars distally, and capitate and lunate medially. The lunate bone, os lunatum, semilunar bone. The lunate bone may be distinguished by its deep concavity and crescentic outline. It is situated in the center of the proximal row of the carpus, between the navicular and triangular. The superior surface, convex and smooth, articulates with the radius. The inferior surface is deeply concave, and of greater extent from before backward than transversely. It articulates with the head of the capitate, and by a long narrow facet, separated by a ridge from the general surface, with the haemate. The dorsal and volar surfaces are rough for the attachment of ligaments, the former being the broader and of a somewhat rounded form. The lateral surface presents a narrow, flattened, semilunar facet for articulation with the navicular. The medial surface is marked by a smooth, quadrilateral facet for articulation with the triangular. Articulations. The lunate articulates with 5 bones, the radius proximally, capitate and haemate distally, navicular laterally, and triangular medially. The triangular bone, os tricatum, cuneiform bone. The triangular bone may be distinguished by its pyramidal shape, and by an oval isolated facet for articulation with the pisiform bone. It is situated at the upper and ulnar side of the carpus. The superior surface presents a medial, rough, non-articular portion, and a lateral convex articular portion which articulates with the triangular articular disc of the wrist. The inferior surface, directed lateralward, is concave, sinuously curved, and smooth for articulation with the haemate. The dorsal surface is rough for the attachment of ligaments. The volar surface presents, on its medial part, an oval facet for articulation with the pisiform. Its lateral part is rough for ligamentous attachment. The lateral surface, the base of the pyramid, is marked by a flat, quadrilateral facet for articulation with the lunate. The medial surface, the summit of the pyramid, is pointed and roughened for the attachment of the ulnar collateral ligament of the wrist. Articulations. The triangular articulates with 3 bones: the lunate laterally, the pisiform in front, the hamate distally, and with the triangular articular disc which separates it from the lower end of the ulna. The pisiform bone, os pisiform. The pisiform bone may be known by its small size and by its presenting a single articular facet. It is situated on a plane anterior to the other carpal bones, and is spheroidal in form. Its dorsal surface presents a smooth, oval facet for articulation with the triangular. This facet approaches the superior, but not the inferior border of the bone. The volar surface is rounded and rough, and gives attachment to the transverse carpal ligament, and to the flexor carpi ulnaris and abductor digiti quinti. The lateral and medial surfaces are also rough, the former being concave, the latter usually convex. Articulation. The pisiform articulates with 1 bone, the triangular. Bones of the distal row, lower row. The greater multangular bone, os multangulum majus. Trapezium. The greater multangular bone may be distinguished by a deep groove on its volar surface. It is situated at the radial side of the carpus, between the navicular and the first metacarpal bone. The superior surface is directed upward and medialward. Medially it is smooth, and articulates with the navicular. Laterally it is rough, and continuous with the lateral surface. The inferior surface is oval, concave from side to side, convex from before backward, so as to form a saddle-shaped surface for articulation with the base of the first metacarpal bone. The dorsal surface is rough, the volar surface is narrow and rough. At its upper part is a deep groove, running from above obliquely downward and medialward. It transmits the tendon of the flexor carpi radialis, and is bounded laterally by an oblique ridge. This surface gives origin to the opponens pollicis and to the abductor and flexor pollicis brevis. It also affords attachment to the transverse carpal ligament. The lateral surface is broad and rough for the attachment of ligaments. The medial surface presents 2 facets. The upper, large and concave, articulates with the lesser multangular. The lower, small and oval, with the base of the second metacarpal. Articulations. The greater multangular articulates with 4 bones: the navicular proximally, the first metacarpal distally, and the lesser multangular and second metacarpal medially. The lesser multangular bone, os multangulum minus, trapezoid bone. The lesser multangular is the smallest bone in the distal row. It may be known by its wedge-shaped form, the broad end of the wedge constituting the dorsal, the narrow end the volar surface, and by its having 4 articular facets touching each other, and separated by sharp edges. The superior surface, quadrilateral, smooth, and slightly concave, articulates with the navicular. The inferior surface articulates with the proximal end of the second metacarpal bone. It is convex from side to side, concave from before backward, and subdivided by an elevated ridge into 2 unequal facets. The dorsal and volar surfaces are rough for the attachment of ligaments, the former being the larger of the 2. The lateral surface, convex and smooth, articulates with the greater multangular. The medial surface is concave and smooth in front, for articulation with the capitate; rough behind, for the attachment of an interosseous ligament. Articulations. The lesser multangular articulates with 4 bones: the navicular proximally, second metacarpal distally, greater multangular laterally, and capitate medially. The capitate bone, os capitatum, os magnum. The capitate bone is the largest of the carpal bones, and occupies the centre of the wrist. It presents, above, a rounded portion or head, which is received into the concavity formed by the navicular and lunate; a constricted portion or neck, and below this the body. The superior surface is round, smooth, and articulates with the lunate. The inferior surface is divided by 2 ridges into 3 facets, for articulation with the second, third, and fourth metacarpal bones, that for the third being the largest. The dorsal surface is broad and rough. The volar surface is narrow, rounded, and rough for the attachment of ligaments, and a part of the adductor pollicis obliquus. The lateral surface articulates with the lesser multangular by a small facet at its anterior inferior angle, behind which is a rough depression for the attachment of an interosseous ligament. Above this is a deep, rough groove, forming part of the neck, and serving for the attachment of ligaments. It is bounded superiorly by a smooth, convex surface for articulation with the navicular. The medial surface articulates with the hamate by a smooth, concave, oblong facet, which occupies its posterior and superior parts. It is rough in front for the attachment of an interosseous ligament. Articulations. The capitate articulates with 7 bones: the navicular and lunate proximally, the second, third, and fourth metacarpals distally, the lesser multangular on the radial side, and the hamate on the ulnar side. The hamate bone, os hamatum, unciform bone. The hamate bone may be readily distinguished by its wedge-shaped form and the hook-like process which projects from its volar surface. It is situated at the medial and lower angle of the carpus, with its base downward, resting on the fourth and fifth metacarpal bones, and its apex directed upward and lateralward. The superior surface, the apex of the wedge, is narrow, convex, smooth, and articulates with the lunate. The inferior surface articulates with the fourth and fifth metacarpal bones by concave facets which are separated by a ridge. The dorsal surface is triangular and rough for ligamentous attachment. The volar surface presents, at its lower and ulnar side, a curved, hook-like process, the hamulus, directed forward and lateralward. This process gives attachment, by its apex, to the transverse carpal ligament and the flexor carpi ulnaris, by its medial surface to the flexor brevis and opponens digiti quinti. Its lateral side is grooved for the passage of the flexor tendons into the palm of the hand. It is one of the 4 eminences on the front of the carpus to which the transverse carpal ligament of the wrist is attached, the others being the pisiform medially, the oblique ridge of the greater multangular, and the tubercle of the navicular laterally. The medial surface articulates with the triangular bone by an oblong facet, cut obliquely from above, downward, and medialward. The lateral surface articulates with the capitate by its upper and posterior part, the remaining portion being rough for the attachment of ligaments. Articulations. The hamate articulates with 5 bones: the lunate proximally, the fourth and fifth metacarpals distally, the triangular medially, the capitate laterally. End of section 40. Recording by Leanne Howlett. Section 41 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit Librivox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 1, by Henry Gray. 6b, Part 2, the Metacarpus. The metacarpus consists of 5 cylindrical bones which are numbered from the lateral side, ossa metacarpalia 1 through 5. Each consists of a body and 2 extremities. Common characteristics of the metacarpal bones. The body, corpus, shaft. The body is prismoid in form and curved so as to be convex in the longitudinal direction behind, concave in front. It presents 3 surfaces: medial, lateral, and dorsal. The medial and lateral surfaces are concave for the attachment of the interossei, and separated from one another by a prominent anterior ridge. The dorsal surface presents in its distal 2/3 a smooth, triangular, flattened area which is covered in the fresh state by the tendons of the extensor muscles. This surface is bounded by two lines which commence in small tubercles situated on either side of the digital extremity, and passing upward, converge and meet some distance above the centre of the bone and form a ridge which runs along the rest of the dorsal surface to the carpal extremity. This ridge separates two sloping surfaces for the attachment of the interossei dorsalis. To the tubercles on the digital extremities are attached the collateral ligaments of the metacarpophalangeal joints. The base or carpal extremity (basis) is of a cuboidal form, and broader behind than in front. It articulates with the carpus and with the adjoining metacarpal bones. Its dorsal and volar surfaces are rough for the attachment of ligaments. The head or digital extremity (capitulum) presents an oblong surface markedly convex from before backward, less so transversely, and flattened from side to side. It articulates with the proximal phalanx. It is broader and extends farther upward on the volar than on the dorsal aspect, and is longer in the antero-posterior than in the transverse diameter. On either side of the head is a tubercle for the attachment of the collateral ligament of the metacarpophalangeal joint. The dorsal surface, broad and flat, supports the extensor tendons. The volar surface is grooved in the middle line for the passage of the flexor tendons, and marked on either side by an articular eminence continuous with the terminal articular surface. Characteristics of the individual metacarpal bones. The first metacarpal bone, os metacarpale 1, metacarpal bone of the thumb, is shorter and stouter than the others, diverges to a greater degree from the carpus, and its volar surface is directed toward the palm. The body is flattened and broad on its dorsal surface, and does not present the ridge which is found on the other metacarpal bones. Its volar surface is concave from above downward. On its radial border is inserted the Apennine pollicis. Its ulnar border gives origin to the lateral head of the first interosseous dorsalis. The base presents a concavo-convex surface for articulation with the greater multangulum. It has no facets on its sides, but on its radial side is a tubercle for the insertion of the abductor pollicis longus. The head is less convex than those of the other metacarpal bones, and is broader from side to side than from before backward. On its volar surface are two articular eminences, of which the lateral is the larger, for the two sesamoid bones in the tendons of the flexor pollicis brevis. The second metacarpal bone, os metacarpale 2, metacarpal bone of the index finger, is the longest, and its base the largest of the four remaining bones. Its base is prolonged upward and medialward, forming a prominent ridge. It presents four articular facets, three on the upper surface and one on the ulnar side. Of the facets on the upper surface, the intermediate is the largest, and is concave from side to side, convex from before backward for articulation with the lesser multangulum. The lateral is small, flat, and oval for articulation with the greater multangulum. The medial, on the summit of the ridge, is long and narrow for articulation with the capitate. The facet on the ulnar side articulates with a third metacarpal. The extensor carpi radialis longus is inserted on the dorsal surface and the flexor carpi radialis on the volar surface of the base. The third metacarpal bone, os metacarpale 3, metacarpal bone of the middle finger, is a little smaller than the second. The dorsal aspect of its base presents on its radial side a pyramidal eminence, the styloid process, which extends upward behind the capitate. Immediately distal to this is a rough surface for the attachment of the extensor carpi radialis brevis. The carpal articular facet is concave behind, flat in front, and articulates with the capitate. On the radial side is a smooth concave facet for articulation with the second metacarpal, and on the ulnar side two small oval facets for the fourth metacarpal. The fourth metacarpal bone, os metacarpale 4, metacarpal bone of the ring finger, is shorter and smaller than the third. The base is small and quadrilateral. Its superior surface presents two facets, a large one medially for articulation with the hamate, and a small one laterally for the capitate. On the radial side are two oval facets, for articulation with the third metacarpal, and on the ulnar side a single concave facet for the fifth metacarpal. The fifth metacarpal bone, os metacarpale 5, metacarpal bone of the little finger, presents on its base one facet on its superior surface, which is concavo-convex and articulates with the hamate, and one on its radial side, which articulates with the fourth metacarpal. On its ulnar side is a prominent tubercle for the insertion of the tendon of the extensor carpi ulnaris. The dorsal surface of the body is divided by an oblique ridge, which extends from near the ulnar side of the base to the radial side of the head. The lateral part of this surface serves for the attachment of the fourth interosseous dorsalis. The medial part is smooth, triangular, and covered by the extensor tendons of the little finger. Articulations. Besides their phalangeal articulations, the metacarpal bones articulate as follows: the first with the greater multangular, the second with the greater multangular, lesser multangular, capitate and third metacarpal, the third with the capitate and second and fourth metacarpals, the fourth with the capitate, hamate, and third and fifth metacarpals, and the fifth with the hamate and fourth metacarpal. End of section 41. Recording by Leanne Howlett.
Section 42 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 1, by Henry Gray. The Phalanges of the Hand. Phalanges digitorum manus. The phalanges are 14 in number, 3 for each finger and 2 for the thumb. Each consists of a body and 2 extremities. The body tapers from above downward, is convex posteriorly, concave in front from above downward, flat from side to side. Its sides are marked by ruff, which give attachment to the fibrous sheaths of the flexor tendons. The proximal extremities of the bones of the first row present oval, concave articular surfaces, broader from side to side than from before backward. The proximal extremity of each of the bones of the second and third rows present a double concavity separated by a median ridge. The distal extremities are smaller than the proximal, and each ends in 2 condyles separated by a shallow groove. The articular surface extends farther on the volar than on the dorsal surface, a condition best marked in the bones of the first row. The ungual phalanges are convex on their dorsal and flat on their volar surfaces. They are recognized by their small size, and by a roughened, elevated surface of a horseshoe form on the volar surface of the distal extremity of each, which serves to support the sensitive pulp of the finger. Articulations. In the forefingers, the phalanges of the first row articulate with those of the second row, and with the metacarpals. The phalanges of the second row with those of the first and third rows, and the ungual phalanges with those of the second row. In the thumb, which has only 2 phalanges, the first phalanx articulates by its proximal extremity with the metacarpal bone, and by its distal with the ungual phalanx. Ossification of the bones of the hand. The carpal bones are each ossified from a single center, and ossification proceeds in the following order: in the capitate and hamate during the first year, the former preceding the latter; in the triangular during the third year; in the lunate and greater multangular during the 5th year, the former preceding the latter; in the navicular during the 6th year; in the lesser multangular during the 8th year, and in the pisiform about the 12th year. Occasionally an additional bone, the os central, is found on the back of the carpus, lying between the navicular, less multangular, and capitate. During the second month of fetal life it is represented by a small cartilaginous nodule, which usually fuses with the cartilaginous navicular. Sometimes the styloid process of the third metacarpal is detached and forms an additional ossicle. The metacarpal bones are each ossified from two centers, one for the body and one for the distal extremity of each of the second, third, fourth, and fifth bones, one for the body and one for the base of the first metacarpal bone. The first metacarpal bone is therefore ossified in the same manner as the phalanges, and this has led some anatomists to regard the thumb as being made up of 3 phalanges, and not of a metacarpal bone and 2 phalanges. Ossification commences in the middle of the body about the 8th or 9th week of fetal life, the centers for the second and third metacarpals being the first, and that for the first metacarpal the last to appear. About the 3rd year the distal extremities of the metacarpals of the fingers and the base of the metacarpal of the thumb begins to ossify. They unite with the bodies about the 20th year. The phalanges are each ossified from 2 centers, one for the body and one for the proximal extremity. Ossification begins in the body about the 8th week of fetal life. Ossification of the proximal extremity commences in the bones of the first row between the 3rd and 4th years, and a year later in those of the 2nd and 3rd rows. The 2 centers become united in each row between the 18th and 20th years. In the ungual phalanges, the centers of the body appear in the distal extremities of the phalanges, instead of the middle of the bodies, as in the other phalanges. Moreover, of all the bones in the hand, the ungual phalanges are the first to ossify. Footnote: Alan Thompson demonstrated the fact that the first metacarpal bone is often developed from 3 centers. That is to say, there is a separate nucleus for the distal end, forming a distinct epiphysis visible at the age of 7 or 8 years. He also stated that there are traces of a proximal epiphysis in the second metacarpal bone. End footnote. End of section 42. Recording by David Lawrence, Brampton, Ontario, September 2008.
Section 43 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body by Henry Gray, Part 1. Chapter 6c. The Bones of the Lower Extremity, Section 1. The Hip Bone. Ossa extremitatis inferioris and os coxae innominate bone. The hip bone is a large, flattened, irregularly shaped bone, constricted in the center and expanded above and below. It meets its fellow on the opposite side in the middle line in front, and together they form the sides and anterior wall of the pelvic cavity. It consists of 3 parts, the ilium, ischium, and pubis, which are distinct from each other in the young subject, but are fused in the adult. The union of the 3 parts takes place in and around a large, cuff-shaped articular cavity, the acetabulum, which is situated near the middle of the outer surface of the bone. The ilium, so called because it supports the flank, is the superior, broad, and expanded portion which extends upward from the acetabulum. The ischium is the lowest and strongest portion of the bone. It proceeds downward from the acetabulum, expands into a large tuberosity, and then, curving forward, forms with the pubis a large aperture, the obturator foramen. The pubis extends medialward and downward from the acetabulum, and articulates in the middle line with the bone of the opposite side. It forms the front of the pelvis, and supports the external organs of generation. The ilium, os ilii. The ilium is divisible into 2 parts, the body and the ala. The separation is indicated on the internal surface by a curved line, the arcuate line, and on the external surface by the margin of the acetabulum. The body, corpus os ilii. The body enters into the formation of the acetabulum, of which it forms rather less than 2/5. Its external surface is partly articular, partly non-articular. The articular segment forms part of the lunate surface of the acetabulum. The non-articular portion contributes to the acetabular fossa. The internal surface of the body is part of the wall of the lesser pelvis and gives origin to some fibers of the obturator internus. Below it is continuous with the pelvic surfaces of the ischium and pubis, only a faint line indicating the place of union. The ala os ilii. The ala is the large expanded portion which bounds the greater pelvis laterally. It presents for examination two surfaces, an external and an internal, a crest and two borders, an anterior and a posterior. The external surface, known as the dorsum ilii, is directed backward and lateralward behind, and downward and lateralward in front. It is smooth, convex in front, deeply concave behind, bounded above by the crest, below by the upper border of the acetabulum, in front and behind by the anterior and posterior borders. This surface is crossed in an arched direction by three lines, the posterior, anterior, and inferior gluteal lines. The posterior gluteal line, superior curved line, the shortest of the three, begins at the crest about 5 centimeters in front of its posterior extremity. It is at first distinctly marked, but as it passes downward to the upper part of the greater sciatic notch where it ends, it becomes less distinct and is often altogether lost. Behind this line is a narrow semilunar surface, the upper part of which is rough and gives origin to a portion of the gluteus maximus. The lower part is smooth and has no muscular fibers attached to it. The anterior gluteal line, the middle curved line, the longest of the three, begins at the crest about 4 centimeters behind its anterior extremity, and, taking a curved direction downward and backward, ends at the upper part of the greater sciatic notch. The space between the anterior and posterior gluteal lines and the crest is concave, and gives origin to the gluteus medius. Near the middle of this line a nutrient foramen is often seen. The inferior gluteal line, inferior curved line, the least distinct of the three, begins in front at the notch on the anterior border, and curving backward and downward, ends near the middle of the greater sciatic notch. The surface of bone included between the anterior and inferior gluteal lines is concave from above downward, convex from before backward, and gives origin to the gluteus minimus. Between the inferior gluteal line and the upper part of the acetabulum is a rough, shallow groove, from which the reflected tendon of the rectus femoris arises. The internal surface of the ala is bounded above by the crest, below by the arcuate line, in front and behind by the anterior and posterior borders. It presents a large, smooth, concave surface called the iliac fossa, which gives origin to the iliacus and is perforated at its inner part by a nutrient canal, and below this a smooth, rounded border, the arcuate line, which runs downward, forward, and medialward. Behind the iliac fossa is a rough surface divided into two portions, an anterior and a posterior. The anterior surface, auricular surface, so called from its resemblance in shape to the ear, is coated with cartilage in the fresh state, and articulates with a similar surface on the side of the sacrum. The posterior portion, known as the iliac tuberosity, is elevated and rough for the attachment of the posterior sacroiliac ligaments, and for the origins of the sacrospinalis and multifidus. Below and in front of the auricular surface is the preauricular sulcus, more commonly present and better marked in the female than in the male. To it is attached the pelvic portion of the anterior sacroiliac ligament. The crest of the ilium is convex in its general outline, but is sinuously curved, being concave inward in front, concave outward behind. It is thinner at the center than at the extremities, and ends in the anterior and posterior superior iliac spines. The surface of the crest is broad and divided into external and internal lips, and an intermediate line. About 5 centimeters behind the anterior superior iliac spine, there is a prominent tubercle on the outer lip. To the external lip are attached the tensor fasciae latae, obliquus externus abdominis, and latissimus dorsi, and along its whole length the fascia lata. To the intermediate line the obliquus internus abdominis, to the internal lip the fascia iliaca, the transverse abdominis, quadratus lumborum, sacrospinalis, and iliacus. The anterior border of the ala is concave. It presents two projections separated by a notch. Of these, the uppermost, situated at the junction of the crest and anterior border, is called the anterior superior iliac spine. Its outer border gives attachment to the fascia lata and the tensor fasciae latae, its inner border to the iliacus, while its extremity affords attachment to the inguinal ligament and gives origin to the sartorius. Beneath this eminence is a notch from which the sartorius takes origin and across which the lateral femoral cutaneous nerve passes. Below the notch is the anterior inferior iliac spine, which ends in the upper lip of the acetabulum. It gives attachment to the straight tendon of the rectus femoris and to the iliofemoral ligament of the hip joint. Medial to the anterior inferior spine is a broad, shallow groove over which the iliacus and psoas major pass. This groove is bounded medially by an eminence, the iliopectineal eminence, which marks the point of union of the ilium and pubis. The posterior border of the ala, shorter than the anterior, also presents two projections separated by a notch, the posterior superior iliac spine and the posterior inferior iliac spine. The former serves for the attachment of the oblique portion of the posterior sacroiliac ligaments and the multifidus. The latter corresponds with the posterior extremity of the auricular surface. Below the posterior inferior spine is a deep notch, the greater sciatic notch. The ischium, os ischii. The ischium forms the lower and back part of the hip bone. It is divisible into three portions, a body and two rami. The body, corpus os ischii. The body enters into and constitutes a little more than 2/5 of the acetabulum. Its external surface forms part of the lunate surface of the acetabulum and a portion of the acetabular fossa. Its internal surface is part of the wall of the lesser pelvis. It gives origin to some fibers of the obturator internus. Its anterior border projects as the posterior obturator tubercle. From its posterior border there extends backward a thin and pointed triangular eminence, the ischial spine, more or less elongated in different subjects. The external surface of the spine gives attachment to the gemellus superior, its internal surface to the coccygeus, levator ani, and the pelvic fascia, while to the pointed extremity the sacrospinous ligament is attached. Above the spine is a large notch, the greater sciatic notch. Converted into a foramen by the sacrospinous ligament, it transmits the piriformis, the superior and inferior gluteal vessels and nerves, the sciatic and posterior femoral cutaneous nerves, the internal pudendal vessels and nerve, and the nerves to the obturator internus and quadratus femoris. Of these, the superior gluteal vessels and nerve pass out above the piriformis, other structures below it. Below the spine is a smaller notch, the lesser sciatic notch. It is smooth, coated in the recent state with cartilage, the surface of which presents 2 or 3 ridges corresponding to the subdivisions of the tendon of the obturator internus, which winds over it. It is converted into a foramen by the sacrotuberous and sacrospinous ligaments, and transmits the tendon of the obturator internus, the nerve which supplies that muscle, and the internal pudendal vessels and nerve. The superior ramus, ramus superior os ischii, descending ramus. The superior ramus projects downward and backward from the body, and presents for examination 3 surfaces: external, internal, and posterior. The external surface is quadrilateral in shape. It is bounded above by a groove which lodges the tendon of the obturator externus. Below is continuous with the inferior ramus. In front it is limited by the posterior margin of the obturator foramen. Behind, a prominent margin separates it from the posterior surface. In front of this margin, the surface gives origin to the quadratus femoris, and anterior to this, to some of the fibers of origin of the obturator externus. The lower part of the surface gives origin to part of the adductor magnus. The internal surface forms part of the bony wall of the lesser pelvis. In front, it is limited by the posterior margin of the obturator foramen. Below, it is bounded by a sharp ridge, which gives attachment to a falciform prolongation of the sacrotuberous ligament, and, more anteriorly, gives origin to the transversus perenni and ischiocavernosus. Posteriorly, the ramus forms a large swelling, the tuberosity of the ischium, which is divided into two portions, a lower, rough, somewhat triangular part, and an upper, smooth, quadrilateral portion. The lower portion is subdivided by a prominent longitudinal ridge, passing from base to apex, into two parts. The outer gives attachment to the adductor magnus, the inner to the sacrotuberous ligament. The upper portion is subdivided into two areas by an oblique ridge, which runs downward and outward. From the upper and outer area, the semimembranosus arises. From the lower and inner, the long head of the biceps femoris and the semitendinosus. The inferior ramus, ramus inferior ossicii, ascending ramus. The inferior ramus is the thin, flattened part of the ischium, which ascends from the superior ramus and joins the inferior ramus of the pubis, the junction being indicated in the adult by a raised line. The outer surface is uneven for the origin of the obturator externus and some of the fibers of the adductor magnus. Its inner surface forms part of the anterior wall of the pelvis. Its medial border is thick, rough, slightly everted, forms part of the outlet of the pelvis, and presents two ridges and an intervening space. The ridges are continuous with similar ones on the inferior ramus of the pubis. To the outer is attached the deep layer of the superficial perineal fascia, fascia of Colles, and to the inner the inferior fascia of the urogenital diaphragm. If these two ridges be traced downward, they will be found to join with each other just behind the point of origin of the transversus perenni. Here the two layers of the fascia are continuous behind the posterior border of the muscle. To the intervening space, just in front of the point of origin of the ridges, the transversus perenni is attached, and in front of this a portion of the crus penis vel clitoridis and the ischiocavernosus. Its lateral border is thin and sharp and forms part of the medial margin of the obturator foramen. The pubis, os pubis. The pubis, the anterior part of the hip bone, is divisible into a body, a superior, and an inferior ramus. The body, corpus os pubis. The body forms 1/5 of the acetabulum, contributing by its external surface both to the lunate surface and the acetabular fossa. Its internal surface enters into the formation of the wall of the lesser pelvis and gives origin to a portion of the obturator internus. The superior ramus, ramus superior os pubis, ascending ramus. The superior ramus extends from the body to the median plane where it articulates with its fellow of the opposite side. It is conveniently described in two portions, viz. A medial flattened part and a narrow lateral prismoidal portion. The medial portion of the superior ramus, formerly described as the body of the pubis, is somewhat quadrilateral in shape, and presents for examination two surfaces and three borders. The anterior surface is rough, directed downward and outward, and serves for the origin of various muscles. The adductor longus arises from the upper and medial angle, immediately below the crest. Lower down, the obturator externus, the adductor brevis, and the upper part of the gracilis take origin. The posterior surface, convex from above downward, concave from side to side, is smooth and forms part of the anterior wall of the pelvis. It gives origin to the levator ani and obturator internus, and attachment to the puboprostatic ligaments and to a few muscular fibers prolonged from the bladder. The upper border presents a prominent tubercle, the pubic tubercle, pubic spine, which projects forward, The inferior crus of the subcutaneous inguinal ring, external abdominal ring, and the inguinal ligament, Poupart's ligament, are attached to it. Passing upward and lateralward from the pubic tubercle is a well-defined ridge, forming a part of the pectineal line, which marks the brim of the lesser pelvis. To it are attached a portion of the inguinal falx, conjoined tendon of obliquus internus and transversus, the lacunar ligament, Gimbernaut's ligament, and the reflected inguinal ligament, triangular fascia. Medial to the pubic tubercle is the crest, which extends from this process to the medial end of the bone. It affords attachment to the inguinal falx and to the rectus abdominis and pyramidalis. The point of junction of the crest with the medial border of the bone is called the angle. To it, as well as to the symphysis, the superior crus of the subcutaneous inguinal ring is attached. The medial border is articular. It is oval and is marked by 8 or 9 transverse ridges, or a series of nipple-like processes arranged in rows, separated by grooves. They serve for the attachment of a thin layer of cartilage, which intervenes between it and the interpubic fibrocartilaginous lamina. The lateral border presents a sharp margin, the obturator crest, which forms part of the circumference of the obturator foramen, and affords attachment to the obturator membrane. The lateral portion of the ascending ramus has 3 surfaces, superior, inferior, and posterior. The superior surface presents a continuation of the pectineal line, already mentioned as commencing at the pubic tubercle. In front of this line, the surface of bone is triangular in form, wider laterally than medially, and is covered by the pectineus. The surface is bounded laterally by a rough eminence, the iliopectineal eminence, which serves to indicate the point of junction of the ilium and pubis, and below by a prominent ridge which extends from the acetabular notch to the pubic tubercle. The inferior surface forms the upper boundary of the obturator foramen, and presents laterally a broad and deep oblique groove for the passage of the obturator vessels and nerve, and medially a sharp margin, the obturator crest, forming part of the circumference of the obturator foramen and giving attachment to the obturator membrane. The posterior surface constitutes part of the anterior boundary of the lesser pelvis. It is smooth, convex from above downward, and affords origin to some fibers of the obturator internus. The inferior ramus, ramus inferior os pubis, descending ramus. The inferior ramus is thin and flattened. It passes lateralward and downward from the medial end of the superior ramus. It becomes narrower as it descends and joins with the inferior ramus of the ischium below the obturator foramen. Its anterior angle is rough for the origin of muscles. The gracilis along its medial border, a portion of the obturator externus where it enters into the formation of the obturator foramen, and between these two, the adductoris brevis and magnus, the former being the more medial. The posterior surface is smooth and gives origin to the obturator internus, and, close to the medial margin, to the constrictor urethrae. The medial border is thick, rough, and everted, especially in females. It presents 2 ridges, separated by an intervening space. The ridges extend downward and are continuous with similar ridges on the inferior ramus of the ischium. To the external, it is attached to the fascia of Colles, and to the internal, the inferior fascia of the urogenital diaphragm. The lateral border is thin and sharp, forms part of the circumference of the obturator foramen, and gives attachment to the obturator membrane. The acetabulum, cotyloid cavity. The acetabulum is a deep, cup-shaped, hemispherical depression directed downward, lateralward, and forward. It is formed medially by the pubis, above by the ilium, laterally and below by the ischium. A little less than 2/5 is contributed by the ilium, a little more than 2/5 by the ischium, and the remaining 1/5 by the pubis. It is bounded by a prominent uneven rim, which is thick and strong above, and serves for the attachment of the glenoidal labrum, cotyloid ligament, which contracts its orifice and deepens the surface for articulation. It presents below a deep notch, the acetabular notch, which is continuous with a circular, non-articular depression, the acetabular fossa, at the bottom of the cavity. This depression is perforated by numerous apertures and lodges a mass of fat. The notch is converted into a foramen by the transverse ligament. Through the foramen, nutrient vessels and nerves enter the joint. The margins of the notch serve for the attachment of the ligamentum teres. The rest of the acetabulum is formed by a curved articular surface, the lunate surface, for articulation with the head of the femur. The obturator foramen, foramen obturatum, thyroid foramen. The obturator foramen is a large aperture situated between the ischium and pubis. In the male it is large and of an oval form, its longest diameter slanting obliquely from before backward. In the female it is smaller and more triangular. It is bounded by a thin, uneven margin to which a strong membrane is attached, and presents superiorly a deep groove, the obturator groove, which runs from the pelvis obliquely medialward and downward. This groove is converted into a canal by a ligamentous band, a specialized part of the obturator membrane, attached to two tubercles. One, the posterior obturator tubercle, on the medial border of the ischium, just in front of the acetabular notch. The other, the anterior obturator tubercle, on the obturator crest in the superior ramus of the pubis. Through the canal, the obturator vessels and nerve pass out of the pelvis. Structure. The thicker parts of the bone consist of cancellous tissue, enclosed between two layers of compact tissue. The thinner parts, as at the bottom of the acetabulum and the center of the iliac fossa, are usually semi-transparent and composed entirely of compact tissue. Ossification. The hip bone is ossified from 8 centers, 3 primary, 1 each for the ilium, ischium, and pubis, and 5 secondary, 1 each for the crest of the ilium, the anterior inferior spine, said to occur more frequently in the male than in the female, the tuberosity of the ischium, the pubic symphysis, more frequent in the female than in the male, and 1 or more for the Y-shaped piece at the bottom of the acetabulum. The centers appear in the following order. In the lower part of the ilium, immediately above the greater sciatic notch, about the 8th or 9th week of fetal life. In the superior ramus of the ischium, about the 3rd month. In the superior ramus of the pubis, between the 4th and 5th months. At birth, the 3 primary centers are quite separate, the crest, the bottom of the acetabulum, and the ischial tuberosity, and the inferior rami of the ischium and pubis still being cartilaginous. By the 7th or 8th year, the inferior rami of the pubis and ischium are almost completely united by bone. About the 13th or 14th year, the 3 primary centers have extended their growth into the bottom of the acetabulum, and are there separated from each other by a Y-shaped portion of cartilage, which now presents traces of ossification, often by 2 or more centers. One of these, the os acetabuli, appears about the age of 12 between the ilium and pubis, and fuses with them about the age of 18. It forms the pubic part of the acetabulum. The ilium and ischium then become joined, and lastly the pubis and ischium, through the intervention of this Y-shaped portion. At about the age of puberty, ossification takes place in each of the remaining portions, and they join with the rest of the bone between the 20th and 25th years. Separate centers are frequently found for the pubic tubercle and the ischial spine, and for the crest and angle of the pubis. Articulations. The hip bone articulates with its fellow of the opposite side and with the sacrum and femur. End of section 43.
Section 44 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Steve Foreman. Anatomy of the Human Body, Part 1, by Henry Gray. The pelvis. The pelvis, so called from its resemblance to a basin, is a bony ring interposed between the movable vertebrae of the vertebral column which it supports and the lower limbs upon which it rests. It is longer and more massively constructed than the wall of the cranial or thoracic cavities, and is composed of 4 bones: the 2 hip bones laterally and in front, and the sacrum and coccyx behind. The greater or false pelvis. The greater pelvis is the expanded portion of the cavity situated above and in front of the pelvic brim. It is bounded on either side by the ilium. In front it is incomplete, presenting a wide interval between the anterior borders of the ilia, which is filled up in the fresh state by the parietes of the abdomen. Behind is a deep notch on either side between the ilium and the base of the sacrum. It supports the intestines and transmits part of their weight to the anterior wall of the abdomen. The true or lesser pelvis. The lesser pelvis is that part of the pelvic cavity which is situated below and behind the pelvic brim. Its bony walls are more complete than those of the greater pelvis. For convenience of description, it is divided into an inlet bounded by the superior circumference, and outlet bounded by the inferior circumference, and a cavity. The superior circumference. The superior circumference forms the brim of the pelvis, an included space being called the superior aperture or inlet. It is formed laterally by the pectineal and arcuate lines, in front of the crest of the pubes, and behind by the anterior margin of the base of the sacrum and sacrovertebral angle. The superior aperture is somewhat heart-shaped, obtusely pointed in front, diverging on either side, and encroached upon behind by the projection forward of the promontory of the sacrum. It has 3 principal diameters: antero to posterior, transverse, and oblique. The anterior-posterior or conjugate diameter extends from the sacrovertebral angle to the symphysis pubis. Its average measurement is about 110 millimeters in the female. The transverse diameter extends from the greatest width of the superior aperture, from the middle of the brim on one side to the same point on the opposite. Its average measurement is about 135 millimeters in the female. The oblique diameter extends from the iliopectineal eminence of one side to the sacroiliac articulation of the opposite side. Its average measurement is about 125 millimeters in the female. The cavity of the lesser pelvis is bounded in front and below by the symphysis pubis and the superior rami of the pubes, above and behind by the pelvic surfaces of the sacrum and coccyx, which, curving forward above and below, contract the superior and inferior apertures of the cavity, laterally by a broad, smooth, quadrilangular area of bone, corresponding to the inner surfaces of the body and superior ramus of the ischium, and that part of the ilium which is below the arcuate line. From this description it will be seen that the cavity of the lesser pelvis is a short, curved canal, considerably deeper on its posterior than on its anterior wall. It contains, in the fresh subject, the pelvic colon, rectum, bladder, and some of the organs of generation. The rectum is placed at the back of the pelvis, in the curve of the sacrum and coccyx. The bladder is in front, behind the pubic symphysis. In the female, the uterus and vagina occupy the interval between these viscera. The lower circumference. The lower circumference of the pelvis is very irregular. The space enclosed by it is named the inferior aperture or outlet, and is bounded behind by the point of the coccyx, and laterally by the ischial tuberosities. These eminences are separated by 3 notches, one in front, the pubic arch, formed by the convergence of the inferior rami of the ischium and the pubis on either side. The other notches, one on either side, are formed by the sacrum and coccyx behind, the ischium in front, and the ilium above. They are called the sciatic notches. In the natural state they are converted into foramina by the sacrotuberous and sacrospinous ligaments. When the ligaments are in situ, the inferior aperture of the pelvis is lozenge-shaped, bounded in front by the pubic arcuate ligament and the inferior rami of the pubes and ischia, laterally by the ischial tuberosities, and behind by the sacrotuberous ligaments and the tip of the coccyx. The diameters of the outlet of the pelvis are 2, anterior-posterior, and transverse. The antero-posterior diameter extends from the tip of the coccyx to the lower part of the pubic symphysis. Its measurement is from 90 to 115 millimeters in the female. It varies with the length of the coccyx and is capable of increase or diminution on account of the mobility of that bone. The transverse diameter, measured from the posterior parts of the ischial tuberosities, is about 115 millimeters in the female. Footnote: the measurements of the pelvis given above are fairly accurate, but different figures are given by various authors, no doubt due mainly to differences in the physique and stature of the population from whom the measurements have been taken. End of footnote. Axes. A line at right angles to the plane of the superior aperture at its center would, if prolonged, pass through the umbilicus above and the middle of the coccyx below. The axis of the superior aperture is therefore directed downward and backward. The axis of the inferior aperture, produced upward, would touch the base of the sacrum, and is also directed downward and slightly backward. The axis of the cavity, i.e., an axis at right angles to a series of planes between those of the superior and inferior apertures, is curved like the cavity itself. This curve corresponds to the concavity of the sacrum and coccyx, the extremities being indicated by the central points of the superior and inferior apertures. A knowledge of the direction of these axes serves to explain the course of the fetus in the passage through the pelvis during parturition. Position of the pelvis. In the erect posture, the pelvis is placed obliquely with regard to the trunk. The plane of the superior aperture forms an angle of from 50 degrees to 60 degrees, and that of the inferior aperture one of about 15 degrees with the horizontal plane. The pelvic surface of the symphysis pubis looks upward and backward. The concavity of the sacrum and coccyx downward and forward. The position of the pelvis in the erect posture may be indicated by holding it so that the anterior superior iliac spines and the front of the top of the symphysis pubis are in the same vertical plane. Differences between the male and female pelvis. The female pelvis is distinguished from that of the male by its bones being more delicate and its depth less. The whole pelvis is less massive, and its muscular impressions are slightly marked. The ilia are less sloped, and the anterior iliac spines more widely separated, hence the greater lateral prominence of the hips. The preauricular sulcus is more commonly present and better marked. The superior aperture of the lesser pelvis is larger in the female than in the male. It is more nearly circular, and its obliquity is greater. The cavity is shallower and wider. The sacrum is shorter, wider, and its upper part is less curved. The obturator foramen are triangular in shape and smaller in size than in the male. The superior aperture is larger and the coccyx more movable. The sciatic notches are wider and shallower, and the spines of the ischia project less inward. The acetabula are smaller and look more distinctly forward. The ischial tuberosities and the acetabula are wider apart, and the former are more everted. The pubic symphysis is less deep, and the pubic arch is wider and more rounded than in the male, where it is an angle rather than an arch. The size of the pelvis varies not only in the two sexes, but also in different members of the same sex, and does not appear to be influenced in any way by the height of the individual. Women of shorter stature, as a rule, have broad pelvis. Occasionally the pelvis is equally contracted in all its dimensions, so much so that all its diameters measure 12.5 millimeters, less than the average, and this even in well-formed women of average height. The principal divergences, however, are found at the superior aperture and affect the relation of the anterior-posterior to the transverse diameter. Thus, the superior aperture may be elliptical either in a transverse or an antero-posterior direction, the transverse diameter in the former and the antero-posterior in the latter, greatly exceeding the other diameters. In other instances, it is almost circular. In the fetus, and for several years after birth, the pelvis is smaller in proportion than in the adult, and the projection of the sacrovertebral angle less marked. The characteristic differences between the male and female pelvis are distinctly indicated as early as the 4th month of fetal life. Abnormalities. There is arrest of development in the bones of the pelvis in cases of extraversion of the bladder. The anterior part of the pelvic girdle is deficient, the superior rami of the pubes are imperfectly developed, and the symphysis is absent. The pubic bones are separated to the extent of from 2 to 4 inches, the superior rami shortened and directed forward, and the obturator foramen diminished in size, narrowed, and turned outward. The iliac bones are straightened out more than normal. The sacrum is very peculiar. The lateral curve, instead of being concave, is flattened out or even convex, with the iliosacral facets turned more outward than normal, while the vertical curve is straightened. End of section 44.
Section 45 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by D. Froster. Anatomy of the Human Body, Part 1, by Henry Gray. The Femur, Part 1. The femur, the longest and strongest bone in the skeleton, is almost perfectly cylindrical in the greater part of its extent. In the erect posture it is not vertical, being separated above from its fellow by a considerable interval, which corresponds to the breadth of the pelvis, but inclining gradually downward and medialward, so as to approach its fellow toward its lower part, for the purpose of bringing the knee joint near the line of gravity of the body. The degree of this inclination varies in different persons, and is greater in the female than in the male, on account of the greater breadth of the pelvis. The femur, like other long bones, is divisible into a body and 2 extremities. The upper extremity, or proximal extremity. The upper extremity presents for examination a head, a neck, a greater and lesser trochanter. The head, or caput femoris. The head, which is globular and forms rather more than a hemisphere, is directed upward, medialward, and a little forward, the greater part of its convexity being above and in front. Its surface is smooth, coated with cartilage in the fresh state, except over an ovoid depression, the fovea capitis femoris, which is situated a little below and behind the center of the head, and gives attachment to the ligamentum teres. The neck, or column femoris. The neck is a flattened pyramidal process of bone, connecting the head with the body, and forming with the latter a wide angle opening medialward. The angle is widest in infancy and becomes lessened during growth, so that at puberty it forms a gentle curve from the axis of the body of the bone. In the adult, the neck forms an angle of about 125 degrees with the body, but this varies in inverse proportion to the development of the pelvis and its stature. In the female, in consequence of the increased width of the pelvis, the neck of the femur forms more nearly a right angle with the body than it does in the male. The angle decreases during the period of growth, but after full growth has been attained it does not usually undergo any change. Even in old age, it varies considerably in different persons of the same age. It is smaller and short than in long bones, and when the pelvis is wide. In addition to projecting upward and medialward from the body of the femur, the neck also projects somewhat forward. The amount of this forward projection is extremely variable, but on an average is from 12 degrees to 14 degrees. The neck is flattened from before backward, contracted in the middle, and broader laterally than medially. The vertical diameter of the lateral half is increased by the obliquity of the lower edge, which slopes downward to join the body at the level of the lesser trochanter, so that it measures 1/3 more than the antero-posterior diameter. The medial half is smaller and of a more circular shape. The anterior surface of the neck is perforated by numerous vascular foramina. Along the upper part of the line of junction of the anterior surface with the head is a shallow groove, best marked in elderly subjects. This groove lodges the orbicular fibers of the capsule of the hip joint. The posterior surface is smooth and is broader and more concave than the anterior. The posterior part of the capsule of the hip joint is attached to it about 1 centimeter above the intertrochanteric crest. The superior border is short and thick and ends laterally at the greater trochanter. Its surface is perforated by large foramina. The inferior border, long and narrow, curves a little backward to end at the lesser trochanter. The trochanters. The trochanters are prominent processes which afford leverage to the muscles that rotate the thigh on its axis. They are 2 in number, the greater and the lesser. The greater trochanter, or trochanter major, great trochanter, is a large, irregular, quadrilateral eminence situated at the junction of the neck with the upper part of the body. It is directed a little lateralward and backward, and, in the adult, is about 1 centimeter lower than the head. It has 2 surfaces and 4 borders. The lateral surface, quadrilateral in form, is broad, rough, convex, and marked by a diagonal impression, which extends from the posterior-superior to the anterior-inferior angle, and serves for the insertion of the tendon of the gluteus medius. Above the impression is a triangular surface, sometimes rough for part of the tendon of the same muscle, sometimes smooth through the interposition of a bursa between the tendon and the bone. Below and behind the diagonal impression is a smooth triangular surface, over which the tendon of the gluteus maximus plays, a bursa being interposed. The medial surface, of much less extent than the lateral, presents at its base a deep depression, the trochanteric fossa or digital fossa, for the insertion of the tendon of the obturator externus, and above and in front of this an impression for the insertion of the obturator internus and gemelli. The superior border is free. It is thick and irregular and marked near the center by an impression for the insertion of the piriformis. The inferior border corresponds to the line of junction of the base of the trochanter with the lateral surface of the body. It is marked by a rough, prominent, slightly curved ridge, which gives origin to the upper part of the vastus lateralis. The anterior border is prominent and somewhat irregular. It affords insertion at its lateral part to the gluteus minimus. The posterior border is very prominent and appears as a free, rounded edge, which bounds the back part of the trochanteric fossa. The lesser trochanter, or trochanter minor, small trochanter, is a conical eminence, which varies in size in different subjects. It projects from the lower and back part of the base of the neck. From its apex 3 well-marked borders extend. 2 of these are above, a medial continuous with the lower border of the neck, a lateral with the intertrochanteric crest. The inferior border is continuous with the middle division of the linea aspera. The summit of the trochanter is rough, and gives insertion to the tendon of the psoas major. A prominence of variable size occurs at the junction of the upper part of the neck with the greater trochanter, and is called the tubercle of the femur. It is the point of meeting of 5 muscles, the gluteus minimus laterally, the vastus lateralis below, and the tendon of the obturator internus, 2 gemelli above. Running obliquely downward and medialward from the tubercle is the intertrochanteric line, or spiral line of the femur. It winds around the medial side of the body of the bone, below the lesser trochanter, and ends about 5 centimeters below this eminence in the linea aspera. Its upper half is rough, and affords attachment to the iliofemoral ligament of the hip joint. Its lower half is less prominent, and gives origin to the upper part of the vastus medialis. Running obliquely downward and medialward from the summit of the greater trochanter on the posterior surface of the neck is a prominent ridge, the intertrochanteric crest. Its upper half forms the posterior border of the great trochanter, and its lower half runs downward and medialward to the lesser trochanter. A slight ridge is sometimes seen commencing about the middle of the intertrochanteric crest, and reaching vertically downward for about 5 centimeters along the back part of the body. It is called the linea quadrata, and gives attachment to the quadratus femoris and a few fibers of the adductor magnus. Generally, there is merely a slight thickening about the middle of the intertrochanteric crest, marking the attachment of the upper part of the quadratus femoris. The body or shaft, or corpus femoris. The body, almost cylindrical in form, is a little broader above than in the center, broadest, and somewhat flattened from before backward below. It is slightly arched, so as to be convex in front and concave behind, where it is strengthened by a prominent longitudinal ridge, the linea aspera. It presents for examination 3 borders, separating 3 surfaces. Of the borders, one, the linea aspera, is posterior, one is medial, and the other lateral. The linea aspera is a prominent longitudinal ridge or crest on the middle third of the bone, presenting a medial and a lateral lip, and a narrow, rough, intermediate line. Above, the linea aspera is prolonged by 3 ridges. The lateral ridge is very rough, and runs almost vertically upward to the base of the greater trochanter. It is termed the gluteal tuberosity, and gives attachment to part of the gluteus maximus. Its upper part is often elongated into a roughened crest, on which a more or less well-marked, rounded tubercle, the third trochanter, is occasionally developed. The intermediate ridge or pectineal line is continued to the base of the lesser trochanter, and gives attachment to the pectineus. The medial ridge is lost in the intertrochanteric line. Between these two, a portion of the iliacus is inserted. Below, the linea aspera is prolonged into 2 ridges, enclosing between them a triangular area, the popliteal surface, upon which the popliteal artery rests. Of these 2 ridges, the lateral is the more prominent, and descends to the summit of the lateral condyle. The medial is less marked, especially at its upper part, where it is crossed by the femoral artery. It ends below at the summit of the medial condyle in a small tubercle, the adductor tubercle, which affords insertion to the tendon of the adductor magnus. From the medial lip of the linea aspera and its prolongations above and below, the vastus medialis arises, and from the lateral lip and its upward prolongation, the vastus lateralis takes origin. The adductor magnus is inserted into the linea aspera, and to its lateral prolongation above and its medial prolongation below. Between the vastus lateralis and the adductor magnus 2 muscles are attached, via the gluteus maximus inserted above, and the short head of the biceps femoris arising below. Between the adductor magnus and the vastus medialis 4 muscles are inserted, the iliacus and the pectineus above, the adductor brevis and the adductor longus below. The linea aspera is perforated a little below its center by the nutrient canal, which is directed obliquely upward. The other 2 borders of the femur are only slightly marked. The lateral border extends from the anterior inferior angle of the greater trochanter to the anterior extremity of the lateral condyle. The medial border from the intertrochanteric line, at a point opposite the lesser trochanter, to the anterior extremity of the medial condyle. The anterior surface includes that portion of the shaft which is situated between the lateral and medial borders. It is smooth, convex, broader above and below than in the center. From the upper 3/4 of this surface the vastus intermedius arises. The lower fourth is separated from the muscle by the intervention of the synovial membrane of the knee joint and a bursa. From this upper part of it the articularis genu takes origin. The lateral surface includes the portion between the lateral border and the linea aspera. It is continuous above with the corresponding surface of the greater trochanter, below with that of the lateral condyle. From its upper 3/4 the vastus intermedius takes origin. The medial surface includes the portion between the medial border and the linea aspera. It is continuous above with the lower border of the neck, below with the medial side of the medial condyle. It is covered by the vastus medialis. The lower extremity, or distal extremity. The lower extremity, larger than the upper, is somewhat cuboid in form, but its transverse diameter is greater than antero-posterior. It consists of 2 oblong eminences known as the condyles. In front, the condyles are but slightly prominent, and are separated from one another by a smooth, shallow articular depression called the patellar surface. Behind, they project considerably, and the interval between them forms a deep notch, the intercondyloid fossa. The lateral condyle is the more prominent and is the broader both in the anterior-posterior and transverse diameters. The medial condyle is the longer and, when the femur is held with its body perpendicular, projects to a lower level. When, however, the femur is in its natural oblique position, the lower surfaces of the two condyles lie practically in the same horizontal plane. The condyles are not quite parallel with one another. The long axis of the lateral is almost directly anterior-posterior, but that of the medial runs backward and medialward. Their opposed surfaces are small, rough, and concave, and form the walls of the intercondyloid fossa. This fossa is limited above by a ridge, the intercondyloid line, and below by the central part of the posterior margin of the patellar surface. The posterior cruciate ligament of the knee joint is attached to the lower and front part of the medial wall of the fossa, and the anterior cruciate ligament to an impression on the upper and back part of its lateral wall. Each condyle is surmounted by an elevation, the epicondyle. The medial epicondyle is a large convex eminence to which the tibial collateral ligament of the knee joint is attached. At its upper part is the adductor tubercle, often referred to, and behind it is a rough impression which gives origin to the medial head of the gastrocnemius. The lateral epicondyle, smaller and less prominent than the medial, gives attachment to the fibular collateral ligament of the knee joint. Directly below it is a small depression from which a smooth, well-marked groove curves obliquely upward and backward to the posterior extremity of the condyle. This groove is separated from the articular surface of the condyle by a prominent lip across which a second, shallower groove runs vertically downward from the depression. In the fresh state, these grooves are covered with cartilage. The popliteus arises from this depression. Its tendons lie in the oblique groove when the knee is flexed, and in the vertical groove when the knee is extended. Above and behind the lateral epicondyle is an area for the origin of the lateral head of the gastrocnemius, above and to the medial side of which the plantaris arises. The articular surface of the lower end of the femur occupies the anterior, inferior, and posterior surfaces of the condyle. Its front part is named the patellar surface and articulates with the patella. It presents a median groove which extends downward to the intercondyloid fossa and two convexities, the lateral of which is broader, more prominent, and extends farther upward than the medial. The lower and posterior parts of the articular surface constitute the tibial surface for articulation with the corresponding condyles of the tibia and menisci. These surfaces are separated from one another by the intercondyloid fossa and from the patellar surface by faint grooves which extend obliquely across the condyles. The lateral groove is the better marked. It runs lateralward and forward from the front part of the intercondyloid fossa and expands to form a triangular depression. When the knee joint is fully extended, the triangular depression rests upon the anterior portion of the lateral meniscus, and the medial part of the groove comes into contact with the medial margin of the lateral articular surface of the tibia in front of the lateral tubercle of the tibial intercondyloid eminence. The medial groove is less distinct than the lateral. It does not reach as far as the intercondyloid fossa, and therefore exists only on the medial part of the condyle. It receives the anterior edge of the medial meniscus when the knee joint is extended. Where the groove ceases laterally, the patellar surface is seen to be continued backward as a semilunar area close to the anterior part of the intercondyloid fossa. This semilunar area articulates with the medial vertical facet of the patella in forced flexion of the knee joint. The tibial surfaces of the condyles are convex from side to side and from before backward. Each presents a double curve, its posterior segment being an arc of a circle, its anterior part of a cycloid.
Footnote. A cycloid is a curve traced by a point in the circumference of a wheel when the wheel is rolled along in a straight line. End of footnote.
The architecture of the femur.
Note. The following paragraphs are taken almost verbatim from Koch's article, in which we have the first correct mathematical analysis of the femur in support of the theory of the functional form of bone proposed by Wolff and by Roux. End of note.
Koch, by mathematical analysis, has shown that in every part of the femur there is a remarkable adaptation of the inner surface of the bone to the mechanical requirements due to the load of the femur head. The various parts of the femur taken together form a single mechanical structure wonderfully well adapted for the efficient economical transmission of the load of the acetabulum to the tibia, a structure in which every element contributes its modicum of strength in the manner required by theoretical mechanics for maximum efficiency. The internal structure is everywhere so formed as to provide in an efficient manner for all the internal stresses which occur due to the load on the femur head. Throughout the femur, where the load on the femur head, the bony material is arranged in the paths of the maximum internal stresses, which are thereby resisted with the greatest efficiency, and hence with maximum economy of material. The conclusion is inevitable that the inner structure and outer form of the femur are governed by the conditions of maximum stresses to which the bone is subjected normally by the preponderant load of the femur head, that is, by the body weight transmitted to the femur head through the acetabulum. The femur obeys the mechanical laws that govern other elastic bodies under stress. The relation between the computed internal stresses due to the load of the femur head and the internal structure of the different portions of the femur is in very close agreement with the theoretical relations that should exist between stress and structure for maximum economy and efficiency, and therefore it is believed that the following laws of bone structure have been demonstrated for the femur. 1. The internal structure and external form of human bone are closely adapted to the mechanical conditions existing at every point in the bone. 2. The inner architecture of normal bone is determined by definite and exact requirements of mathematical and mechanical laws to produce the maximum of strength with a minimum of material. End of section 45. Recording by D. Froster.
Section 46 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit Librivox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 1, by Henry Gray. The Femur, Part 2. The inner architecture of the upper femur. The spongy bone of the upper femur, to the lower limit of the lesser trochanter, is composed of two distinct systems of trabeculi arranged in curved paths, one which has its origin in the medial inner side of the shaft, and curving upward in a fan-like radiation to the opposite side of the bone; the other having origin in the lateral outer portion of the shaft, and arching upward and medially to end in the upper surface of the greater trochanter, neck and head. These two systems intersect each other at right angles. A medial compressive system of trabeculi. As the compact bone of the medial inner part of the shaft nears the head of the femur, it gradually becomes thinner and finally reaches the articular surface of the head as a very thin layer. From a point at about the lower level of the lesser trochanter, 2½ to 3 inches from the lower limit of the articular surface of the head, the trabeculi branch off from the shaft in smooth curves, spreading radially to cross to the opposite side in two well-defined groups, a lower or secondary group, and an upper or principal group. A. The secondary compressive group. This group of trabeculi leaves the inner border of the shaft beginning at about the level of the lesser trochanter, and for a distance of almost 2 inches along the curving shaft, with which the separate trabeculi make an angle of about 45 degrees. They curve outwardly and upwardly to cross in radiating smooth curves to the opposite side. The lower filaments end in the region of the greater trochanter. The adjacent filaments above these pursue a more nearly vertical course and end in the upper portion of the neck of the femur. The trabeculi of this group are thin and with wide spaces between them. As they traverse the space between the medial and lateral surfaces of the bone, they cross at right angles the system of curved trabeculi which arise from the lateral outer portion of the shaft. B. The principal compressive group. This group of trabeculi springs from the medial portion of the shaft just above the group above described, and spreads upward and in slightly radial smooth curved lines to reach the upper portion of the articular surface of the head of the femur. These trabeculi are placed very closely together, and are the thickest ones seen in the upper femur. They are a prolongation of the shaft from which they spring in straight lines which gradually curve to meet at right angles the articular surface. There is no change as they cross the epiphyseal line. They also intersect at right angles the system of lines which rise from the lateral side of the femur. This system of principal and secondary compressive trabeculi corresponds in position and in curvature with the lines of maximum compressive stress, which were traced out in the mathematical analysis of this portion of the femur. B. Lateral tensile system of trabeculi. As the compact bone of the outer portion of the shaft approaches the greater trochanter, it gradually decreases in thickness. Beginning at a point about 1 inch below the level of the lower portion of the greater trochanter, numerous thin trabeculi are given off from the outer portion of the shaft. These trabeculi lie in 3 distinct groups. C. The greater trochanter group. These trabeculi rise from the outer part of the shaft just below the greater trochanter and rise in thin curving lines to cross the region of the greater trochanter and end in its upper surface. Some of these filaments are poorly defined. This group intersects the trabeculi of group A, which rise from the opposite side. The trabeculi of this group evidently carry small stresses, as is shown by their slenderness. D. The principal tensile group. This group springs from the outer part of the shaft immediately below group C and curves convexly upward and inward in nearly parallel lines across the neck of the femur and ends in the inferior portion of the head. These trabeculi are somewhat thinner and more widely spaced than those of the principal compressive group, B. All the trabeculi of this group cross those of groups A and B at right angles. This group is the most important of the lateral system, tensile, and, as will be shown later, the greatest tensile stresses of the upper femur are carried by the trabeculi of this group. E. The secondary tensile group. This group consists of the trabeculi which spring from the outer side of the shaft and lie below those of the preceding group. They curve upward and medially across the axis of the femur and end more or less irregularly after crossing the midline, but a number of these filaments end in the medial portion of the shaft and neck. They cross at right angles the trabeculi of group A. In general, the trabeculi of the tensile system are lighter in structure than those of the compressive system in corresponding positions. The significance of the difference in thickness of these two systems is that the thickness of the trabeculi varies with the intensity of the stresses at any given point. Comparison of Figure 247 with Figure 251 will show that the trabeculi of the compressive system carry heavier stresses than those of the tensile system in corresponding positions. For example, the maximum tensile stress at section 8 in the outermost fibre is 771 pounds per square inch, and at the corresponding point on the compressive side the compressive stress is 954 pounds per square inch. Similar comparisons may be made at other points, which confirm the conclusion that the thickness and closeness of spacing of the trabeculi varies in proportion to the intensity of the stresses carried by them. It will be seen that the trabeculi lie exactly in the paths of the maximum tensile and compressive stresses, and hence these trabeculi carry these stresses in the most economical manner. This is in accordance with the well-recognized principle of mechanics that the most direct manner of transmitting stress is in the direction in which the stress acts. Figure 249 shows a longitudinal frontal section through the left femur, which is the mate of the right femur on which the mathematical analysis was made. In this midsection the system of tensile trabeculi, which rises from the lateral, outer part of the shaft, and crosses over the central area to end in the medial portion of the shaft, neck, and head, is clearly shown. This figure also shows the compressive system of trabeculi which rises on the medial portion of the shaft and crosses the central area to end in the head, neck, and greater trochanter. By comparing the position of these two systems of trabeculi shown in Figure 249 with the lines of maximum and minimum stresses shown in Figures 248 and 250, it is seen that the tensile system of trabeculi corresponds exactly with the position of the lines of maximum and minimum tensile stresses, which were determined by mathematical analysis. In a similar manner the compressive system of trabeculi in Fig. 249 corresponds exactly with the lines of maximum and minimum compressive stresses computed by the mathematical analysis. The amount of vertical shear varies almost uniformly from a maximum of 90 lbs. 90% of the load on the femur head, midway between sections 4 and 6, to a minimum of 5.7 lbs. At section 18. There is a gradual diminution of the spongy bone from section 6 to section 18 parallel with the diminished intensities of the vertical shear. The trabeculi of the upper femur, as shown in frontal sections, are arranged in two general systems, compressive and tensile, which correspond in position with the lines of maximum and minimum stresses in the femur determined by the mathematical analysis of the femur as a mechanical structure. 2. The thickness and spacing of the trabeculi vary with the intensity of the maximum stresses at various points in the upper femur, being thickest and most closely spaced in the regions where the greatest stresses occur. 3. The amount of bony material in the spongy bone of the upper femur varies in proportion to the intensity of the shearing force at the various sections. 4. The arrangement of the trabeculi in the positions of maximum stresses is such that the greatest strength is secured with a minimum of material. Significance of the inner architecture of the shaft. 1. Economy for resisting shear. The shearing stresses are at a minimum in the shaft. It is clear that a minimum amount of material will be required to resist the shearing stresses. As horizontal and vertical shearing stresses are most efficiently resisted by material placed near the neutral plane, in this region a minimum amount of material will be needed near the neutral axis. In the shaft there is very little if any material in the central space, practically the only material near the neutral plane being in the compact bone, but lying at a distance from the neutral axis. This confirms the requirement of mechanics for economy, as a minimum of material is provided for resisting shearing stresses where these stresses are a minimum. 2. Economy for resisting bending moment. The bending moment increases from a minimum at section 4 to a maximum between sections 16 and 18, then gradually decreases almost uniformly to 0 near section 75. To resist bending moment stresses most effectively, the material should be as far from the neutral axis as possible. It is evident that the hollow shaft of the femur is an efficient structure for resisting bending moment stresses, all of the material in the shaft being relatively at a considerable distance from the neutral axis. It is evident that the hollow shaft provides efficiently for resisting bending moment, not only due to the load on the femur head, but from any other loads tending to produce bending in other planes. 3. Economy for resisting axial stress. The inner architecture of the shaft is adapted to resist in the most efficient manner the combined action of the minimal shearing forces and the axial and maximum bending stresses. The structure of the shaft is such as to secure great strength with a relatively small amount of material. The distal portion of the femur. In frontal section, in the distal 6 inches of the femur, there are to be seen two main systems of trabeculi, a longitudinal and a transverse system. The trabeculi of the former rise from the inner wall of the shaft and continue in perfectly straight lines parallel to the axis of the shaft and proceed to the epiphyseal line, whence they continue in more or less curved lines to meet the articular surface of the knee joint at right angles at every point. Near the centre there are a few thin, delicate, longitudinal trabeculi, which spring from the longitudinal trabeculi just described, to which they are joined by fine transverse filaments that lie in planes parallel to the sagittal plane. The trabeculi of the transverse system are somewhat lighter in structure than those of the longitudinal system, and consist of numerous trabeculi at right angles to the latter. As the distal end of the femur is approached, the shaft gradually becomes thinner until the articular surface is reached, where there remains only a thin shell of compact bone. With the gradual thinning of the compact bone of the shaft, there is a simultaneous increase in the amount of the spongy bone, and a gradual flaring of the femur which gives this portion of the bone a gradually increasing gross area of cross-section. There is a marked thickening of the shell of bone in the region of the intercondyloid fossa, where the anterior and posterior crucial ligaments are attached. The thickened area is about 0.4 inch in diameter and consists of compact bone from which a number of thick trabeculi pass at right angles to the main longitudinal system. The inner structure of the bone is here evidently adapted to the efficient distribution of the stresses arising from this ligamentary attachment. Near the distal end of the femur, the longitudinal trabeculi gradually assume curved paths and end perpendicularly to the articular surface at every point. Such a structure is in accordance with the principles of mechanics, as stresses can be communicated through a frictionless joint only in a direction perpendicular to the joint surface at every point. With practically no increase in the amount of bony material used, there is a greatly increased stability produced by the expansion of the lower femur from a hollow shaft of compact bone to a structure of much larger cross-section almost entirely composed of spongy bone. Significance of the inner architecture of the distal part of the femur. The function of the lower end of the femur is to transmit through a hinged joint the loads carried by the femur. For stability, the width of the bearing on which the hinge action occurs should be relatively large. For economy of material, the expansion of the end bearing should be as lightly constructed as is consistent with proper strength. In accordance with the principles of mechanics, the most efficient manner in which stresses are transmitted is by the arrangement of the resisting material in lines parallel to the direction in which the stresses occur and in the paths taken by the stresses. Theoretically, the most efficient manner to attain these objects would be to prolong the innermost filaments of the bone as straight lines parallel to the longitudinal axis of the bone, and gradually to flare the outer shell of compact bone outward, and continuing to give off filaments of bone parallel to the longitudinal axis as the distal end of the femur is approached. These filaments should be well braced transversely, and each should carry its proportionate part of the total load parallel to the longitudinal axis, transmitting it eventually to the articular surface and in a direction perpendicular to that surface. Referring to Fig. 249, it is seen that the large expansion of the bone is produced by the gradual transition of the hollow shaft of compact bone to cancellated bone, resulting in the production of a much larger volume. The trabeculi are given off from the shaft in lines parallel to the longitudinal axis, and are braced transversely by two series of trabeculi at right angles to each other, in the same manner as required theoretically for economy. Although the action of the muscles exerts an appreciable effect on the stresses in the femur, it is relatively small and very complex to analyse, and has not been considered in the above analysis. Ossification. The femur is ossified from 5 centres, one for the body, one for the head, one for each trochanter, and one for the lower extremity. Of all the long bones, except the clavicle, it is the first to show traces of ossification. This commences in the middle of the body at about the 7th week of fetal life, and rapidly extends upward and downward. The centres in the epiphyses appear in the following order. In the lower end of the bone, at the 9th month of fetal life, from this centre the condyles and epicondyles are formed, in the head. At the end of the 1st year after birth, in the greater trochanter, during the 4th year, and in the lesser trochanter between the 13th and 14th years. The order in which the epiphyses are joined to the body is the reverse of that of their appearance. They are not united until after puberty, the lesser trochanter being first joined, then the greater, then the head, and lastly the inferior extremity, which is not united until the 20th year. End of section number 46.
Section 47 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit Librivox.org. Recording by Steve Foreman. Anatomy of the Human Body, Part 1, by Henry Gray. The patella. The patella is a flat, triangular bone situated on the front of the knee joint. It is usually regarded as a sesamoid bone, developed in the tendon of the quadriceps femoris, and resembles these bones, 1. in being developed in a tendon, 2. in its center of ossification presenting a knotty or tuberculated outline, 3. in being composed mainly of dense cancellous tissue. It serves to protect the front of the joint, and increases the leverage of the quadriceps femoris by making it act at a greater angle. It has an anterior and a posterior surface, 3 borders, and an apex. Surfaces. The anterior surface is convex, perforated by small apertures for a passage of nutrient vessels and marked by numerous rough longitudinal striae. This surface is covered, in the recent state, by an expansion from the tendon of the quadriceps femoris, which is continuous below with the superficial fibers of the ligamentum patella. It is separated from the integument by a bursa. The posterior surface presents above a smooth, oval, articular area divided into two facets by a vertical ridge. The ridge corresponds to the groove on the patellar surface of the femur, and the facets to the medial and lateral parts of the same surface. The lateral facet is the broader and deeper. Below the articular surface is a rough, convex, non-articular area, the lower half of which gives attachment to the ligamentum patellae. The upper half is separated from the head of the tibia by adipose tissue. Borders. The base or superior border is thick and sloped from behind, downward, and forward. It gives attachment to that portion of the quadriceps femoris which is derived from the rectus femoris and vastus intermedius. The medial and lateral borders are thinner and converge below. They give attachment to those portions of the quadriceps femoris which are derived from the vasti lateralis and medialis. Apex. The apex is pointed and gives attachment to the ligamentum patella. Structure. The patella consists of nearly uniform, dense cancellous tissue covered by a thin, compact lamina. The cancelli immediately beneath the anterior surface are arranged parallel with it. In the rest of the bone, they radiate from the articular surface toward the other parts of the bone. Ossification. The patella is ossified from a single center, which usually makes its appearance in the second or third year, but may be delayed until the sixth year. More rarely, the bone is developed by two centers placed side by side. Ossification is completed about the age of puberty. Articulation. The patella articulates with the femur. The tibia. The tibia is situated at the medial side of the leg, and excepting the femur, is the longest bone of the skeleton. It is prismoid in form, expanded above, where it enters into the knee joint, contracted in the lower third, and again enlarged, but to a lesser extent below. In the male, its direction is vertical, and parallel with the bone of the opposite side, but in the female, it has a slightly oblique direction downward and lateralward, to compensate for the greater obliquity of the femur. It has a body and two extremities. The upper extremity is large and expanded into two eminences, the medial and lateral condyles. The superior articular surface presents two smooth articular facets. The medial facet, oval in shape, is slightly concave from side to side and from before backward. The lateral, nearly circular, is concave from side to side, but slightly convex from before backward, especially at its posterior part, where it is prolonged onto the posterior surface for a short distance. The central portions of these facets articulate with the condyles of the femur, while their peripheral portions support the menisci of the knee joint, which here intervene between the two bones. Between the articular facets, but nearer the posterior than the anterior aspect of the bone, is the intercondyloid eminence, or spine of tibia, surmounted on either side by a prominent tubercle, onto the sides of which the articular facets are prolonged. In front of and behind the intercondylar eminence are rough depressions for the attachment of the anterior and posterior cruciate ligaments and the menisci. The anterior surfaces of the condyle are continuous with one another, forming a large, somewhat flattened area. This area is triangular, broad above, and perforated by large vascular foramina, narrow below where it ends in a large oblong elevation, the tuberosity of the tibia, which gives attachment to the ligamentous patella. A bursa intervenes between the deep surface of the ligament and the part of the bone immediately above the tuberosity. Posteriorly, the condyles are separated from each other by a shallow depression, the posterior intercondylar fossa, which gives attachment to part of the posterior cruciate ligament of the knee joint. The medial condyle presents posteriorly a deep transverse groove for the insertion of the tendon of the semimembranosus. Its medial surface is convex, rough, and prominent. It gives attachment to the tibial collateral ligament. The lateral condyle presents posteriorly a flat articular facet, nearly circular in form, directed downward, backward, and lateralward for articulation with the head of the fibula. Its lateral surface is convex, rough, and prominent in front. On it is an eminence situated on a level with the upper border of the tuberosity, and at the junction of its anterior and lateral surfaces, for the attachment of the iliotibial band. Just below this is a part of the extensor digitorum longus takes off, and a slip from the tendon of the biceps femoris is inserted. The body or shaft. The body has 3 borders and 3 surfaces. Borders. The anterior crest or border, the most prominent of the 3, commences above at the tuberosity and ends below at the anterior margin of the medial malleolus. It's sinuous and prominent in the upper 2/3 of its extent, but smooth and rounded below. It gives attachment to the deep fascia of the leg. The medial border is smooth and rounded above and below, but more prominent in the center. It begins at the back part of the medial condyle and ends at the posterior border of the medial malleolus. Its upper part gives attachment to the tibial collateral ligament of the knee joint to the extent of about 5 centimeters, and insertion to some fibers of the popliteus. From the middle third of some fibers of the soleus and flexor digitorum longus take origin. The interosseous crest, or lateral border, is thin and prominent, especially its central part, and gives attachment to the interosseous membrane. It commences above in front of the fibular articular facet and bifurcates below to form the boundaries of a triangular rough surface for the attachment of the interosseous ligament connecting the tibia and fibula. Surfaces. The medial surface is smooth, convex, and broader above than below. Its upper third, directed forward and medialward, is covered by the aponeurosis derived from the tendon of the sartorius, and by the tendons of the gracilis and semitendinosus, all of which are inserted nearly as far forward as the anterior crest. In the rest of its extent it is subcutaneous. The lateral surface is narrower than the medial. Its upper 2/3 present a shallow groove for the origin of the tibialis anterior. Its lower third is smooth, convex, curves gradually forward to the anterior aspect of the bone, and is covered by the tendons of the tibialis anterior, extensor hallucis longus, and the extensor digitorum longus, arranged in this order from the medial side. The posterior surface presents, at its upper part, a prominent ridge, the popliteal line, which extends obliquely downward from the back part of the articular facet for the fibula to the medial border. At the junction of its upper and middle thirds, it marks the lower limit of the insertion of the popliteus, serves for the attachment of the fascia covering this muscle, and gives origin to part of the soleus, flexor digitorum longus, and tibialis posterior. The triangular area above this line gives insertion to the popliteus. The middle third of the posterior surface is divided by a vertical ridge into 2 parts. The ridge begins at the popliteal line and is well marked above, but indistinct below. The medial and broader portion gives origin to the flexor digitorum longus, the lateral and narrower to part of the tibialis posterior. The remaining part of the posterior surface is smooth and covered by the tibialis posterior, flexor digitorum longus, and the flexor hallucis longus. Immediately below the popliteal line is the nutrient foramen, which is large and directed obliquely downward. The lower extremity. The lower extremity is much smaller than the upper, presents 5 surfaces. It is prolonged downward on the medial side as a strong process, the medial malleolus. Surfaces. The inferior articular surface is quadrilateral and smooth for articulation with the talus. It is concave from before backward, broader in front than behind, and traversed from before backward by a slight elevation separating 2 depressions. It is continuous with that on the medial malleolus. The anterior surface of the lower extremity is smooth and rounded above, and covered by the tendons of the extensor muscles. Its lower margin presents a rough transverse depression for the attachment of the articular capsule of the ankle joint. The posterior surface is traversed by a shallow groove directed obliquely downward and medialward, continuous with a similar groove on the posterior surface of the talus, and serving for the passage of the tendon of the flexor hallucis longus. The lateral surface presents a triangular rough depression for the attachment of the inferior interosseous ligament connecting it with the fibula. The lower part of this depression is smooth, covered with cartilage in the fresh state, and articulates with the fibula. The surface is bounded by 2 prominent borders, continuous above with the interosseous crest. They afford attachment to the anterior and posterior ligaments of the lateral malleolus. The medial surface is prolonged downward to form a strong pyramidal process, flattened from without inward, the medial malleolus. The medial surface of this process is convex and subcutaneous. Its lateral or articular surface is smooth and slightly concave, and articulates with the talus. Its anterior border is rough for the attachment of the anterior fibers of the deltoid ligament of the ankle joint. Its posterior border presents a broad groove, the malleolar sulcus, directed obliquely downward and medialward, and occasionally double. This sulcus lodges the tendons of the tibialis posterior and flexor digitorum longus. The summit of the medial malleolus is marked by a rough depression behind for the attachment of the deltoid ligament. Structure. The structure of the tibia is like that of the other long bones. The compact wall of the body is thickest at the junction of the middle and lower thirds of the bone. Ossification. The tibia is ossified from 3 centers, one for the body and one for either extremity. Ossification begins in the center of the body about the 7th week of fetal life and gradually extends towards the extremities. The center for the upper epiphysis appears before or shortly after birth. It is flattened in form and has a thin tongue-shaped process in front, which forms the tuberosity. That for the lower epiphysis appears in the 2nd year. The lower epiphysis joins the body at about the 18th, and the upper one joins about the 20th year. 2 additional centers occasionally exist, one for the tongue-shaped process of the upper epiphysis, which forms the tuberosity, and one for the medial malleolus. End of section 47.
Section 48 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 1 by Henry Gray. The Fibula. 6C, Part 6, The Fibula. Calf bone. The fibula is placed on the lateral side of the tibia, with which it is connected above and below. It is the smaller of the 2 bones, and in proportion to its length, the most slender of all the long bones. Its upper extremity is small, placed toward the back of the head of the tibia, below the level of the knee joint, and excluded from the formation of this joint. Its lower extremity inclines a little forward, so as to be on a plane anterior to that of the upper end. It projects below the tibia and forms the lateral part of the ankle joint. The bone has a body and 2 extremities. The upper extremity or head, capitulum fibulae, proximal extremity. The upper extremity is of an irregular quadrate form, presenting above a flattened articular surface directed upward, forward, and medialward for articulation with a corresponding surface on the lateral condyle of the tibia. On the lateral side is the thick and rough prominence continued behind into a pointed eminence, the apex styloid process, which projects upward from the posterior part of the head. The prominence, at its upper and lateral part, gives attachment to the tendon of the biceps femoris and to the fibular collateral ligament of the knee joint, the ligament dividing the tendon into two parts. The remaining part of the circumference of the head is rough for the attachment of muscles and ligaments. It presents in front a tubercle for the origin of the upper and interior fibers of the peroneus longus, and a surface for the attachment of the anterior ligament of the head, and behind another tubercle for the attachment of the posterior ligament of the head and the origin of the upper fibers of the soleus. The body or shaft, corpus fibulae. The body presents four borders: the anterolateral, the anteromedial, the posterolateral, and the posteromedial, and four surfaces: anterior, posterior, medial, and lateral. Borders. The anterolateral border begins above in front of the head, runs vertically downward to a little below the middle of the bone, and then curving somewhat lateralward, bifurcates so as to embrace a triangular subcutaneous surface immediately above the lateral malleolus. This border gives attachment to an intermuscular septum which separates the extensor muscles on the anterior surface of the leg from the peronei longus and brevis on the lateral surface. The anteromedial border, or interosseous crest, is situated close to the medial side of the preceding, and runs nearly parallel with it in the upper third of its extent, but diverges from it in the lower two-thirds. It begins above, just beneath the head of the bone. Sometimes it is quite indistinct for about 2.5 centimeters below the head, and ends at the apex of a rough triangular surface immediately above the articular facet of the lateral malleolus. It serves for the attachment of the interosseous membrane which separates the extensor muscles in front from the flexor muscles behind. The posterolateral border is prominent. It begins above at the apex and ends below in the posterior border of the lateral malleolus. It is directed lateralward above, backward in the middle of its course, backward and a little medialward below, and gives attachment to an aponeurosis which separates the peronei on the lateral surface from the flexor muscles on the posterior surface. The posteromedial border, sometimes called the oblique line, begins above at the medial side of the head, and ends by becoming continuous with the interosseous crest at the lower fourth of the bone. It is well marked and prominent at the upper and middle parts of the bone. It gives attachment to an aponeurosis, which separates the tibialis posterior from the soleus and flexor hallucis longus. Surfaces. The anterior surface is the interval between the anterolateral and anteromedial borders. It is extremely narrow and flat in the upper third of its extent. Broader and grooved longitudinally in its lower third, it serves for the origin of three muscles: the extensor digitorum longus, extensor hallucis longus, and peroneus tertius. The posterior surface is the space included below the posterolateral and the posteromedial borders. It is continuous below with the triangular area above the articular surface of the lateral malleolus. It is directed backward above, backward and medialward at its middle, directly medialward below. Its upper third is rough for the origin of the soleus. Its lower part presents a triangular surface, connected to the tibia by a strong interosseous ligament. The intervening part of the surface is covered by the fibers of origin of the flexor hallucis longus. Near the middle of this surface is the nutrient foramen, which is directed downward. The medial surface is the interval included between the anteromedial and the posteromedial borders. It is grooved for the origin of the tibialis posterior. The lateral surface is the space between the anterolateral and posterolateral borders. It is broad and often deeply grooved. It is directed lateralward in the upper 2/3 of its course, backward in the lower third, where it is continuous with the posterior border of the lateral malleolus. This surface gives origin to the peronei longus and brevis. The lower extremity or lateral malleolus, malleolus lateralis, distal extremity, external malleolus. The lower extremity is of a pyramidal form and somewhat flattened from side to side. It descends to a lower level than the medial malleolus. The lateral surface is convex, subcutaneous, and continuous with the triangular, subcutaneous surface on the lateral side of the body. The medial surface presents in front a smooth triangular surface, convex from above downward, which articulates with a corresponding surface on the lateral side of the talus. Behind and beneath the articular surface is a rough depression, which gives attachment to the posterior talofibular ligament. The anterior border is thick and rough, and marked below by a depression for the attachment of the anterior talofibular ligament. The posterior border is broad, and presents the shallow malleolar sulcus for the passage of the tendons of the peronei longus and brevis. The summit is rounded, and give attachment to the calcaneofibular ligament. Ossification. The fibula is ossified from 3 centers, one for the body and one for either end. Ossification begins in the body about the 8th week of fetal life, and extends toward the extremities. At birth the ends are cartilaginous. Ossification commences in the lower end in the 2nd year, and in the upper about the 4th year. The lower epiphysis, the first to ossify, unites with the body about the 20th year. The upper epiphysis joins about the 25th year. End of section 48. Recording by Leanne Howlett.
Section 49 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit Librivox.org. Recording by Jennifer Stearns. Anatomy of the Human Body, Part 1, by Henry Gray. Section 49, Tarsus. The skeleton of the foot consists of 3 parts: the tarsus, the metatarsus, and phalanges. The tarsus. Ossa tarsi. The tarsal bones are 7 in number, namely the calcaneus, talsus, cuboid, navicular, and the 1st, 2nd, and 3rd cuneiforms. The calcaneus, os calcis. The calcaneus is the largest of the tarsal bones. It is situated at the lower and back part of the foot, serving to transmit the weight of the body to the ground, and forming a strong lever for the muscles of the calf. It is irregularly cuboidal in form, having its long axis directed forward and lateralward. It presents, for examination, 6 surfaces. Surfaces. The superior surface extends behind onto that part of the bone which projects backward to form the heel. This varies in length in different individuals, is convex from side to side, concave from before backward, and supports a mass of fat placed in front of the tendo calcaneus. In front of this area is a large, usually somewhat oval-shaped facet, the posterior articular surface, which looks upward and forward. It is convex from behind forward, and articulates with the posterior calcaneal facet on the under surface of the talus. It is bounded anteriorly by a deep depression, which is continued backward and medialward in the form of a groove, calcaneal sulcus. In the articulated foot, this sulcus lies below a similar one on the under surface of the talus, and the two form a canal, sinus tarsi, for the lodgment of the interosseous talocalcaneal ligament. In front and to the medial side of this groove is an elongated facet, concave from behind forward, and with its long axis directed forward and lateralward. This facet is frequently divided into two by a notch. Of the two, the posterior and larger is termed the middle articular surface. It is supported on a projecting process of bone, the sustentaculum tali, and articulates in the middle calcaneal facet on the under surface of the talus. The anterior articular surface is placed on the anterior part of the body and articulates with the anterior calcaneal facet on the talus. The upper surface, anterior and lateral to the facets, is rough for the attachment of ligaments and for the origin of the extensor digitorum brevis. The inferior or plantar surface is uneven, wider behind than in front, and convex from side to side. It is bounded posteriorly by a transverse elevation, the calcaneal tuberosity, which is depressed in the middle and prolonged at either end into a process. The lateral process, small, prominent, and rounded, gives origin to part of the abductor digiti quinti. The medial process, broader and larger, gives attachment, by its prominent medial margin, to the abductor hallucis, and in front of the flexor digitorum brevis and the plantar aponeurosis. The depression behind the processes gives origin to the abductor digiti quinti. The rough surface in front of the processes gives attachment to the long plantar ligament, and to the lateral head of the quadratus plantae, to a prominent tubercle nearer the anterior part of the surface, as well as to a transverse groove in front of the tubercle, is attached the plantar calcaneocuboid ligament. The lateral surface is broad behind and narrow in front, flat and almost subcutaneous. Near its center is a tubercle for the attachment of the calcaneofibular ligament. At its upper and anterior part, this surface gives attachment to the lateral talocalcaneal ligament, and in front of the tubercle it presents a narrow surface marked by two oblique grooves. The grooves are separated by an elevated ridge or tubercle, the trochlear process, peroneal tubercle, which varies much in size in different bones. The superior groove transmits the tendon of the peroneus brevis, the inferior groove that of the peroneus longus. The medial surface is deeply concave. It is directed obliquely downward and forward, and serves for the transmission of the plantar vessels and nerves into the sole of the foot. It affords origin to part of the quadratus plantae. At its upper and forepart is a horizontal eminence, the sustentaculum tali, which gives attachment to a slip of the tendon of the tibialis posterior. This eminence is concave above and articulates with the middle calcaneal articular surface of the talus. Below it is grooved for the tendon of the flexor hallucis longus. Its anterior margin gives attachment to the plantar calcaneonavicular ligament, and its medial to a part of the deltoid ligament of the ankle joint. The anterior or cuboid articular surface is of a somewhat triangular form. It is concave from above downward and lateralward, and convex in a direction at right angles to this. Its medial border gives attachment to the plantar calcaneonavicular ligament. The posterior surface is prominent, convex, wider below than above, and divisible into three areas. The lowest of these is rough and covered by the fatty and fibrous tissue of the heel. The middle, also rough, gives insertion to the tendo calcaneus and the plantaris, while the highest is smooth and is covered by a bursa, which intervenes between it and the tendo calcaneus. Articulations. The calcaneus articulates with two bones, the talus and cuboid. The talus, astragalus, ankle bone. The talus is the second largest of the tarsal bones. It occupies the middle and upper part of the tarsus, supporting the tibia above, resting upon the calcaneus below, articulating on either side with the malleoli, and in front with the navicular. It consists of a body, a neck, and a head. The body, corpus tali. The superior surface of the body presents, behind, a smooth trochlear surface, the trochlea, for articulation with the tibia. The trochlea is broader in front than behind, convex from before backward, slightly concave from side to side. In front it is continuous with the upper surface of the neck of the bone. The inferior surface presents two articular areas, the posterior and middle calcaneal surfaces, separated from one another by a deep groove, the sulcus tali. The groove runs obliquely forward and lateralward, becoming gradually broader and deeper in front. In the articulated foot, it lies above a similar groove upon the upper surface of the calcaneus, and forms with it a canal, sinus tarsi, filled up in the fresh state by the interosseous talocalcaneal ligament. The posterior calcaneal articular surface is large and of an oval or oblong form. It articulates with the corresponding facet on the upper surface of the calcaneus. Footnote: Sewell, Journal of Anatomy and Physiology, Volume 38, pointed out that in about 10% of bones a small triangular facet, continuous with the posterior calcaneal facet, is present at the junction of the lateral surface of the body with the posterior wall of the sulcus tali. End footnote. And is deeply concave in the direction of its long axis, which runs forward and lateralward at an angle of about 45 degrees with the median plane of the body. The middle calcaneal articular surface is small, oval in form and slightly convex. It articulates with the upper surface of the substentacuum tali of the calcaneus. The medial surface presents at its upper part a pear-shaped articular facet for the medial malleolus, continuous above with the trochlea. Below the articular surface is a rough depression for the attachment of the deep portion of the deltoid ligament of the ankle joint. The lateral surface carries a large triangular facet, concave from above downward, for articulation with the lateral malleolus. Its anterior half is continuous above with the trochlea, and in front of it is a rough depression for the attachment of the anterior talofibular ligament. Between the posterior half of the lateral border of the trochlea and the posterior part of the base of the fibular articular surface is a triangular facet, which comes into contact with the transverse inferior tibiofibular ligament during flexion of the ankle joint. Below the base of this facet is a groove which affords attachment to the posterior talofibular ligament. The posterior surface is narrow and transversed by a groove running obliquely downward and medialward, and transmitting the tendon of the flexor hallucis longus. Lateral to the groove is a prominent tubercle, the posterior process, to which the posterior talofibular ligament is attached. This process is sometimes separated from the rest of the talus, and is then known as the os trigonum. Medial to the groove is a second smaller tubercle. The neck, column tali. The neck is directed forward and medialward, and comprises the constricted portion of the bone between the body and the oval head. Its upper and medial surfaces are rough for the attachments of ligaments. Its lateral surface is concave and is continuous below with a deep groove for the interosseous talocalcaneal ligament. The head, caput tali. The head looks forward and medialward. Its anterior articular or navicular surface is large, oval, and convex. Its inferior surface has two facets, which are best seen in the fresh condition. The medial, situated in front of the middle calcaneal facet, is convex, triangular, or semi-oval in shape, and rests on the plantar calcaneo-navicular ligament. The lateral, named the anterior calcaneal articular surface, is somewhat flattened, and articulates with the facet on the upper surface of the anterior part of the calcaneus. Articulations. The talus articulates with four bones: tibia, fibula, calcaneus, and navicular. The cuboid bone, os cuboideum. The cuboid bone is placed on the lateral side of the foot, in front of the calcaneus, and behind the fourth and fifth metatarsal bones. It is of a pyramidal shape, its base being directed medialward. Surfaces. The dorsal surface, directed upward and lateralward, is rough, for the attachment of ligaments. The plantar surface presents in front a deep groove, the perineal sulcus, which runs obliquely forward and medialward. It lodges the tendon of the perineus longus, and is bounded behind by a prominent ridge, to which the long plantar ligament is attached. The ridge ends laterally in an eminence, the tuberosity, the surface of which presents an oval facet. On this facet glides sesamoid bone or cartilage frequently found in the tendon of the perineus longus. The surface of bone behind the groove is rough. For the attachment of the plantar calcaneocuboid ligament, a few fibers of the flexor hallucis brevis and a fasciculus from the tendon of the tibialis posterior. The lateral surface presents a deep notch formed by the commencement of the perineal sulcus. The posterior surface is smooth, triangular, and concavo-convex. For articulation with the anterior surface of the calcaneus, its infero-medial angle projects backward as a process which underlies and supports the anterior end of the calcaneus. The anterior surface, of smaller size, but also irregularly triangular, is divided by a vertical ridge into two facets. The medial, quadrilateral in form, articulates with the fourth metatarsal. The lateral, larger and more triangular, articulates with the fifth. The medial surface is broad, irregularly quadrilateral, and presents at its middle and upper part a smooth oval facet for articulation with the third cuneiform, and behind this occasionally a smaller facet for articulation with the navicular. It is rough in the rest of its extent for the attachment of strong interosseous ligaments. Articulations. The cuboid articulates with four bones: the calcaneus, third cuneiform, and fourth and fifth metatarsals, occasionally with a fifth, the navicular. The navicular bone, os naviculare pedis, scaphoid bone. The navicular bone is situated at the medial side of the tarsus, between the talus behind and the cuneiform bones in front. Surfaces. The anterior surface is convex from side to side and subdivided by two ridges into three facets, for articulation with the three cuneiform bones. The posterior surface is oval, concave, broader laterally than medially, and articulates with the rounded head of the talus. The dorsal surface is convex from side to side and rough for the attachment of ligaments. The plantar surface is irregular and also rough for the attachment of ligaments. The medial surface presents a rounded tuberosity, the lower part of which gives attachment to part of the tendon of the tibialis posterior. The lateral surface is rough and irregular for the attachment of ligaments, and occasionally presents a small facet for articulation with the cuboid bone. Articulations. The navicular articulates with four bones: the talus and three cuneiforms, occasionally with a fifth, the cuboid. The first cuneiform bone, os cuneiform primum, internal cuneiform. The first cuneiform bone is the largest of the three cuneiforms. It is situated at the medial side of the foot, between the navicular behind and the base of the first metatarsal in front. Surfaces. The medial surface is subcutaneous, broad and quadrilateral, and its anterior plantar angle is a smooth oval impression, into which part of the tendon of the tibialis anterior is inserted. In the rest of its extent it is rough for the attachment of ligaments. The lateral surface is concave, presenting along its superior and posterior borders a narrow L-shaped surface. The vertical limb and posterior part of the horizontal limb of which articulate with the second cuneiform, while the anterior part of the horizontal limb articulates with the second metatarsal bone. The rest of this surface is rough for the attachment of ligaments and part of the tendon of the peroneus longus. The anterior surface, kidney-shaped and much larger than the posterior, articulates with the first metatarsal bone. The posterior surface is triangular, concave, and articulates with the most medial and largest of the three facets of the anterior surface of the navicular. The plantar surface is rough and forms the base of the wedge. At its back part is a tuberosity for the insertion of part of the tendon of the tibialis posterior. It also gives insertion in front to part of the tendon of the tibialis anterior. The dorsal surface is the narrow end of the wedge, and is directed upward and lateralward. It is rough for the attachment of ligaments. Articulations. The first cuneiform articulates with four bones: the navicular, second cuneiform, and first and second metatarsals. The second cuneiform bone. Os cuneiforme secundum. Middle cuneiform. The second cuneiform bone is smallest of the three, is of very regular wedge-like form, the thin end being directed downward. It is situated between the other two cuneiforms, and articulates with the navicular behind, and the second metatarsal in front. Surfaces. The anterior surface, triangular in form, and narrower than the posterior, articulates with the base of the second metatarsal bone. The posterior surface, also triangular, articulates with the intermediate facet on the anterior surface of the navicular. The medial surface carries an L-shaped articular facet running along the superior and posterior borders for articulation with the first cuneiform, and is rough in the rest of its extent for the attachment of ligaments. The lateral surface presents posteriorly a smooth facet for articulation with the third cuneiform bone. The dorsal surface forms the base of the wedge. It is quadrilateral and rough for the attachment of ligaments. The plantar surface, sharp and tuberculated, is also rough for the attachment of ligaments, and for the insertion of a slip from the tendon of the tibialis posterior. Articulations. The second cuneiform articulates with four bones: the navicular, first and third cuneiforms, and second metatarsal. The third cuneiform bone. Os cuneiforme tertium. External cuneiform. The third cuneiform bone, intermediate in size between the two preceding, is wedge-shaped, the base being uppermost. It occupies the center of the front row of the tarsal bones, between the second cuneiform medially and cuboid laterally, the navicular behind, and the third metatarsal in front. Surfaces. The anterior surface, triangular in form, articulates with the third metatarsal bone. The posterior surface articulates with a lateral facet on the anterior surface of the navicular, and is rough below for the attachment of ligamentous fibers. The medial surface presents an anterior and posterior articular facet, separated by a rough depression. The anterior, sometimes divided, articulates with the lateral side of the base of the second metatarsal bone. The posterior skirts the posterior border, and articulates with the second cuneiform. The rough depression gives attachment to an interosseo ligament. The lateral surface also presents two articular facets, separated by a rough non-articular area, the anterior facet, situated at the superior angle of the bone, is small and semi-oval in shape, and articulates with the medial side of the base of the fourth metatarsal bone. The posterior and larger one is triangular or oval, and articulates with the cuboid. The rough, non-articular area serves for the attachment of the interosseous ligament. The three facets for articulation with the three metatarsal bones are continuous with one another. Those for articulation with the second cuneiform and navicular are also continuous, but that for articulation with the cuboid is usually separate. The dorsal surface is of an oblong form, its posterior-lateral angle being prolonged backward. The plantar surface is a rounded margin, and serves for the attachment of part of the tendon of the tibialis posterior, part of the flexor hallucis brevis, and ligaments. Articulations. The third cuneiform articulates with 6 bones, the navicular, the second cuneiform, cuboid, and second, third, and fourth metatarsals. End of section 49. Recording by Jennifer Stearns, Concord, New Hampshire.
Section 50 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Recorded by Laurie Anne Walden. Anatomy of the Human Body, Part 1, by Henry Gray. The metatarsus. The metatarsus consists of 5 bones which are numbered from the medial side, ossa metatarsalia, 1 through 5. Each presents for examination a body and 2 extremities. Common characteristics of the metatarsal bones. The body is prismoid in form, tapers gradually from the tarsal to the phalangeal extremity, and is curved longitudinally, so as to be concave below, slightly convex above. The base or posterior extremity is wedge-shaped, articulating proximally with the tarsal bones, and by its sides with the contiguous metatarsal bones. Its dorsal and plantar surfaces are rough for the attachments of ligaments. The head or anterior extremity presents a convex articular surface, oblong from above downward, and extending farther backward below than above. Its sides are flattened, and on each is a depression, surmounted by a tubercle, for ligamentous attachment. Its plantar surface is grooved antero-posteriorly for the passage of the flexor tendons, and marked on either side by an articular eminence continuous with the terminal articular surface. Characteristics of the individual metatarsal bones. The first metatarsal bone, os metatarsali 1, metatarsal bone of the great toe. The first metatarsal bone is remarkable for its great thickness, and is the shortest of the metatarsal bones. The body is strong and of well-marked prismoid form. The base presents, as a rule, no articular facets on its sides, but occasionally on the lateral side there is an oval facet by which it articulates with the second metatarsal. Its proximal articular surface is of large size and kidney-shaped. Its circumference is grooved for the tarso-metatarsal ligaments, and medially gives insertion to part of the tendon of the tibialis anterior. Its plantar angle presents a rough oval prominence for the insertion of the tendon of the peroneus longus. The head is large. On its plantar surface are 2 grooved facets on which glide sesamoid bones. The facets are separated by a smooth elevation. The second metatarsal bone, os metatarsali 2. The second metatarsal bone is the longest of the metatarsal bones, being prolonged backward into the recess formed by the 3 cuneiform bones. Its base is broad above, narrow and rough below. It presents 4 articular surfaces, one behind of a triangular form for articulation with the second cuneiform, one at the upper part of its medial surface for articulation with the first cuneiform, and 2 on its lateral surface, an upper and lower, separated by a rough non-articular interval. Each of these lateral articular surfaces is divided into 2 by a vertical ridge. The two anterior facets articulate with the third metatarsal. The two posterior, sometimes continuous, with the third cuneiform. A fifth facet is occasionally present for articulation with the first metatarsal. It is oval in shape, and is situated on the medial side of the body, near the base. The third metatarsal bone, os metatarsali 3. The third metatarsal bone articulates proximally, by means of a triangular smooth surface, with the third cuneiform, medially by two facets, with the second metatarsal, and laterally by a single facet, with the fourth metatarsal. This last facet is situated at the dorsal angle of the base. The fourth metatarsal bone, os metatarsali 4. The fourth metatarsal bone is smaller in size than the preceding. Its base presents an oblique quadrilateral surface for articulation with the cuboid, a smooth facet on the medial side, divided by a ridge into an anterior portion for articulation with the third metatarsal, and a posterior portion for articulation with the third cuneiform. On the lateral side, a single facet for articulation with the fifth metatarsal. The fifth metatarsal bone, os metatarsali 5. The fifth metatarsal bone is recognized by a rough eminence, the tuberosity, on the lateral side of its base. The base articulates behind by a triangular surface cut obliquely in a transverse direction, with the cuboid, and medially with the fourth metatarsal. On the medial part of its dorsal surface is inserted the tendon of the peroneus tertius, and on the dorsal surface of the tuberosity, that of the peroneus brevis. A strong band of the plantar aponeurosis connects the projecting part of the tuberosity with the lateral process of the tuberosity of the calcaneus. The plantar surface of the base is grooved for the tendon of the abductor digiti quinti, and gives origin to the flexor digiti quinti brevis. Articulations. The base of each metatarsal bone articulates with one or more of the tarsal bones, and the head with one of the first row of phalanges. The first metatarsal articulates with the first cuneiform, the second with all three cuneiforms, the third with the third cuneiform, the fourth with the third cuneiform and the cuboid, and the fifth with the cuboid. The phalanges of the foot, phalanges digitorum pedis. The phalanges of the foot correspond, in number and general arrangement, with those of the hand. There are 2 in the great toe, and 3 in each of the other toes. They differ from them, however, in their size, the bodies being much reduced in length, and, especially in the first row, laterally compressed. First row. The body of each is compressed from side to side, convex above, concave below. The base is concave, and the head presents a trochlear surface for articulation with the second phalanx. Second row. The phalanges of the second row are remarkably small and short, but rather broader than those of the first row. The ungual phalanges, in form, resemble those of the fingers, but they are smaller and are flattened from above downward. Each presents a broad base for articulation with the corresponding bone of the second row, and an expanded distal extremity for the support of the nail and end of the toe. Articulations. In the second, third, fourth, and fifth toes the phalanges of the first row articulate behind with the metatarsal bones, and in front with the second phalanges, which in their turn articulate with the first and third. The ungual phalanges articulate with the second. Ossification of the bones of the foot. The tarsal bones are each ossified from a single center, excepting the calcaneus, which has an epiphysis for its posterior extremity. The centers make their appearance in the following order: calcaneus at the 6th month of fetal life, talus about the 7th month, cuboid at the 9th month, third cuneiform during the 1st year, first cuneiform in the 3rd year, second cuneiform and navicular in the 4th year. The epiphysis for the posterior extremity of the calcaneus appears at the 10th year, and unites with the rest of the bone soon after puberty. The posterior process of the talus is sometimes ossified from a separate center, and may remain distinct from the main mass of the bone, when it is named the os trigonum. The metatarsal bones are each ossified from 2 centers, one for the body and one for the head of the second, third, fourth, and fifth metatarsals, one for the body and one for the base of the first metatarsal. Footnote: as was noted in the first metacarpal, so in the first metatarsal there is often a second epiphysis for its head. End footnote. Ossification commences in the center of the body about the 9th week, and extends toward either extremity. The center for the base of the first metatarsal appears about the 3rd year; the centers for the heads of the other bones between the 5th and 8th years; they join the bodies between the 18th and 20th years. The phalanges are each ossified from 2 centers, one for the body and one for the base. The center for the body appears about the 10th week, that for the base between the 4th and 10th years; it joins the body about the 18th year. End of section 50. Section 51 of Gray's Anatomy, Part 1. This is a Librivox recording. All Librivox recordings are in the public domain. For more information or to volunteer, please visit librivox.org. Recorded by Laurie Anne Walden. Anatomy of the Human Body, Part 1, by Henry Gray. Section 51. Comparison of the bones of the hand and foot. The hand and foot are constructed on somewhat similar principles, each consisting of a proximal part, the carpus or the tarsus, a middle portion, the metacarpus or the metatarsus, and a terminal portion, the phalanges. The proximal part consists of a series of more or less cubical bones, which allow a slight amount of gliding on one another, and are chiefly concerned in distributing forces transmitted to or from the bones of the arm or leg. The middle part is made up of slightly movable long bones, which assist the carpus or tarsus in distributing forces and also give greater breadth for the reception of such forces. The separation of the individual bones from one another allows of the attachments of the interossei and protects the dorsipalmar and dorsiplantar vascular anastomoses. The terminal portion is the most movable, and its separate elements enjoy a varied range of movements, the chief of which are flexion and extension. The function of the hand and foot are, however, very different, and the general similarity between them is greatly modified to meet these requirements. Thus the foot forms a firm basis of support for the body in the erect posture, and is therefore more solidly built up, and its component parts are less movable on each other than those of the hand. In the case of the phalanges the difference is readily noticeable. Those of the foot are smaller, and their movements are more limited than those of the hand. Very much more marked is the difference between the metacarpal bone of the thumb and the metatarsal bone of the great toe. The metacarpal bone of the thumb is constructed to permit of great mobility, is directed at an acute angle from that of the index finger, and is capable of a considerable range of movements at its articulation with the carpus. The metatarsal bone of the great toe assists in supporting the weight of the body, is constructed with great solidity, lies parallel with the other metatarsals, and has a very limited degree of mobility. The carpus is small in proportion to the rest of the hand, is placed in a line with the forearm, and forms a transverse arch, the concavity of which constitutes a bed for the flexor tendons and the palmar vessels and nerves. The tarsus forms a considerable part of the foot, and is placed at right angles to the leg, a position which is almost peculiar to man, and has relation to his erect posture. In order to allow of their supporting the weight of the body with the least expenditure of material, the tarsus and a part of the metatarsus are constructed in a series of arches, the disposition of which will be considered after the articulations of the foot have been described. The sesamoid bones, ossa sesamoidea. Sesamoid bones are small, more or less rounded masses embedded in certain tendons, and usually related to joint surfaces. Their functions probably are to modify pressure, to diminish friction, and occasionally to alter the direction of a muscle pull. That they are not developed to meet certain physical requirements in the adult is evidenced by the fact that they are present as cartilaginous nodules in the fetus, and in greater numbers than in the adult. They must be regarded, according to Thelenius, as integral parts of the skeleton phylogenetically inherited. Physical necessities probably come into play in selecting and in regulating the degree of development of the original cartilaginous nodules. Nevertheless, irregular nodules of bone may appear as the result of intermittent pressure in certain regions, for example, the rider's bone, which is occasionally developed in the adductor muscles of the thigh. Sesamoid bones are invested by the fibrous tissue of the tendons, except on the surfaces in contact with the parts over which they glide, where they present smooth articular facets. In the upper extremity the sesamoid bones of the joints are found only on the palmar surface of the hand. Two, of which the medial is the larger, are constant at the metacarpophalangeal joint of the thumb. One is frequently present in the corresponding joint of the little finger, and one or two in the same joint of the index finger. Sesamoid bones are also found occasionally at the metacarpophalangeal joints of the middle and ring fingers, at the interphalangeal joint of the thumb, and at the distal interphalangeal joint of the index finger. In the lower extremity, the largest sesamoid bone of the joints is the patella, developed in the tendon of the quadriceps femoris. On the plantar aspect of the foot, two, of which the medial is the larger, are always present at the metatarsophalangeal joint of the great toe, one sometimes at the metatarsophalangeal joints of the second and fifth toes, one occasionally at the corresponding joint of the third and fourth toes, and one at the interphalangeal joint of the great toe. Sesamoid bones apart from joints are seldom found in the tendons of the upper limb. One is sometimes seen in the tendon of the biceps brachii opposite the radial tuberosity. They are, however, present in several of the tendons of the lower limb, for example, one in the tendon of the peroneus longus, where it glides on the cuboid, one appearing late in life in the tendon of the tibialis anterior, opposite the smooth facet of the first cuneiform bone, one in the tendon of the tibialis posterior, opposite the medial side of the head of the talus, one in the lateral head of the gastrocnemius, behind the lateral condyle of the femur, and one in the tendon of the psoas major, where it glides over the pubis. Sesamoid bones are found occasionally in the tendon of the gluteus maximus, as it passes over the greater trochanter, and in the tendons which wind around the medial and lateral malleoli. End of section 51. End of Anatomy of the Human Body, Part 1, by Henry Gray.